He has been president of Society of Clinical Risk Management, Italy. Professor Quirono, we can play the first talk.
Okay, good morning from Italy. Here is very early in the morning, it's 5 o'clock more or less, so I'll try to do my best. I would like, first of all, to thank Yash for this invitation and all the organized committee. And I would like to start immediately because my job is to open this important session. I try to do just a second. About SARS-CoV-2 pandemic on sepsis management. And we know that the novel coronavirus disease pandemic caused by the severe acute respiratory syndrome coronavirus 2, SARS-CoV-2, has placed an unprecedented strain on healthcare. Concern is the novel coronavirus SARS-CoV antimicrobial early low rates of bacterial and fungal infection in hospitalized, but empirical microbial with different from infection significant and evidence make and COVID is necessary antimicrobial prescribed in patient and you potentially of drug is a life to a response to infection. The globe around sun 20 and no term 2019 COVID-19 caused respiratory syndrome virus 2, SARS-CoV-2, emerged and as a result in more than 1,500,000 more deaths globally. These two conditions share many pathophysiological and clinical features, notably both sepsis patients consumptive hemolytic anemia, vascular septic shock, respiratory fever, leukopenia, hypotension, leukocytosis, eyesight, and eye predispositionistic infection. Considering the parallels in the immunopathogenesis and manifestation of COVID-19, it is a high sepsis, well-established system could inform on COVID-19 management. In present, the immunopathogenesis and COVID-19 and non-sepsis from sepsis applicable to clinical microbiology infection. The colleague period of co-infection and superinfection in hospitalized patients with COVID-19. They say that the fungal co-infection was in 7,000 patients, more or less, and the percentage was very low, 0.7. 3 patients were diagnosed with Aspergillus fumigatus, albicans, bloodstream, and intra-abdominal infection 1. Based on prior pandemic, concern were initially raised regarding rates of bacterial and fungal associationality. In COVID-19, no evidence has emerged to support increased effect. Whilst documented hospital-acquired infection in COVID-19 cases has been higher, this appears to be associated care to be common nosocomial infection rather than directly attributable to COVID-19. And epidemics such as SARS-1 and Middle Eastern respiratory syndrome, little evidence of a bacterial and fungal infection has been. The importance of good hand hygiene, aseptic technique, surveillance of and the isolation must be promoted. This is the key intervention in reducing the impact of COVID-19 on antimicrobial resistance must be carefully considered. Concern regarding increased overcrowding of hospitals in opportunities to isolate patients with multi-resistant organisms may have a negative impact on AMR. Must be balanced against increased social distancing, a renewed focus on apparent reduction in community antimicrobial use that may have a positive impact on AMR. The COVID-19 stood. It is plausible that immune dysregulation and the lung damage stemming from COVID-19 superinfection in a way that is at least partially distinct from other respiratory viruses. From one, if you invasive fungal infection may occur in between from 4 to 5% of COVID-19 episodes. Even that in one, galotmenan testing is rarely available and the fungal diagnostics are sparse. This is likely in patients with COVID-19 requiring ICU admission. Recent reports from Europe indicated that IPA for COVID-19 patients to admission. Initial study, we know that demonstrated that COVID-19 severity with inflammatory cytokines. including interleukin-6, interleukin-1 beta, as well as interleukin-2, interleukin-8, interleukin-6 factor, granule colony stimulating factor, human interferon, inducible protein 10, and the tumor necrosis factor. So it's a very from an immuno these patients. It was suggested that these elevated levels of pro-inflammatory cytokines may result in shock and tissue damage, leading to multiple organ failure. And we have a relief also pulmonary pathology, resulting in enormous infiltration of neutrophils and macrophages, diffuse alveolar damage with the development of hyaline membranes and thickening of the alveolar wall. Lymph node observed the suggestive damage. Pro-inflammatory response, lymphocyte activity and production, and complement coagulation activation and cellular protection. I want to underline, however, that despite the repertoire, pathogens can persist in the blood with the immune system, leading to sepsis. Sepsis by pro-anti-inflammatory response. The intense production of a pro-inflammatory can result in cytokine storm, which deregulates the immune response and activates pathological inflammatory disorder. The dysregulated immune response and the production of nitroxide associated with sepsis may progress to vascular endothelial injury and the circulatory organ dysfunction associated with significant hemopathologic changes. The overproduction of nitroxide is a very important factor from a vascular point of view and from sepsis, and is not still well known. Also leads to persistent vasodilation, which affects organs, contributing in a very important way to hypotension and hypoxia. Barely 3 months into the COVID-19 pandemic, an arm of guidelines were used for or against the management of critically ill adult COVID-19 patients. Previously, WHO had used the guideline on how to manage sepsis menage, although it still remains a health challenge. Here, leveraging the striking similarities between severe COVID-19 and sepsis, we provide some suggestions on how to manage the 3 major complications. This is something new for sepsis. The first one is a hyperinflammatory response. The second one is immunosuppression, and the last one is a hypovolemia in COVID-19 patients based on lessons from sepsis. The elevated levels of pro-inflammatory cytokine observed in severe COVID-19 cases suggest that keeping the immune system from making such exacerbated response may improve. Hence, recommendation from management of severe inflammatory response syndrome in sepsis may benefit severe COVID-19 patients. In sepsis and septic shock, downregulating response is a recommended adjunctive therapy for which corticosteroids are used. The last slide. I want to underline that the gravity of COVID-19 pandemic requires a variety of solutions. As vaccine development continues, adapting existing treatment regimens from disease with similar pathogenic pathways could help improve treatment outcomes and lower the mortality associated with SARS-CoV-2 infection. Here we have discussed the parallels between COVID-19 and sepsis, focusing on the similarity with regards to immunopathogenesis and pathophysiology, and offer suggestions on how sepsis condition might inform on management of three major complications in sepsis pathophysiology are warranted to help deal with COVID-19. On the flip side, considering the enormous COVID-19 sepsis management, which is still a major global health burden, may also benefit for COVID-19. The survivor sepsis conclusion panel of which regarding treatment, now recommendation are weak. Find no recommendation for 6 questions. The topic were infection control, laboratory diagnosis, the COVID-19 therapy. The Surviving Sepsis Campaign COVID-19 panel used several support caring from critically ill ICU patients with COVID-19. This guideline provides a recommendation to support management also with COVID-19 in intensive care unit. The target users of this guideline are frontline clinicians, allied health workers with COVID. The guideline applies to both high and low middle income settings. Thank you for listening to with a big discussion through all the day in this important topic. Thank you.
Thank you so much, Professor Curino, sir. It was a very the impact management. I know it's 5 o'clock in Italy and you're having a very, very early sunrise session, but thank you so much. For those who, for welcoming again, for all those who are having organized by the Indian Sepsis Forum, myself, Dr. Choube Arora, and we have our first session going on. The second talk will be on droplets, aerosols, N95 era, which is being presented by Dr. Sumesh Arora, who is an intensive care specialist joining us live from Australia, and he's also the convener of Go the Extra Mile. So handing over.
Hello.
Yes, sir. You're audible, sir.
Thank you very much, Dr. Arora, and thank you for having My greetings to Dr. Pradeep Rangappa, Dr. Suryakant, and Dr. But my first job in intensive care was as his registrar at Sir Gangaram Hospital many years ago.
Yes.
I remember you.
Many years.
Gangaram was like Makkah of critical care.
Yeah.
Nothing like Makkah of critical care.
Okay, so I will share my screen now. Hello again. I'm Sumesh Arora from Prince of Wales Hospital in Randwick in Sydney. Respirators and peppers. A conflict of interest to declare. I work as the director of Quiz Time in Critical Care, which runs a website called gotheextramile.com. Salary or payment from Quiz Time. Quiz Time has thus far donated all its profits to charity. So, never paid much attention to. When I think of droplets, I want to know what droplets are or their variants like droplet nuclei. Where are they produced? How far do they travel? And are they infectious? I would like to go through these questions one by one in the upcoming slides. Droplets are all documents that I came across led me to a single source, which was a WHO pandemic preparation guide. For the purpose of this document, we define droplet as something which is an expired breathing particle, which is larger than 5 micron in size, and the two were combined in the umbrella aerosol. It has been known for quite some time that the droplets come and the larger droplet, and at the same time a virus which is coming out in the secretions is not smaller, will hitch a ride on whatever it can take. Unfortunately, this distinction between less than 5 and more than precaution fusion across the world. And the reader should know, or the audience should know, that currently there is no one standard definition to say larger than this. Expired breath particles come in all sizes. The particles are produced everywhere along the respiratory tract. When we talk, the fluid lining the vocal cord aerosolized. Generally, it results in formation of larger particles. The alveoli predominantly. The origin of these particles is a matter of conjecture. It is thought that during inspiration, the terminal bronchioles, which may have collapsed, would snap open and result in aerosolization of the respiratory tract lining fluid. This fluid is then into the out during the expiration. We think this is how they may be produced because the number of particles coming out increases for a person breathing. Other way where the fluid is coming from, if we subject the expired breath particles to chemical analysis, salt content are expected to be from salivary origin, whereas those which contain more of surfactant protein or other proteins lining the respiratory tract may come from And as a result, we know that most of the really small particles, they come from alveoli. If we subject the expired breath particles droplets to chemical analysis, once again, the ones with higher amylase content or higher salt change depending on my pattern of breathing. If I start breathing fast, I may produce too many particles. If I have inflammation in my nose or my larynx or my lungs, the number of particles similarly will change. This is around a 20-year-old study which looked at number of particles over 10 breaths. Found distributed along a distribution curve with smaller particles more numerous than larger. The particles of this size and even smaller particles may be, to some extent, counting them may have been limited by the sensitivity equipment used. Same study looked at the distribution during different maneuvers. On the vertical axis, we have the number of droplets, whereas on the horizontal axis, we have the droplet diameter. And in different airway maneuvers, it comes as talking the number of particles, they go up. And during a sneeze, the number of particles is even higher and they travel even farther. The number of particles will vary from study sensitivity conditions of the experiment, and if for a small number of volunteers, they may also change because one volunteer may produce different number of droplets than okay. A lot of literature says that droplets settle within 2 meters and therefore beyond 2 meters if a bacteria or virus is safe. And I think we should be better informed than that. And we know that the droplets, they continuum. Okay? So larger droplets, they have a tendency to fall closer, medium-sized droplet a bit farther, and much smaller droplet go even farther. However, travel by how fast they're coming out. So a sneeze droplet travels farther. How big they are, obviously, whether the person, keeping their hand in front of their face, and the velocity of the ambient air. So if we are, let us say, outdoors and there is breeze at 5 meters per second, a droplet which is likely to stay suspended for 2 seconds may have traveled 10 meters before it settles on the ground. So similarly, presence of fans, presence of air conditioning, flow of air conditioner is where everything will affect different droplets in different ways. But do we know that if the surgical mask worn by the source, and this is some confident that it does. For those interested in the literature on droplets and aerosols, would benefit a lot by reading the work of Dabuk and Drikakis. These guys from extensive their literatures physics of fluids. And if I knew maths any better, I would have been even more fascinated by reading about them. The droplet spread is significantly curtailed by presence of a surgical mask at a distance of around 70 centimeters. And they kinds of masks with different degree of leak. Now, once a droplet has escaped from the source, does it change over a period of time? And of course, it does. A droplet is a proteins from the respiratory tract. This is obviously surfactant, amylase, salt, and so forth. Once it has come out, it is evaporate. The rate of evaporation would depend on the relative humidity and the temperature. And in hot climate and low relative humidity, it will dry residue. Two things are very important that need to be considered. Number one, now that it is smaller in size significantly compared to original size, it may period of time and may travel farther. Dehydrated drop environment on which the vitality of the bacterial cell envelope. To put in perspective, SARS-CoV-2 is an enveloped virus and may survive much better in wet conditions than in desiccated conditions of a droplet nuclei. Remain viable then? Well, evolve because determining replication is very difficult. Not every lab. A correspondence published in New England Journal of Medicine approximately 5 months ago or so found that the half-life of replication-competent virus in the droplet may be around an hour, around 5. And we now know that there is replication-competent virus can be isolated from room air from rooms occupied by COVID-19 patients or is stay suspended in air for much longer is progressively increasing, and precautions that we can to keep ourselves safe, which means holding meetings, meeting people, keeping our social distancing. My mask protects me. And for healthcare, the burden of the virus may be high, or there are a lot of respirators, which is the subject of my next section. And once again, when we look at N95, we want to know what is N, what is 95, what are the types, the fit, and so forth. Let's go through some of these things one by one. So N refers to testing when there is no oil in the air. 95 means which will of the mass, 5% of the particles greater than 0.3 micron. Of course, this in real life will and to put it in perspective, SARS-CoV-2 is approximately 0.1 micron across. But we should remember that SARS-CoV-2 doesn't fly solo. It is kept. It is with it and proteins and so forth. And N95 capturing 95 particles more than 0.3 micron doesn't mean that it won't capture any particles smaller. There's a lot, 95%. N95 is not a universal terminology. Other countries have their own standards, like N95 is by the OSHA in the United States. Chinese masks have KN95, which are equivalent, FFP2 in the Europe, P2 in Australia, and so forth. Some of the common masks are 3-panel flat in the shortest supply, with a panel which covers over the nose in front of the face and a panel behind it or on the chin, has a moldable strip here and side labial folds. And if this strip is made of metal, the mask is not N95 compatible. Actually, I should use the term respirator. The correct terminology than a mask. They have fixed right to left and top to bottom dimension. and relies on a person's face actually occupying the space in it, and all around. Particularly thin people fit this mask. Mouth to talk, change the top geometry of the face and dimension, and as a result, talking, smiling may alter the fitness of this mask. In general, when wearing the N95 respirators, we should try and talk to the minimum and avoid rapid movements of the head, or doing things like chewing a gum. The duckbill are other common. They do not bottom in people who are talking. Yeah. We can test whether the respirator fits well or not by the manufacturer recommended users. Hand on the bottom and feel for a leak. And multiple studies have looked at it and found that the user seal check is neither a sensitive nor a specific deter leak in a respirator. Other ways are doing a quantitative fit test, like the equipment shown here, which is what we use in our institute. It's called port account, though a different version. The respirator has been modified for a sampling port. Air from inside the respirator is sampled, and in the blue line from the atmosphere from here, and the machine will count the particles. Ratio of particles outside divided by inside would give what is known as a proverbial fit factor, and it is assumed that if the fit factor obtained then one we use this equipment for two studies to answer two questions, which I show in the subsequent slides. One of our whether the presence of fogging of the eyeglasses may be used as a point of care test to say no leak. So point of the fogging was used as a novel or a quantitative and a sensitive ROC was created. It was a good ROC curve, green line, which is a perfect, and of a coin, it line the chance diagonal closer to rather than a good test. And indeed, we concluded that fogging doesn't leak. Fogging and there may and vice versa. Fogging present, there's no leak. Fogging not present, there is still a leak. So we test, but to be the same group fitness of a fitting of proved label for that a respirator can improve the contact between the respirator and the face by using with an elastic of the goggles. Here we might just increase the fitting, and indeed in our pilot study of 60 cases, all volunteers, 25 respirators, and found that our fit factor increased from 69 to 169, which was highly from 20%. The result should be this first study, one type of demographics and BMI and so forth. So results need to be applied in a larger group for it to be considered a useful technique. Finally, a word on peppers or pressurized air purifier. Of 3M Versaflow that we use in our department. No different. There is a pump in air and air. The filter is a FFP3 filter. It goes through the breathing tube into the helmet. There is a wide and the air to 105 liters per minute. Just the air delivered through the pepper rather than any atmospheric air. Pepper is the N95. Sorry, not the N95. The neck and full 19 patient to be of great, fairly comfortable of 4 or 5 or even longer of COVID patient. I have to say thank you. I is at the end.
So it was really for this 5 was very, thank you so much. Moving, session of presented by the Indian on AI in Sepsis, presented by who is in and Research Associate, University of Utah, Medical Center live. So can I please welcome Dr. for the third for this morning.
Good morning. Dr. Arora, I had a recording.
Kajal?
Sure, sir. Thank you.
My name is Sandal Nachimatu. I'm about artificial intelligence and has been where I work as an adjunct assistant professor of biomedical research assistant. I also work as a senior, and there are no conflicts of interest. The way I'm going to page, the address is on the last slide. For today's talk is various AI of your patients with sepsis or COVID-19. Tools that patients for some frustration. Start with some intelligence deals with making computers learn from data, such as without each case. The algorithms and computational method. The applications of artificial descriptive analytics. So descriptive analytics, predictive analytics, and it's just descriptive analytics. So the examples that I've given from our own work: prediction or early detection of sepsis in the emergency, artificial intelligence. And the applications of artificial intelligence are often insulin dose and glucose control, descriptive, predictive, prescriptive analytics. Prescriptive analytics the current condition, say, of a patient. Predictive analytics detect a role more, it's like that. Detecting sepsis in the emergency department. Dose and insulin dose and glucose control, or which is our work, former work in prescriptive analytics, and our current work involved. So to talk about these models, I want you to models, because that is very important when you start to you. So I would broadly classify machine learning techniques used in medicine into pattern recognition models and causal models. Those include neural networks, deep learning, support vector machines, and so on, where they take a lot of data, run through a complex algorithm, and then the model outputs the different patterns that it finds in the data. They're called really can reason for it can't explain it in terms of medical evidence, for instance. Causal models such as models, hidden Markov models, and so on, they take the structure of model from medical literature or from the knowledge of clinicians or something we discover from data and then validate it and then provide the inference. So because of that nature, they are able to explain the reason for any of the outputs. So here's an example diagram of a neural network. Mimics a human neurological network. So there are various input nodes and then processing, and then various outputs. Deep learning is nothing but output. Suitable where we don't need the model to explain the going to test image detection, as well as population health, where we are not looking for evidence, diagnosis, or treatment. However, a lot of work is being done in the past 3 years or so to improve the explainability. So that is that's a rapidly emerging area of research. When it comes to probabilistic models, here's smoking can cause lung cancer or bronchitis. And then they can both lead to abnormal chest X-ray findings or dyspnea. There are probabilities associated with them. And then when a node is dependent on multiple other nodes, then we end up with what we call explaining such as diagnostic or therapeutic and clinical. Testing the hypotheses discovered by pattern recognition models. So we don't have to use black box models and these kind of causal models by themselves too. But there is a common Achilles heel for both these types of models. Medicine, by definition, involves incomplete data and reasoning under and measure knows how to treat a patient. We don't know about a patient. However, many of the models expect a fairly complete data set. If the data are missing, so if you don't have a well-defined and a well-populated data set, some of these models fail. And also these models can detect correlation. They don't have the notion of causality to the models. Question to ask when you look at these models. However, clinical decision support does not always require complex AI methods. Sometimes simple rule-based systems are very useful as well. For example, SOFA, QSOFA news criteria. There can also be easy rule-based models for drug-drug interaction checking, so we don't give two drugs that have harmful interactions to a patient. We can also have drug allergy interaction checking, so describing that the patient might be allergic to. For example, some of you might have come across patients with computer prevented me from prescribing a drug that is available today if you want to. It can be proven systems or just a special case of probabilistic models where the probabilities are either 0 or 1 instead of they're very useful for human use at the bedside without a computer. Models than these or rule-based models. So here's the search criteria, which is a measured model. We trained it on the data from the emergency department of Intermountain Healthcare in Salt Lake City. And then we ran the model with data of the first admission and 5 hours post-admission. And we found that was to 0.94 at 23 hours. So, looking at the chart on the right-hand side, we see that the sensitivity model is the same and the area under the curve. So what this tells us is that with more data, we can diagnose more patients with sepsis. There's one limitation of our model, though. We enriched the data set with a prevalence of 20% sepsis instead of the real-world emergency department sepsis prevalence of 2%. So that is something that that we want to address in our future work. So I want to point you to a recent meta-analysis, which is very helpful to compare these models. So Florin and others compared 130 models from 28 different papers for sepsis detection. And they say the area under the curve ranges from 0.68, which is somewhat better than a coin toss, to 0.98, which is extremely good. But they say that only 3 papers implemented their models in a clinical care setting. And when you look at the chart on the right-hand side, they show that the area under the curve of these models are much higher when the patient has sepsis compared to, say, 12 hours before the onset of sepsis. So now, we can ask a very good question here. So, this denotes that the models are more accurate when the patient is closer to developing sepsis. So we can study the correctness of these models, but what about the usefulness of these models? Diagnosed sepsis and then the patient. When the model gives us an early warning, and then we can treat the patient with antibiotics to prevent the onset of sepsis or septic shock, that's a lot more useful than telling the doctor what they already know. So that is, a lot. There's a lot we can learn and discuss about models that have been published and peer reviewed. But there are also a lot of models that are commercially available, that are proprietary, and we don't have a way to look into those models. They are not externally validated or peer reviewed. So how can we even understand how correct and how useful those models are? So how does a clinician decide which AI model to use and how to interpret the statistical results when they are available? So before we take a look at that, let's talk about COVID-19 models. There are more than 100 different COVID detection models that have been built in the last 2 years, But a recent MIT Technology Review article says none of them have been useful for, improving the outcomes of patients. So the question I would pose is, do clinicians really need an AI to detect a pandemic that has an extremely high prevalence? I would also pose other questions about where they might be useful. I came across the case of a patient, I read about a patient with dengue who was misdiagnosed as having COVID-19. And then the patient was treated with heparin for COVID-19. Subsequently, the patient had hemorrhagic complications from dengue as well as heparin. So if the AI could tell that patient has dengue, not COVID, that would be helpful, rather than, if the model could tell whether the patient has sepsis or not, because everybody's thinking about COVID, and, chances are we won't miss COVID. Let's extend that thought experiment a bit. Let's say if you have a population level spatiotemporal epidemiological model that helps to detect the outbreaks, predict the future pattern of the outbreaks, and it helps us to manage hospital logistics, supply chain, as well as public health intervention, social distancing, or vaccination allocations. I think that'll be extremely helpful for public health. Perhaps we can have telemonitoring models that use where the AI can detect abnormal patterns and alert the patient or the doctor. Perhaps we can have sepsis early detection models, other complications of sepsis. And then perhaps we can have ventilator management and that can help us at the bedside. Perhaps we can have AI that identifies COVID-19 variants and helps us to pick samples for genotyping, so we know the patterns earlier about what variants are emerging and various attributes of those variants. Perhaps we can have a hypothesis generation model that helps us with what causes mucormycosis in COVID-19 patients. All of these requires a national digital health infrastructure. I came across the National Digital Health Mission that the government of India is working on. So if there are any policymakers in the audience, or if any of you know policymakers, please talk to them. The more they hear, the more they can prioritize and make this happen. So how do we, distinguish hype from reality? This diagram is the Gartner hype cycle. There's too much hype and unreasonable expectations about it. And soon people get disillusioned. And then over a period of time, people understand the realistic expectations of what's possible and then use it effectively. When it comes to AI, in 2017, deep learning and machine learning were at the peak of this hype cycle. And then last year, there's more and more disillusionment. So I think we'll hit a trough and then we'll start having realistic expectations. And I see this emerging already. So a few months ago, there was a JAMA Internal Medicine editorial, which went along with a paper that was published on the same issue by researchers from the University of Michigan that studied the sepsis detection model from EPIC, which is the most popular electronic health record system in the US, and said that EPIC's model was not as good as they claimed to be. So this editorial called for external validation rather than somebody just trying to sell a model without peer review. Attention paid towards the need for regulation, such as FDA or whatever regulatory agency you have in your country, which talks about more and more need for regulation of these models because currently these models are not regulated. There's also a lot of talk about bias in AI models. A common example we see is a model that is trained on a predominantly white population doesn't work accurately when applied to a Black patient. That may be the case when a model that was trained in North America or Western Europe, where the demographics are different, as well as the healthcare environment is different, and then you try to apply it, say in an environment in India where the patient's demographics as well as the healthcare environment may be different, then the model needs to be validated in the target population before it's used. There's also a lot of attention being paid to these days about the explainability of black box models, because people rightfully reject black box models when it comes to evidence-based medicine. So let me compile a top 10 list of what clinicians need to watch out for while using AI models in medicine. First, they need to be helpful. So they need to be both correct and timely. They can't just tell me things that I already know, then that's not really useful. What about legal responsibility? Right now, they are not regulated because the decision maker, namely you, are in the loop between the model and the patient. So you are responsible for the decision, not the model, not the AI. So that's something you need to keep in mind until the regulatory landscape changes in different countries where these models are used. The third aspect is explainability, we talked about. The fourth is workflow. The tool has to fit within the clinical workflow, especially when you're seeing 100 COVID patients a day. You can't change your clinical workflow around the model. The model has to fit within your clinical workflow. We talked about, and then we need to watch out for hypothesis generation models that may be promoted as validated models. Be very clear about that. The models need to follow the scientific method. They cannot hide under the term of data science, where they talk more about the data rather than the science. The models need to be peer-reviewed, and they need to be control-for biased. We need to have a good understanding of statistics, at least about the positive predictive value to avoid false alerts, which causes alert fatigue. And then we need to know about negative predictive value so that we don't miss patients who might have a condition that we are looking for. Safety and transparency. You need to be able to publish about safety issues. There should be no gag clauses around it. Imagine Boeing 737 MAX had a gag clause around studying the safety issues. You don't want that in medicine. So that brings up to the end of this high-level overview of AI around sepsis and COVID-19. If you have any questions, please reach out to me. My email address, as well as other communication information, is here, and I'll be delighted to answer questions. Thanks for your attention, and thank you to the organizers.
Thank you so much, Dr. Senthil. It was really nice to know about AI in COVID and sepsis both. Can we have the Q&A session, and can I please request the chairpersons?
Yeah, my sincere thanks to all the speakers. You have such a nice. My question is from Dr. Somesh, because at the time of trying to face this problem with N95 respirator, and particularly the papers, how we are going to clean and sterilize the papers, particularly the external part of the papers.
Sorry, how are we going to sterilize, is it?
Yes,
Clean?
yes.
Yeah, so in our institute, we use thermal sterilization. So in terms of the number of parts that a paper has, we have the helmet-like thing. We have a breathing tube which connects the helmet to the turbo unit. Then we have the turbo unit or the reverse vacuum cleaner itself, and then a battery of the vacuum cleaner. Now, when we come out of the COVID unit, we have a buddy who helps us doff. And during the time we spend inside the unit, the turbo unit and battery is actually always concealed under a gown. So we make an assumption that those two things are not contaminated. When we come out of the doffing area, we remove the helmet and the breathing tube which is connected to it. They come off and go inside a box, which is the original paper box. And the two things together go for... the two things together... the two things together, they go for thermal sterilization. And the battery and the turbo unit itself, we clean it with a chlorhex and alcohol wipe. Because everybody cleans their own turbo unit and battery. So the next time I go in, I may get a turbo unit cleaned by you. And when you go in, you may get a turbo unit cleaned by me. So we try and have due diligence in cleaning it as if you yourself are going to wear it the next time. And then the helmet and the breathing tube, once they come back from sterilization, they have two parts which need to be assembled together. One of them is a like a foam cushion to protect the forehead, and another the visor which covers the chin and the neck. It takes around 5 minutes. Cushion through almost 80 to. We have a group of dedicated, mostly doctors who come in their own time, and we have set up a rotating roster and we assemble those papers every day, which is a work, but that workload is shared by whoever is free in the unit at that. The turbo unit, thorax, and the breathing tube and the helmet through by thermal disinfection.
Thank you.
Thank you so much. Can I please have the final word from the chair on the sunrise session, and then we move ahead to the next one?
Okay. So, Dr. Charu, thank you very much for moderating wonderfully. You have, of course, taken over the charges of all chairpersons and all UC organizers. So, you are representing the most active moderator. Thank you very much. And I think we have observed the wonderful session. 3 lectures. Early lecture, usually now I can understand why you have kept the name Sunrise, because in Italy it was 5 o'clock, and of course Dr. Curino was talking at 5 o'clock from his country. Italy is one of the worstly affected country in the Europe for the COVID-19, and of course as India, of course during second wave. So I think he has presented a wonderful lecture on what is the sepsis, what are the complications of sepsis, and what are the preventive measures for the sepsis. I think beautifully he has managed. The second lecture also wonderful. You see, basically it was the anatomy and of course of mechanism behind it, and how the mask they can of course prevent these transmission of these droplets. So it was very practical if you are really dealing in sepsis and you want the prevention. And third lecture was, of course, basically the person like me, they are not updated in this field, that is artificial intelligence. So it is a new subject for me. You are the younger people, Dr. Yash, and of course, everybody. But I think to update and upgrade yourself, this is the basic requirement of our medical profession. And everybody has to be updated. And during COVID times, a lot of things have come in artificial intelligence. And of course, we could understand a little bit. And of course, personally, I'm expressing that I could understand a little bit and I have to understand more. So I think Yash will organize some more conferences and then we will learn more about artificial intelligence. So thank you, Yash, and thank you, whole team Regency Hospital. First time, I think I'm experiencing that corporate hospital Regency, which was very much popular in the Kanpur, 4-5 branches in Kanpur. Now, of course, doing very well in the Lucknow also, in the city of, in the capital city. So, of course, the congratulations to whole team Regency, especially Dr. Yash. Thank you very much. Thank you.
Thank you so much, Dr. Suryakant sir. It was really nice, and thank you for the encouraging words. So, for all those who have just attended and just joined us on the occasion of the World Sepsis Day, we are presenting Global Sepsis Experts Meeting organized by Indian Sepsis Forum, partner organizations, Indian Resuscitation Council, American Society of Microbiologists, and Global Sepsis Alliance. We are streaming live on Facebook, YouTube, and Anesthesia TV. Welcoming all faculty. Also, Dr. Yash sir, you were saying something.
Fine. And then we move on to the next.
Thank Dr. Pradeep Rangappa sir.
Yeah. Charu. So it was a great session. So World Sepsis Day, which was conceptualized by Yash. So hello to my good friend Sumesh. So excellent talk, Sumesh. You are always at the forefront of heightening the intellectual quotient. So which was very evident. And artificial intelligence is something which is really taking off. And I think we have had a great insights from Senthil. So Senthil, I just have one question before I close the session about artificial, because that was one area which is really taking mortality predicting that would really be excellent sort, and it's a lot of intensivists so the session.
Yeah, I've come across some mortality prediction models, and I start wondering when I see a model, that predicts an outcome. One, it has to be, as in, it needs to predict something after. So I've seen these mortality prediction models, come up a few times, and I start wondering, okay, what will be the use of a machine that predicts mortality rather than something that predicts preventable and treatable? So let's say if the patient is going in for septic shock, and then the model gives an early warning, maybe 6 hours ahead of time or something like that, then I think that would be of a lot more use. So I'd like to hear more from, intensivists about how would a mortality prediction model help you, as opposed to a model where it gives you usable information that's actionable that you can use to, treat to change the outcome.
Thank you, Dr. Senthil. Yeah, over to you, Dr. Yash.
Thank you, Dr.
Thank you so much.
Yeah, Dr. Senthil. If we have a predictive model which is quite precise, we can decide on the site of admission, how intensive our care should be, how advanced our intervention should be, and obviously the family counseling part of it. So, lot to apply on the bedside if we have good, precise models. Thank you.
Thank you.
Yeah, Dr. Charu, thank you. We move on to the next session. Please proceed.
Thank you so much. I would request all the audience members to please keep themselves on mute while the sessions are going on. Moving to the next session, we have the chairpersons, Dr. Ranveer Tyagi, sir, who is a senior intensivist and director of the Synergy Hospital in Agra. We have Dr. Srinivas Samavedan, who is an intensivist from Rinchi Hospital in Hyderabad. And we have Dr. P.K. Das, who is an intensivist from RML in Lucknow. And we have the first session of this is one of my favorites and personal favorites because my thesis was on this. It is new biomarkers in sepsis, which is presented by Dr. Ashish Khanna, who's an associate professor and vice chair for research, Department of Anesthesiology, section on critical care medicine, Wake Forest School of Medicine, Wake Forest Baptist Health, Winston-Salem, USA. Can I please ask Dr. Ashish Khanna to proceed?
Over to chairpersons. You can please take on the proceedings of this session. Thank you.
Yeah, good. Hi there, and thank you to the Indian Sepsis Forum for this kind invitation. I'll talk to you all today about new biomarkers of sepsis. These are some of my disclosures. So as we talk about the response to vasodilatory or septic shock, we've always talked about the sympathetic nervous system and the arginine vasopressin system, but new in the last few years is the role of the renin-angiotensin-aldosterone cascade. So really, the three of them constitute what we call the three-legged stool for counter-regulatory systems for blood or septic shock. The initial experience with angiotensin II, which is the major metabolite coming out of the renin-angiotensin cascade, goes back to the 1960s or the early 1960s, where first reports of the use of angiotensin II in septic shock were initially published. Subsequently, over the last 40 or 50 years, there's been anecdotal uses of angiotensin II in the emergency room, in the ICU, here in this case, in a case of ACE inhibitor overdose, where angiotensin 2 led to improved hemodynamics and improved urinary output. More recently, the ethos trial was done at the George Washington University, led by Lakshmi Chawla and colleagues, saw a significant norepinephrine sparing role of angiotensin 2 along with hemodynamic stability for this new vasopressor. We joined the angiotensin 2 research group in 2017 when we published the angiotensin 2 for treatment of vasodilatory shock trial in the New England Journal of Medicine. This was a large phase 3 trial on vasodilatory shock patients done at about 80 plus sites across ICUs all over the world, where we showed that angiotensin 2 compared to placebo had a significantly increased odds of getting to a predetermined hemodynamic response that was a MAP of 75 or 10 more than baseline. In addition, we also saw that this MAP response was brisk and consistent all through utilization of angiotensin 2, that is shown in the blue lined graph here compared to the red line graph of the placebo arm. We did not see a survival benefit at day 28, even though there was a nice separation of the survival curves that started pretty early on in the process. So our approach really is a more synergistic model to resuscitation of septic shock, and that's where we'll be talking about some biomarkers as well. So my approach is early utilization of not just the adrenal medulla. So you just don't go to norepinephrine as your primary agent for resuscitation of septic shock. You also go early on to the posterior pituitary and to vasopressin or vasopressin metabolites, and then very early on switch to the renin-angiotensin cascade, angiotensin 2 then acting through the AT1 receptor for most of its downstream effects of vasoconstriction, aldosterone secretion, sodium and water reabsorption, and also some synergistic vasopressin release. So broadly speaking, early synergistic vasopressor therapy. So coming to more of the biomarker side of things now after this initial background, we know that there is a gross impairment in the sympathetic nervous system in septic shock. There's also a deficiency of plasma vasopressin in septic shock. And now we also know that the RAS system is altered in septic shock. So angiotensin receptors are downregulated, and this has been shown in various studies over the last 2 decades or so. ACE itself is a pulmonary capillary endothelial enzyme. So knowing that the endothelial lining is destroyed in various forms of shock, especially those that lead to acute lung injury and ARDS, we are considering that ACE would be decreased in patients with septic shock, and therefore there would be low endogenous Ang2. And this has been shown, for example, in this investigation published in Circulation almost 20 years ago now. As the amount of underlying acute lung injury increased, so did the decrease in the ACE substrate. So basically, as acute lung injury went from a lung injury score of 0 down at the bottom here, a lung injury score of 0.5, the Amax over Km values also decrease. So the enzymatic activity of angiotensin converting enzyme decreased as the lung injury score increased. Now, what does this translate into? This, so the ARDS have low endogenous Ang2 activity, and really it is that into stream effects, we are now looking at in patients with septic shock, and therefore our important novel biomarker in septic shock becomes renin and also precursor metabolites like angiotensinogen and angiotensin 1. Renin, because easily becomes a novel and an important biomarker in septic shock then. Now, how does all of this work again? Angiotensinogen, angiotensin 1, ACE, I talked about endothelial injury, angiotensin 2, and downstream effects. also affecting the adrenal cortex and the ADH secretion. And this is a tight feedback loop. So if everything else is okay downstream, then renin is kept in check. So it means that you and me, because we are at physiological equilibrium right now, our renin levels are normal or have been kept in check by enough endogenous Ang2 floating around in our systems. So good biofeedback mechanism. But when this is impaired at various levels, then angiotensin 1 start up, and this biofeedback loop will, once it is impaired, will then increase renin and angiotensinogen. When we provide exogenous angiotensin 2 in the green arrow here to patients who are deprived of ACE and endogenous angiotensin 2, then we are able to reset this biofeedback loop, and we're able to then decrease angiotensinogen and renin back to normal. So again, hypotension, septic shock, renin activity is increased, and hypotension, septic shock, ACE is decreased. Both of them lead to increase in back products. You provide exogenous angiotensin 2, you're able to reset this biofeedback loop. So how does this translate into the biomarker renin itself? Well, this is how it is. So simplistically speaking, angiotensinogen, renin, Ang1, Ang2, classical pathway, non-classical pathway, impairment of production of endogenous angiotensin 2. What happens in the non-classical pathway is that this whole pathway is diverted to ACE2, angiotensin 2 to 9, and angiotensin 1 to 7. And angiotensin 2 to 9 and 1 to 7 are vasodilatory, which also contributes to the refractory vasodilatation we see sometimes in septic shock. So remember again, it is not just the decrease in angiotensin 2, it is also the increased production of angiotensin 2 to 9 and 1 to 7, because a diversion of this pathway to the non-classical pathway that is leading to problems in septic shock, and also increased bradykinin and metabolites that further contribute to the vasodilatory arm of septic shock. So renin has been investigated, and this work comes from the group in Belgium, where Jean-Louis Vincent was part of these investigators. Patrick Gleason is the first author. They looked at about 20 patients and 110 odd samples of renin from a very heterogeneous population of shock, and they showed that renin outperformed lactate as a marker of tissue perfusion and prognosis. So renin was not just outperforming lactate in this investigation, it was also not affected by diurnal variation, by continuous renal replacement therapy, or other drugs that affected the ACE or renin-angiotensin cascades, outperformed lactate as a predictor of ICU mortality. Now, this work, I wrote an editorial for this titled Tissue Perfusion and Prognosis in the Critically Ill, Is Renin the New Lactate? And I guess renin is the new lactate. But the problem is that as a biomarker, it's difficult to use renin because there's no point-of-care test of renin as yet. So while lactate comes back to us within minutes when we send a blood gas, and we're able to titrate perfusion and resuscitation based on lactate, we're unable to do that with renin, which really means that renin, because it takes a few days to come back at best, cannot serve as a real-time marker that patients in the ICU. The work with renin very recent, published ahead of print, is a group from Merrill at about 200 patients in ICU for greater than 6 hours to maintain a map of 65 that significant or terms of renin for 70. Also, a high renin versus a high lactate. So high renin was 40 picograms per cc high lactate. High renin itself was more discriminatory in terms of poor prognosis of patients than high lactate. So at each study time point, a higher proportion of renin values exceeded thresholds of normal in non-survivors than in survivors. And this association was not significant for lactate. So very simplistically speaking, if we looked at in the dark, the patients who died and the slightly light patients who stayed alive, the patients who got to a renin of more than 40, significantly higher proportion died at clearly renin peak renin for here to ICU out. This renin angiotensin 1, angiotensin 2 correlation has now been well established. This goes back to a few years ago when we did see that an Ang1, Ang2 ratio that was high, so low endogenous angiotensin 2 led to poor outcomes. And when this was correct, Ang2 in the group with the to a survival benefit. Hyperreninemia for several is the most common cause of hyperreninemia, where ATHOS-3 was in our renin levels are very high. So high levels are about 150. Our Q1 and Q2 500 here, and our outliers are, we did exclude common causes of high. Understand that high outside of a reninoma is very common in patients with high output or septic shock. That's what I'm trying to tell you here with this slide. So after we've looked at all of these renin numbers, let's look at what we did. Just last year, we published this. We looked at patients who received placebo instead of angiotensin 2, and those who had renin above median in our cohort of ATHOS-3. And we saw that about half of these patients were dead at 1 week, and about 80% of these patients were dead at 4 weeks. So high renin received placebo, almost all died at 4 weeks out. However, in the blue is patients who received exogenous angiotensin 2 to correct this biofeedback based on this high levels of this biomarker. And most of them have survived. In fact, there was a distinct survival benefit that we published in the Blue Journal in early 2020. So in patients and those and again, serum renin, it's to ratio, so of baseline Ang1 Ang2 ratio and baseline renin. So as the Ang1 Ang2 ratio increased, so did the baseline renin. So low endogenous Ang2, high baseline renin. So what does all of this show? This table is a real sort of summary of what I've been trying to say. So work with Belomo and colleagues. This was part of a part of those slides. And we looked at the renin Ang1 Ang2 relationship. We looked at the use of exogenous and that 3 hours post and was a survey. The basic implication of that was that we were able to identify patients that could benefit from synthetic angiotensin 2 through the RAS mechanism. This was followed by the Gleason investigation that I previously showed, the Belgian group, 20 patients 110, 112 samples, all comers with shock, single center investigation, but a retrospective look at prospectively collected samples. They looked at peak renin and lactate and change in renin and lactate over time. Their outcome compared to below here was 28-day survival. Gleason was ICU mortality. They looked at and they saw that peak renin and rate mortality compared to Gleason, compared to below where it was a baseline renin elevation in catecholamine-resistant vasodilatory shock, and that use of exogenous Ang2 would benefit these patients, correct and improve mortality and outcomes. The Gleason investigation was the first one that compared renin and lactate and saw, in terms of an early piece of evidence, that renin is a better biomarker of ICU mortality compared with lactate. And then more very recently, a larger cohort, this time nearly 2 patients, again, all comers shock, single center, but again, this time it was initial and peak renin and lactate and change in renin and lactate over time, outcome being in-hospital mortality compared to ICU mortality for Gleason. And this time, what has been done as a sort of advancement in science is both renin and lactate as initial and peak predicted in-hospital mortality, but the rate of change of renin or renin greater than 40 picograms per cc was a better predictor than the rate of change of lactate or an absolute lactate more than 2 millimoles per liter. So this added to the evidence that renin is a better biomarker of ICU mortality compared with lactate, especially reinforced the rate of change of renin and a threshold value, and open avenues for more prospective work, hopefully more randomized trials that it can actually give something to correct work that would develop point-of-care assays for the renin-angiotensin cascade and renin itself. In other news, renin has also been shown to predict AKI post-CT surgery, so a fairly decent ROC curve with an AOC of 0.702 and 0.817 state difference in renin to allosteric bypass. And of angiotensin also show there's that of hemodynamics on vasopressor survival benefit specifically shown that Hoover. We anecdotal experiment on VV for septic. This is maps were in the four. This is about the point we started angiotensin 2 on top reference. I sent was an extreme shock, and the renin came back at our 4.3. So renin was 10 times elevated, typical high out. Patient angio almost hours or so hemodynamics by the morning biotics broad spectrum say at some stage clearly there was benefit with the angiotensin 2 days later and elevated. I remember, and there's another example story. Adrian started with significant activity, catechol and correcting of this shown to improve has been shown to improve to shown to overall all are trying to catechol increased catecholamine, and that is today. But keep in mind, still as this biomarker is concerned, and I wish you all the best. If you have any questions, my contact information is on the slide. Stay safe, stay strong, and wear your protection. Take care.
Thank you so much, Dr. Khanna. That was a very nice talk. Can I please request our Srinivas session?
Let's use our next bias format and speak to us about sepsis.
Speakers.
Recording in progress.
Sepsis. To Indian Sepsis Forum for kindly inviting me to give a presentation on tropical diseases and mostly on the resources from management of sepsis in resource-limited settings, as well as from the various commentaries and documents from Global Sepsis Forum, as well as Regional Sepsis Initiative. We are all aware that Sustainable Development Goal and infection has been provided enormous importance, like ending the epidemics of AIDS, tuberculosis, and malaria, and neglected tropical diseases, and combating hepatitis, waterborne diseases, and other communicable diseases, and also covering access to quality healthcare services and vaccines for all. In addition, sepsis related to resolutions, as well as the water sanitation hygiene resolutions, are relevant for infection and sepsis management. Globally, in the 6 World Health Organization regions, the varieties of infections differ. Bacterial, viral, dengue, the region. The definition of sepsis, according to 2016 guidelines, is life-threatening organ dysfunction caused by a dysregulated host response to infection. To emphasize the difference between infection and sepsis, the host response determines the organ dysfunction guidance rather of the illness. Common causes of sepsis in tropical countries, although the detailed epidemiological information on sepsis and septic shock in tropical regions is extremely limited, but wide range of systemic febrile illness, respiratory-related illness, hemorrhagic fever, diarrheal diseases, vaccine diseases, sex, the common cause of infection. In Shigella, E. coli, Klebsiella pneumoniae, the Acinetobacter, Salmonella typhi and paratyphi still dominant. The non-typhoidal Salmonella. In one study in Dhaka, in a selected population, the Bacteria pseudomeliae has been found to be quite common. gram-positive streptococcus, microbiome tuberculosis are examples. In other parasitic diseases, for example, malaria, there are a significant proportion of severe malaria has bacterial infection. So also in visceral leishmaniasis, having the immunosuppressed conditions, the infections acquired in the community are dominated by gram-positive organism. The hospital-acquired infections are dominated by gram-negative organism. In one hospital, the 300 adults and children admitted malaria negative, examined by blood and relevant urine culture and other cultures. Positive or various types of the 19 by PCR detected, so also rickettsia, dengue, and other viral illness. Antibiotic resistance is one of the important concerns for LMIC. Despite the limited data for guiding antibiotic treatment, clinical and lab data of surveillance data are lacking. But despite that, there are a significant proportion of ESBL, MRSA has been detected in Asia, and also carbapenem-resistant organism up to 8%. New Delhi metallobitalactamase NDM has been found in 5 to 8% Enterobacteriaceae. Risk factor for antimicrobial resistance is one of the important risk factors is previous use in MRSA, ESBL, carbapenem producing under contribute. I say, of course, they are due to out-of-pocket expenditure, including the quality of antibiotic as well as contents and substandard and counter. The infection and respiratory rate, pressure less than 100, and any acute change in mental status. To recognize patients, infection, tetanus, sepsis, severe malaria, having the WHO tracking, etc. The diagnosis of dengue infection like shock, respiratory distress, severe bleeding, or death. Then sepsis, there are prevalent factors from those threatening conditions may be associated with a significant risk of death, with such as Ebola virus disease, tetanus, rabies, etc. Sepsis campaign do not provide information on the management of sepsis disease. The in the tropics due to the population at preventive healthcare, control of comorbidities like malnutrition, infection, causing there may be parasitic, antimicrobial resistance, clinical circumstances, capacity, having a lack of large different. There are, if we classify into 3 groups, it's a non-communicable. 20 years or so, the infection may see. As well, the sepsis is dominant in Southeast Asia region, Africa, and South America. with the this SDI, Social Demographic Index. In that case, both the cause of death as well as the in income countries, the proportion of death is much reduced, could be reduced due to the economic condition and better quality ICU. And so also the two age structures in adults in early childhood as well as in adults, the infections are in our age, India as well as in Bangladesh. It has been found that around 8% infections, the 8% admissions in ICU are due to infection is quite high in these ICUs. Particularly to note that tropical infections around 17% of admissions in ICUs. Of them, the 31% of infections due to tropical diseases is to die in ICUs. There are several steps to reduce the burden of sepsis by strengthening public health and acute healthcare delivery system, accurately cases, the conduction of inclusive research, then establishing data-driven and context-specific management guidelines, and promoting creative interventions. And then there are the critical our region in LMIC. In comparison to developed world, where there are 5 to 30 beds per 100,000 inhabitants, in LMIC there are around 2%, maybe less than 1% in some countries. There is no dedicated critical care facilities in tropical highly infectious diseases, except in recent COVID-19 infections. In the limited setting, quick sequential sepsis organ failure assessment score, QSOFA, by simple clinical parameters of respiratory rate, mental status, historic blood pressure. By these three parameters, around 10,000 population, LMIC cohort in 9 diverse settings, covering diseases. If the QSOFA is more than 2, there is increased likelihood of death. So the odd ratio is about 3.6 if QSOFA is more than 2. The recommendation that antibiotics be administered early may not always be appropriate because many of them are non-bacterial diseases, but despite that, if microbiological facilities are available, culture should be taken for understanding the source, for the source control, and all the epidemic also been versus community risk and to treatment, antibiotic, and de-escalation is possible to narrow spectrum of antibiotic therapy. The suggested care bundle for sepsis management in resource poor setting, in acute care bundle, we can provide oxygen therapy, fluid resuscitation, early adequate antimicrobial therapy, surgical source control. With post-acute care bundle, the evaluation of antimicrobial therapy, providing prophylaxis for deep venous thrombosis, adequate control of glucose, and weaning of invasive support system. The classical tropical diseases and sepsis, malaria, we shall talk a bit detail in a minute. In dengue, the mild dengue as well as the severe dengue, we can differentiate. And in severe dengue, there is no education. Then those followed by attention, the limited followability, there is of course, the large trial is still room for doing fast trials. The platelet transfusion Choube typhoid, the evidence-based is not available. Resistance typhus fever test is not easily if diagnosis is suspected. For example, jaundice and respiratory organ involvement may have as an important cause of sepsis in regions and in oil transmitted bacteria where there is rural non-mechanized farming is there, diabetes mellitus either not controlled or they are not a broad spectrum combination antibiotics for weeks followed by oral. They may present with abscess and in sepsis in such a situation melioidosis will be unsuspected. Strangulosis is a specific concern in LMIC, particularly when there is use of a steroid or immunosuppressed conditions is there. Severe sepsis, strangulosis is treatable doing the dural aspirate examination. Strong suspicion. There is debate whether COVID-19 is sepsis or not. So also rabies. This is malaria. We have entered in a new era where this nation is an expected 30 by either by parasitological by micro. One of the reassurance program detect the parasite and one it periodically the quantify then there is a suspicion that the as has been seen here in Greater Mekong sub-region there is a Kelch 13 mutation from Laos and then spread eastwards to Vietnam, Cambodia, Thailand, and eastern part of the Myanmar. Study treated Filciparum malaria in treatment. There has been this malaria is sequestration of the erythrocytes containing Meseriform vasculature of the vital organ and clogging at the erythrocytes. There are the cytoadherence to the causing compromised circulation. Situation, the severe malaria and many, for example, gestations, apathy, convulsions, the respiratory acute kidney failure, renal failure, convulsions. It differs. This in children, there are classical retinal findings detected by symmetrical hemorrhage, and this is almost equivalent to the similar findings could be the photography. The severe malaria, quite. This is associated with jaundice, convulsion, of course, common both adults and children. The treatment of been years due to a very large station severe or by artificial it has been found in all in African in the anticipating if death, the mortality was 2%. In other words, 35 could be made by organization. Health infections evidence of sepsis is caused affecting different or are posing problem in LMIC are underestimated. Logistics tackle sepsis. It is the on-site by public in early disease before outbreak.
PK Das sir to introduce our
Yeah, thank you. I hope I am audible. Speak to at Children's and Women's Global and BCC Critical Care in Global Child Health, BCCH Research Institute, Sir Global Sepsis Alliance, Vancouver. I think no,
Doctor behind the global sepsis schedule, he could thank.
Yeah.
Okay. We thank the Indian Sepsis Forum and the Indian Resuscitation Council for inviting in their meeting for Global Sepsis celebration. But I know many of you have been much in COVID work, and from what I understand, India, I hope you're answer. Our dedication, sepsis would be very important, and for sure, it's really some reflections. I think is the future. We need this. The many faces of sepsis we see is that sepsis is several things. It's a medical problem with varying etiologies, delayed recognition and treatment. It's a socioeconomic problem in which those that do and early, there's a lack of resources, money. There are staff shortages in some areas. Health-seeking behavior is suboptimal in those with less resources. And at the end of the day, in many societies in which women are not empowered, children suffer and their own health suffer. It's a political problem also where government priorities, staff poaching, drug shortages and vaccination issues play a part, as we see it right now happening in the COVID pandemic worldwide. Both said it very clearly when he said many political borders serve as semi-permeable membranes. And what he meant is diseases often quite pass very freely across borders, as we've seen with this global pandemic. Cures is close to drugs, and so be contained in this way. And I think for global issues, who predicted the Ebola epidemic wrote that when we think of global issues as we are dealing with a global to prevent pandemics and other global issues, we need pharmaceutical industries, laboratory governments, health forces worldwide need to be marshaled for this target. So we not only have to reap the fruit, the labor of science, but also politics, sociology, economics, and even elements of religion, philosophy, and psychology to really get best sort of penetration of cures, penetrations of prevention measures. And in fact, when we look at healthcare in this era of the Sustainable Developmental Goals, while good health and well-being plays a central role, we know that good health and well-being depends on eliminating or decreasing poverty, decreasing malnutrition, supporting quality education, fighting gender inequities, and climate change, etc. And one can go through these 17 different sort of targets in the Sustainable Developmental Goals and see how they all play into health. So hence, I hope I've convinced you that we need a broader view of sepsis and hence a broader view of innovation if we are going to make inroads in sepsis and COVID-19. So I'll give you one example. This is a very recent study that just came out in the Lancet earlier this year. And it shows that the importance of parental education and inequalities in child mortality. In fact, a child born to a mother with a high school degree had a 31% lower risk of dying before their fifth birthday. That's 31% lower risk of dying for a child with an educated mother. For a father, it's 17%, which shows that most of the care for children are taken care by mothers. And 1.5% lower neonatal mortality per year of education for mothers, slightly lower for fathers, but still appreciable. In fact, when we look at parental education in neonatal and child mortality, which is mostly due to sepsis and birth problems, we need to, there needs to be address prioritizing needs of the poor, addressing malnutrition, achieve inclusive and equitable quality education, fighting gender inequalities, water and sanitation for all, etc. So mobilization of resources and technology in every one of these areas will have an added benefit. Indeed, what has been stated is that education is social medicine. And I think that's very important to know in looking at sepsis and COVID-19. So if we are thinking of the dimensions of system resilience in taking care of COVID, we need prevention and preparedness, which would depend on anticipation of what is going to happen. And then we need agility and transformative capacity. And again, that would be absorption, adaptation, and transformation. And one can see in all these areas, we have made some changes in COVID that is beneficial during the pandemic, beyond the pandemic. COVID is pandemic and one, etc. into the we know enough breaks, and many of falls between in not sort of anticipating the epidemic and not preparing for it. The technological advanced tools, which I'll be talking about some, which is required to anticipate emergence of an application of outbreaks, good tracking system, etc. And when now we have a global and we have more people living in rural, in urban areas and rural areas, we need to adapt all these systems to public health measures, surveillance system. And all this was stated in the WHO informal consultation looking at anticipating emerging infectious disease epidemics. So when we look at some of the new technologies to fight COVID-19, wearables and early COVID-19 detection, there's the issue of using heart rate, sleep patterns, and skin temperature, which these wearables can be used at home or anywhere else. And to spread public health messages in many ways. And there's a downside to this, which I'll talk about, advice on hygiene, prevention, and seeking healthcare, etc. Leveraging artificial intelligence to help identify COVID treatments is very important. And looking at treatments to decrease the body's own cytokine inflammatory-based response, etc., is pathologies. Detection through X-ray scans is now also being looked at through artificial intelligence-based database of X-ray scan and deep neural networks to distinguish between patients with pneumonia, TB, and COVID-19. And we have also moved from e-commerce, where we were using our sort of electronic systems, to v-commerce, which is virtual commerce, and that has led to us having some of the physical separation and being able to limit the spread of COVID-19. And all of these need to be leveraged as we go forward and in the field of sepsis also. If we look at the global reach of mobile phones to affected areas during COVID-19, one can see in the rich countries in Europe, Latin America, and some parts of the two have been cases is very high. World in which there's a high density of mobile phone, and it just shows the power of having technology and leveraging this technology for good. And we have seen this during sepsis also. There are a marked number of changes, in fact, Google searches, etc., when there's an incident in sepsis in the, anywhere in the world. So one can see that leveraging technology in the areas in which, like sub-Saharan Africa and some of Southern Asia, in which a large number of patients has not penetrated, it's problematic right now in really even getting an idea of the burden of COVID-19. We have used smart technology in our smart discharges program in Uganda. And it is simple use of cell phone technology in which we have programmed triage tools, simple treatment protocols, but also predictor tools to predict who those children who are the highest risk of mortality from sepsis, set up counseling through these instruments, and follow up also such that they can be followed up. And we have shown 30% fewer deaths after discharge and better health seeking behavior, because 60% of these children, and I think talking about is not only high tech and high resource environments, rich folks, but also in very poor environments, frugal technology can be used. But right now, technology also has made the world more inequitable and spiky. So for instance, when we look at new technologies to fight COVID-19, there is a different health. economic resistance in the region and cybersecurity. 29% America and Africa, South America, in the same pattern. The areas in the world with the greatest burden have less resources and technology, and this is something that we need to be aware of and correct. Digital technologies used in the public response to COVID are many. They've been used to target public health messages, syndromic surveillance. We have looked at visualization tools, data dashboards, digital diagnostics, symptom reporting apps. Time, because one technology where tracing is contacted, the other contact record, they confirm into a centralized data system. User B now has their user B the reason that happened was with, so we need to have a all get back tracing used in some areas for COVID, but has been used. It should be used for beyond. Talk about beyond COVID now. A few things. Spoken about sepsis. It should be a fact obtained and showed that it's a good solutions are needed. As some of the sepsis cancer, it pathogens respond differently, needing different treatment approaches, reinforcing the understanding of training and supportive care, appropriate intervention, public health, maintaining the research infrastructure, because one of the things that has been very seismic advance in this is the infrastructure and funding for research, and we need to maintain those international platforms. We also wrote recently, WORLD SEPSIS data and improve. We need to develop care, and we need effective and agile research in pediatric sepsis, and all that can play a part in what we've said before. When we look at a triumph of modern technology during COVID, we look at vaccines before polio, typhoid, yellow fever, influenza, chickenpox, swine flu, etc. It has to produce, and when it has been produced in a year. Now, granted, it has built on that all the experience from those previous vaccines, trials, etc. But it's really innovation that we should go forward where vaccine is suboptimal. We look at also, we went from academic research to phase 2 trials are done very quickly. Building factories were done. So academic research to traditional ways done, manufacturing industry, approval and distribution. And one can see the large number of vaccines across the world that have been produced in short period of time. So I think that that's all very important and very useful going forward. when we talk about hospital care, out of hospital care has changed. Intra-hospital monitoring for, say, cardiac failure in patients required several things: blood exam, chest X-ray, intake, output, etc. But many of those can have been done by home monitoring now, and I think this is a way not going to happen. So sepsis care is also changing in this direction. And summary and a few reflections. There was a conference recently, technology and some of the issues they've spoken about. In short, all these issues they've spoken about are relevant for sepsis, but it's really more narrow focus. And we need to widen the focus, as I said, and take a more global view, a broader view. We also know that coronavirus disease has spawned a pandemic, infodemic of information. In fact, when we look at just over 50,000 papers on Library of Science and almost 17,000 in technology only. So how does someone sift this information? We know what is happening on the web. We know the movement of vaccine hesitancy and anti-vaxxers, and it's all spawned by information, very difficult. And we have to do a better job at containing the infodemic and being practitioners to give the best information. And that can be done via technology also. And answers in any with COVID. We know is that while we needed acceleration in many areas, child health, maternal health, HIV, immunizations, TB, etc., because of the pandemic, there's decades of improvement have been reversed by healthcare disruptions, and less than half of the global population is covered by essential health services. Interrupted vaccine programs in 70 countries will affect children again. It is expected that illness and deaths from communicable disease, including, for instance, malaria, there will be 100% increase in deaths in sub-Saharan Africa. So I think we need to be cognizant of that and not be enamored by the technology only. I'd like to end with this, is that basically, while we've said that technology has made the world flat, I think it has made it more spiky, as we've seen during COVID. And the point is that we are not all in the same boat, but we are certainly in the same storm. I'd like to thank you very much for the opportunity, and I wish you a very successful conference, a very successful World Sepsis Day. And I also like to wish that you keep well, and I hope that we can meet each other face to face at some time. It's been too long. Thank you. Bye.
Thank you so much, Dr. Kissoon. It was very enlightening on harnessing technology advances from COVID-19 and sepsis. And thank you so much for taking out time for all of us during this World Sepsis Day. Now, due to time limit, comment from our chairperson, Dr. Ranveer Tyagi, sir, from Synergy Hospital, Agra. Dr. Tyagi, sir, any final comments on the session?
Dr. Srinivas and Dr. Das, your comments, please.
I will probably thank you, Yash, for organizing this listening experience, listening to all the people who are driving this sepsis movement across the world. It's also reassuring to hear from Dr. Kishan a positive outlook and positive contribution of COVID to healthcare. I mean, it's not all gloom and doom everywhere. I mean, you have learned a lot. Technology has taught us how to deliver intensive care in the toughest of circumstances. And we also take it back to what Dr. Faiz spoke about what are the limitations of the guidelines and the applicability in low-income and middle-income countries. We forget the burden of drug resistance in these countries, which is much more than what it's in the West. Hopefully, we will find a good
turnaround time with run-in activity measurements, as Ashish was so elegantly, and that's all I can.
Dr. Das, your final thoughts?
And Niranjan, use of new different scenario is areas of sepsis also. Dr. Faz also had a very nice lecture on tropical diseases and how sepsis can also develop in such patients. And first lecture by Dr. Assis about the new biomarkers. We're looking more about the PCT or seeing the tissue perfusion by assessing the lactate level. But renin has got a new emerging role in the diagnosis of sepsis. So it was a very nice lecture and very nice session. Thank you, Dr. Yes, for organizing such a nice action of COVID has had session on interaction was will certainly be very helpful to all the viewers. Thank you.
Thank you. Thank you. Thank you, Chairperson.
Thank you so
move
much.
on to the inauguration. Very feel free. May I invite Dr. Rama Chaudhary? Dr. Rama Chaudhary is professor at AIIMS, Delhi. She represents ASM, American Society of Microbiology in India. Welcome, madam. We have Dr. S.C. Chakrarao. Dr. S.S.C. Chakrarao is a very, very senior anesthetist. He has been president of ISA. He has been Director General of Health Services in Andhra Pradesh. And now he is Indian Resuscitation Council. And the council is doing wonderful job in increasing awareness about resuscitation and CPR. We are also pleased to have Dr. Rajesh Mishra. He is President-elect IACCM, a thorough academician, a very intense intensivist. He hails from Ahmedabad. He is a freelance intensivist attached to many hospitals. He has tele-ICU services, which he is providing worldwide services from Bangladesh to Africa and other parts of the world. We are privileged to have all three of you during the inauguration ceremony. May I request Dr. Rajesh Mishra, very dear friend of mine, to say a few words about the World
Thank you for the invite. This on need of the update and interest, you can go ahead. And I wish all the success for this activity, and I wish that all the viewers will update their knowledge and understanding about sepsis. So thank you for this. Please go ahead.
Thank you, Dr. Mishra. May I request Dr. Chakrarao to say a few words about the World Sepsis Day in ISM?
Thank you. Actually, this is a. Actually, we are talking in the middle of the pandemic. Came to know this is the 10th anniversary of the Global Sepsis Expert Forum, and the Indian Sepsis Forum has come out, and the Indian Resuscitation Council will be taking part in all the activities. Not only that, apart from the new biomarkers for detecting the sepsis, we have to make some create some awareness among the people regarding the sepsis. So this is, I think, and it's a very auspicious thing, and definitely we work together and go further. And I wish you a very good luck, and let us all work for the. Thank you.
Thank you, Madam. Your words.
Good morning, everybody. I'm really happy to be in this forum as a representative of microbiology. First, and thanks for inviting us on this forum. So American Society for Microbiology is working with all local and other organizations in advancing the field of microbiology, collaborating with scientists, with clinicians, ID specialists world over. And we have been able to kind of actually told by UN, and especially the is talking about the good health number 4, which and the last goal out very clearly through American Society. I think on this, the is really worth kind of lectures which have been all clinicians, interventionists, in Indian Resuscitation Alliance, a huge task which is really congratulate. Wishes for.
Thank you, madam.
Sir, can I please ask you all?
One second. It's a privilege to welcome you all to this meeting. We have tried to initiate a dialogue between various stakeholders from sepsis. What generally happens, there is a monologue between the intensivists or the ID physicians, at most with the microbiologists. But this meeting we took as an opportunity to outreach physicians, surgeons, public health experts, microbiologists, resuscitation experts, and do a lot of crosstalk. The meeting, if we organizations, I am privileged to have Dr. Rama Chaudhary, madam, who represents American Society of Microbiology, and they have a joint session with us today afternoon. Thank you, madam. Indian Resuscitation Council, we have a very interesting and novel session on resuscitation in sepsis and COVID, and we have very elegant speakers talking about the concept. We also have been supported by Anesthesia TV for our. We are relaying this program on YouTube Live and Facebook Live, also on various other social media platforms. Indian Sepsis Forum was convened in 2000 meetings, profile meeting, and this year that we have to all our friends and have organized this meeting. Forum, Indian Sepsis are on the meeting. To medical learning, we had very medical learning done wonderful. Thankful to Dr. Charu, various organizations being represented by various people, Dr. Kisun, Dr. Ashish Khanna, Dr. Sumesh, Professor Quirino, from to delegate and through various others. Keen, and it has been an off hour, late hour at many countries, but still they have joined us for this August meeting. I'll try to keep the meeting on time, so I'll stop here and over to you, Dr. Charu.
Thank you so much. And we welcome you all after the inauguration to the Global Sepsis Forum and the Intensivist Group, YouTube and streaming on Anesthesia TV. We have the moderator, Dr. Neeraj Yadav.
Yeah.
Ma'am is a consultant in critical care medicine, Lucknow. Over to you, Dr. Yadav.
Yeah. She's probably busy in the ICU.
I'll take care of it.
Yeah.
Chairpersons for this session would be Dr. Ved Prakash sir, who's the head of pulmonary critical care at KGMU Lucknow. Dr. Kamalpreet ma'am, who's the director and head of critical care at Deep Hospital, Ludhiana, Punjab. And we have Dr. Gunjan Chanchalani, who's a chief intensivist, Bhatia Hospital, Mumbai. Is everyone available? And then we can start with the next session.
We have Arun Alok, microbiologist. We are privileged to have him with us. And he had a very, very busy schedule. But despite of his commitments, he was forthcoming and we could record. He needs no introduction. He is the face of microbiology for the ESHAM and for the ESHAM which will be held in India next year. He is also the principal coordinator of Fungal Infection Study Forum. There is an online registry which is happening right now. May I request the recording from Dr. Arun Aloke to be presented? Yeah.
Good afternoon, ladies and gentlemen. At the outset, I'd like to thank me infection in COVID. What is the fungal infection? Let's see that in any of the respiratory viruses, when they enter, they damage the airway epithelium. Because of that, this go inside the lung. Even the immune dysfunction produced by the virus is further invasion. Regulation, even during infection, is known to release danger-associated molecular pattern and this role in pathogenesis of fungal disease. And while we manage COVID-19 patient or inappropriate corticosteroid, or even if you are giving appropriate steroid and anti-IL-6 antibody, both help in case of fungal invasion. But in case of the invasive candidiasis, I would say that it is more with the compromise in infection control that is major issue. So, fungal infection in COVID patient mainly seen in case of ICU or severe. When we speak about fungal infection, the two names which come at the forefront, invasive candidiasis and aspergillosis. And if you look into the papers with COVID, they said that the really other causes the infection like mucormycosis, after probiotics, Saccharomyces fungemia, or invasive fusariosis. But I would say that COVID-associated mucormycosis in India has changed the whole paradigm. And we see that's a major issue in case of the COVID in case of India. But when we discuss about the pulmonary mycosis, the problem in COVID is that the symptoms and signs of pulmonary mycosis are similar to the COVID-19, so there is a big problem in case of diagnosis. We have COVID-19. So what I'm going to discuss with you is these three topics. First, I am going to discuss the COVID-associated candidiasis. You know, in the early part of COVID-19 last year, when people evaluated, found that the incidence of secondary fungal infection is very low. But by the time in the second half of 2020, it had been seen that already the COVID-associated candidiasis rate increased. This happened because of comorbidities, indiscriminate use of antibiotics, group infection control. From the different country, you can see 0.7% to 23.5% of the ICU where they suffered from invasive candidiasis. And India had shown around 2.5% rate. But I would say that despite marked immune dysregulation of COVID-19, no prominent defect in immune cells that are critically required for COVID-associated candidiasis. So it is more with the management issue and other factors like prolonged ICU stay, CBC, overuse of antibiotics. These are important.
But what is that the multi-drug resistant Candida auris and even Candida glabrata, which are increasing. Multi-drug resistant Candida auris pandemic, you already know that it has spread in 42 countries. And here also what it had been seen in this year and end of the last year, that there is increased number of cases which have been seen in COVID-19. You can see this has been seen in case of Florida, this has been seen in Mexico, this has been seen in case of Colombia, even in case of India. If you look into the analysis of all the papers, mainly they have highlighted lapses in infection control practice. In case of hand wash, important issue in this scenario. Single center study from Turkey, but this is the first study where case control had been done. Means candemia with COVID-19, without COVID-19 candemia. What they have found, candemia incidence is higher in COVID-19. There is higher rate of corticosteroid use in this group, and also they acquired the infection much earlier. With multivariate logistic regression, it showed that older age, admission diagnosis with COVID-19, antifungal treatment over 3 days, prior corticosteroid use, presence of sepsis, these are all risk factors for mortality. Now, coming to the COVID-associated pulmonary aspergillosis, this is a real challenge which had come since last year, I would say rather later part of the last year. And unfortunately, till today, there is no center study had been reported from India. But if you look into all this study, the essence of the study shows that out of all COVID-19 cases, it is which are hospitalized in with mechanical ventilation, it is around 10.3%. But here, the problem mainly is that how to diagnose these cases. I'm just comparing with the influenza-associated pulmonary aspergillosis because there was some diagnostic challenge similar to the COVID-associated pulmonary aspergillosis. Because when you cannot have proven cases, means collecting sample from the lung, we generally used to depend on this URTC MSG classification. But this classification holds good when your host factor shows there is immune suppression. Here there is no immune suppression, so most of the patients could not be. Second important thing, what it had been found is that in influenza, large number of patients produce Aspergillus tracheobronchitis, which is very few in case of. And here the infection happens much earlier compared to the upper group. Now then, when our clinical symptoms and signs are similar, if there is no tracheobronchitis, so that is a lung infection. If we try to look into the CT, look into this confirmed aspergillosis without fungal infection. Both the CT are almost similar. So where we give more stress is that multiple pulmonary nodule or lung cavitation, refractory fever more than 3 days, new fever, worsening of the respiratory status, smoke tests, pleural rub or chest pain can be important factor. But when you try to do the biomarker, as people are scared to collect sample from the respiratory tract, people rely on serum galactomannan. Even serum galactomannan sensitivity is so that in immunocompetent patient, serum galactomannan is not good sensitive. So what we did is that from European Confederation of Medical Microbiology and from our International Society of Human and Animal Microbiology, you can see this paper had come in Lancet in microscopy with BL that was due to aerosol germination as a big other procedure like non-bronchoscopy. That is part from to we start growing up. As we like the we found world started as had here part that the most they start the data from is 20 this and put in on the of the one one important by the one third of gravity is that they which we have is by the to have you have in multi come India, which data has shown percent 8%. They have shown only they part of this what we I say people coming with night. Moment of in mentioned that for where on in the first thing what is the mirror people this but just to think that in the in vitro condition when it is in if this third was built ours in the yet across into the we didn't you have a mask. What do we say are at this and he which is also This is not very easy. Both people learn control that body, our first part of being one right from my perspective. I see how instead of have comorbid that those as this see that six. Now they could say there's immediate. So to cases of in second wave. Diabetes factor. What is the scenario? This in the pavement final glycemic in case of instead of 630 we have got is two important is produce also can hyper because of I don't species I don't is help which is there is a yes where there is healthy whole community. What we is project diabetic either to the this yes to say can have food sample to a can is not growth There is with lot of things. So here, what we say is negative galactomannan or beta-D about gas, we have started seeing such type of cases. There is abdominal bleed. If there is acidosis, at least GI, what on bloodstream and respiratory fungal infection, what of lapses due to worry issue, real incidence is understand and what case of uncontrolled diabetes inappropriate of the this is also here therapy I like from our long but for to say so often so friends this any
and very Dr. Arun, as per the schedule. So any questions? A very we are thankful. You can please.
Elaborate meeting for infection into such a forum. To the next will be Dr. Paolo Pelosi, talking about the role of these biases in critically ill patients. Yes.
One second, just a question. One question, sir. Dr. Alok. Sir, how to diagnose fungal sepsis in eyes? Almost all new onset.
Is giving a good turnaround time. Expensive neuro. They hardly are using it because really important such test, and it's a repeated test. And this Chennai around which should you have therapy and beta-glucan should, then you can stop the therapy. That's very important because much of the empiric therapy, 50 picogram, then it of Candida sepsis. So that is the only test available, but there are now new platforms are coming up. Hopefully that would be more evaluated in the molecular diagnosis platform that would possibly increase the sensitivity in diagnosis.
Thank you, sir. There was a slight swap in the schedule. So next we have Kelly Dayton speaking about diving into delirium. Can I have the CV slide of Kelly Dayton? Kelly Dayton is famous worldwide for her podcast on walking home from ICU. She is a critical care nurse and she has a forum of critical care people working for her. And her podcast, she tries to inculcate the concept of early mobilization worldwide, not only on ventilated patients, patients on ECMO, neonates, she try to cycle. So over to Kelly Dayton. And the next session will be from Dr. Shikha Panwar on early mobilization. Dr. Paulo's talk will be in the next session. Over to Chairperson, Dr. Kamalpreet. Kelly Dayton talk, please.
Hi, my name is Kaylee Dayton. I'm an ICU nurse practitioner in the United States. I host a podcast and webinar series called Walking Home from the ICU. Much of my expertise and my conviction comes from working in an awake and walking ICU in the state of Utah. Yes, it is exactly how it sounds. Almost every patient on mechanical ventilation is awake and walking, even and especially throughout sepsis, ARDS, and now COVID. I am so excited to be sharing some of my thoughts and information about delirium in the context of sepsis. I'll try to be brief and concise, as I know it's hard for me to narrow down 80 some odd episodes worth of commentary. I think it's really important to call delirium for what it really is, acute brain dysfunction. I think we've all heard the word delirium, but I think our focus really easily goes towards acute kidney injury, certain organ dysfunction that we can actually measure. But I think it would be helpful to call delirium acute brain dysfunction, as that is exactly what's happening. And it presents in different ways with different patients. There's two kinds of delirium. There's hypoactive delirium, which is inattention, confusion, lots of somnolence, apathy, and hyperactive delirium, which is manifested by inattention, confusion, agitation, and delusional thinking. One study showed that out of patients with delirium, about 43.5% had hypoactive delirium, and about 1.6% had only hyperactive delirium. The other 54.1% had a mix, which I'm sure we've all seen, in which patients fluctuate from being hypoactive and hyperactive, and that's incredibly common. Yet, I think what we fail to really recognize in our ICU community is the patient's reality. Patients that are in active delirium are not in the hospital in their brains. As I've interviewed patients, or rather survivors, on the podcast, they've told me about experiences that we on our side would call hallucinations, delusions, misinterpretations of the environment. But to survivors and those actively in delirium in that moment, this is not a dream or a nightmare. These are real kind of reality that they explain to be more real than when we're having this conversation. And the things that they experience are part of reality. So they take little fragments of the environment that they're in, and it gets twisted into something really morbid and horrific and very personal and damaging to the survivors. So they experience kidnapping, rape, abuse. They relive past traumas. I spoke with a survivor when I was on a plane ride. This is the first survivor I'd ever talked to that could actually tell me about what he experienced during delirium. And he tearfully tried to tell me that during his ICU stay 4 years prior, he'd had what he didn't say was delirium, but I knew was delirium. He said that he was trapped in a forest with his limbs nailed to the ground and trees were falling on him and monsters were coming out of the sky and lots of other experiences that he, even 4 years later, could not talk about. So that's what our patients are actually experiencing. To us, sometimes these patients are really hard to manage. They may be combative. They may be very difficult to manage. But when we understand their reality, what they're actually experiencing, they think their kids are kidnapped. They think they're in enemy territory. They think they're handcuffed. They think they're being murdered, mutilated, just the most horrific things. I would hope that that would change how we treat them and the kind of approach that we take to caring for them. We also need to appreciate that after the ICU, delirium is strongly associated with post-ICU PTSD, manifested in depression, anxiety, panic attacks. For example, background, more get and someone in not be you go to instruct gets lost right back into her delivery. Another survivor told me that to go back to the courtroom and would be triggered into a panic attack and be lost. Never. But after the ICU, when he can feel psychology of life opportunity and to define life based impact and so we all causes and shock. This focus have a mobility, avoiding the area. So I'd like to show a real my and walking had PTSD hospital for acute sepsis, alcohol, someone lies in the shock is increasing for her. And position not wake setting 60 so that of risk. Looking at that treat her safe. Some of our safety definitions include keeping them safe from falls, keeping the breathing tube in. But the Awake and Walking ICU also includes safety as far as long term. They knew that she had high risks of developing delirium because she was coming out of alcohol withdrawal and had been deeply sedated for a week. They also knew that her baseline or predisposing factor for post-ICU some unlikely dependence on alcohol and benzodiazepines. And was dementia, weakness. Keep her well. Keep her anonymous. Suppressor on her and really trying to pull out it nice. Did it. We evaluate cannot through it. Right, those true liberating delirium. Had see for pendant as a lamb and turned in him under the ankle. The other that risk continue was like this. That comes eventually moment to then she interact because again practice can you deep and so get our process of care critical illness in order to cover we to traded one sweet fairly takes significant during that and first extremely great this is pod well she's the and that she breathing first time that we start to lyric if someone ends up inside of the really following there often when the conditions are more sedated 14 or and delirium started to and walk the bed that why question less calmer and her and she became for the test too. And she week out of read her she did function and yet survived after the attributed to the care that she received in the awake and walking ICU. She is so grateful that she was allowed to be awake and walking even in her delirium and ARDS and cavitary pneumonia. She was allowed to be human and her future and her long-term outcomes were taken into account. She was to remain in that other. As we practices, even sepsis, we can short. If you're interested in support for your teams to transition your practices and culture, I'd love to help you throughout my webinar and consulting services. Thanks so much.
The novel solutions available. Dr. Shikha. Can we have Dr. Shikha's talk, please? We'll be taking the question.
Afternoon to all of you. Talking about so first of all, allowing me to have a talk in this prestigious conference, and with that, let me just start sharing my screen. And as we have already seen, what are like the benefits and what are the benefits effects of immobility in the ICU. Enhancing on the topic that how we can actually so we have some declaration bits. With that, we move ahead. As we have already seen that because of the care which we are providing with the excellent ICU care, the mortality has actually decreased over the decades, but yes, the morbidity is increasing. So what is happening? We are saving the patients, but are we making them functionally viable? Are they able to go back to their work once they are recovered from the critical illness? So, but actually, as we have already discussed, that more than 50% of these patients, they experience neuromuscular weakness. And critical illness can actually create a kind of wreak havoc on their body. As you see, the norm was to keep the patients completely sedated and paralyzed, but now we realize that that's not good. So we know that there's a severe burden of the critical care illness, which has already been discussed. So moving ahead, so now we know that it's beneficial to mobilize the patient. So what is the early mobilization? Early mobilization is the intensification and the early application as early as within 2 to 5 days of critical illness of the physical therapy that is administered to the critical ill patients. So it also includes additional specific mobilization enhancing interventions such as active mobilizations of the patients requiring mechanical ventilation and the use of novel techniques such as cycle ergometry and transcutaneous electrical muscle stimulation. So all these things, when you combine them, they form a part of early mobilization. So we know the benefits of the early mobilization: reduced ICU-acquired weakness, improved functional recovery of the patient, reduced length of hospital stay. So these all things are the benefits of early mobilization. Yes, we are aware that mobilization is good for patients and we should be doing mobilization. But the question is, are we doing enough mobility? So let's see what the studies have to say regarding that. As you can see, this is one study which was done by Barnett et al. And was published in Critical Care Resuscitation Journal. And as you see, they analyzed total 130 patients. And out of these 130 patients, if you see that, yes, in-bed exercise was done for most of the patients, around 111. Around 128 patients were made to sit out of bed. But if you see that we were very reluctant to have them walk around. So it's less than 50% of the patients were walking, and around more than 50% were able to stand. So do you think this is good parameter? Maybe not after this. None of these patients were mechanically ventilated. So as you can see, these patients are not even as sick, but still we are very reluctant to have our patient moving around in the ICU. So this is one thing which is there, definitely there. Now coming to the more sicker patients, let's see what's happening there. If you see now in this study, which was published by Nidat et al. In Critical Care Medicine in 2013, what they did, they studied around 775 patients, and in which around 401 were having endotracheal intubation. So around that, if you see, the remaining in bed is around 92% of the patients. So we are actually not hardly moving any patients who are having endotracheal tube in place. Even if they might not be very sick, maybe they are not on vasopressors, maybe they are conscious, but still they stay in bed. So this is one thing. This is one thing we really need to see, that why is this happening? So is this a universal practice? But I did some more research and found certain publications which are saying otherwise. So mobilization practices in the ICU, a nationwide one-day point prevalence study in Brazil. So in this, they studied around 26 ICUs. In point prevalence, they collect the data over a certain point of time, and then they analyze the data. So in this study, what they found out, in 26 participating ICUs, in 358 patients were included in the study, And they found out that 87.4% of the patients, they were actually mobilized. So activity was performed in these patients. Even if the patients, they were under invasive mechanical ventilation, those on NIV or those without any ventilator support, they were mobilizing their patients. So this percentage is pretty high. So now the question is, if they can, so can we. So that's most important, that we really need to do. We really need to achieve those targets. But now the question comes, how? How can we do that? So that's the question. So most important thing is by removing the barriers, because we all know that yes, the patient has to be mobilized, but then there are certain concerns which come in place. So many times we think about the patient's safety. So many times there are other patient factors, then there are team conflicts, and last but not the least, there's organizational issues. So let's see what are these barriers and how we can remove these barriers so that we can move the barriers. And so most important things are patient. He's like, he feels in the bed. Sometimes GCS delirium. So these are all the patient factors. So now what to do about these? As we have been A, B, C, we applied now. This is the liberation from in this is awakening trials, that you have to stop sedation every day, and you have to awaken your patient daily. So this is the most important thing, because if your patient is sleeping, obviously you can't do anything. He'll just keep on sleeping, and nothing, no progress is going to occur. So you have to give spontaneous awakening trial, then you have to give spontaneous breathing trial to your patient. You have to have protocolized weaning trial, trial, which should be protocol driven, that yes, this is the fixed protocol, this has to happen. Then apart from that, C is choice of sedatives and the coordination of awakening and breathing trials. D, delirium. So take care of the delirium. Make sure your patient sleeps well at night. And then, there are certain other things which we can try to, have the day and night orientation of the patient. We can use other devices, to stimulate the patient so that he's not in a delirium state. And we can, and E is early mobility, and F is for the family involvement. That we should actually involve family. This is something which I find like many places, most of the places we really avoid the families. So these are the things. So if we do this A, B, C, D, E, and F, we can actually take care of the patient factor. So sometimes what happens, coordination in the team, there is lack of communication. So some people may actually mobilize the patient who's intubated and ventilator. It's a lot of work. And yes, it is exactly a lot of work, but then it has to be done. So that thing has to be done, and the things have to be done in such a way that it doesn't feel a lot of burden. Maybe the staff is not experienced, there's poor leadership, and might be the last but not the least, the work culture is poor. So what you have to do here, you have to do some team building exercises. You have to see what is the apprehension, what are the issues, and you have to try to solve them. So because the team means that only together everyone achieves more. So that's what we have to do here. Lastly, we have the organizational factors. Maybe the organization is not ready to give the funds to buy the proper equipment, because I think in today's era, without proper equipment, mobilizing the patients out of the bed is really a Herculean task, because when you have so many things available and the better things, I think we should go opt for those things. Then time constraints, lack of equipment, lack of staffing, and busy caseloads. So for these things, to remove these factors, we can have a patient is, if you this equipment faster, patients heal faster, they move out of the ICU faster. So the short-sightedness can be improved here. And then you can make a mobility team. This mobility team can be a group of nurses or the physiotherapists, so that the burden is actually everything. That yes, if I move my, and serve the physicians really major. It's going to be. Let's see the true studies. Alien colleagues in 2007, they published a prospective observational study of 103 patients, and what they found out that the adverse events, they were like very less. So and there was systolic blood pressure, and one patient comes and increase the probability discharge early. More serious adverse. So if you yes, when you are none of them are take care of them. So now what? Let's take our patients out. And as you can see, I am showing you certain pictures. And these are the pictures of my past patients, which have been like who was quite. There's no joy. This is the best joy when he used to go out in the chair every day. We used to make him sit out in the balcony and all. So, he really used to enjoy this thing. This is again one quadriplegic boy and who suffered with injury. So these are the patients which are really finding, which are actually, mobilization actually helps them. So coming to now how to do stepwise. So now we will be taking it in two steps. First, we will identify the level of our patient. So we'll divide it into level 1, 2, 3, 4, and 5, and what equipment we should use at what level. So coming to the level 1, so these are the sickest of the patients, and these are basically most of them are intubated, ventilated, who are having a poor sensorium, and their FiO2 requirement is high, and their PEEP requirement is high, and they might be on vasopressors. So these are the level 1 patients, and these patients actually, for these patients, you have to do in-bed exercise, and obviously you them. And basically, the intensivist should be deciding what exercises they need, and accordingly, they should be treated. Coming to the level 2 patients, they are conscious, but they cannot move. Level 3 patients, they can move their arm against gravity. Level 4 patients, level 5 patients. So they're actually the level 1. Yes, can do is so patient be conscious. So for them, you have to do the same thing every and position. We can do a minimum 20 minutes. Sit. Coming to the level 3, the one who can passive along with the bed. So this is one thing. When they start moving their leg against gravity, we can transfer them to chair, out of bed mobilization, and then along with that, we can do the mobility team can take them out for 20. Should be equipment. So what equipment? Mobility level. Obviously, we need a lot of dependent equipment. We need a sling to. And, if you want to make the patient sit out of bed. Coming to the mobility level, again, from sitting position because they don't have power. So we need a mechanical sit to stand. Depend to the now, they can use non-powered stand aid. Walker, cane, crutches, these are the devices they can use. Coming to the mobility level 4, these are quite independent. They have power in legs also. So we just need to have the safety checks, maybe an harness and, a belt which can just hold them while they're walking. So these are the kind of equipment they need. So again, dividing them for level 1, we need ceiling lift, mobile lift, chair sling, and the roller board. For level 2, we need ceiling lift, mobile lift, chair sling, power sit to stand lift, friction reducing roller board. Level 3, we need the gait belt, walker, cane, sit to stand devices, walker harness, lift, and crutches. Level 4, just we have to say for that call, don't fall. They are quite independent. So as you can see, this is a ceiling lift, in which you can the patient can be lifted up nicely, and it is attached to the ceiling. That is why it is known as a ceiling lift. Then this is was for level 1. When the patient becomes level 2, you can use some of equipments like this kind of equipments in which you can support the knees, and these are the handles to give the hand grip, and the patient is supported by a sling. So he can actually take and, from sitting position, he can try to raise up. So then coming to the other things which we have, like we have these gait belts are there, walking harnesses there, crutches are there. So all these things can be used to actually make the patient mobile. So now, since the technology is getting advanced, we have really very new beds and chairs which are coming up in market. And so if you see this amazing bed, and in which the patient can actually, while the patient is in bed itself, you can make the patient sit. Your patient to stand, you can, with the help of this, stand up. So as you can see, this bed has got tilt functions, foot lifter, and this is how it actually, if you have a, so, but yes, if we can do. So this is pictures from my previous institute. So this was a makeshift chair which was there, and so it's like not very expensive one. So you can use such kind of things, but yes, do something, have something for your patients, make them mobile. So this is a chair which is there, and as you can see, these are the side rails. Once you position the patient, you can put the side rails, and as you can see, this is here for the foot support. And if your patient is not this active and your patient is slightly, if the level is not this level, level 3, if it's level 2, if you can see, this is a handle here. You can actually unlock it, and it becomes like the angle actually decreases. So these are certain things which can be done. So this is one video, and in which I can show you simple things, mobilizing the patient with very simple things. And you can see this is the patient when he's going out, he's feeling like, really satisfied with the mobility. So you don't need very high equipment, as you can see. I am just using a Bain circuit there. So just try to do something, make your local protocols and make your local stuff and equipment, whatever is available with you, but you take care of patient safety also. So this is one thing. Coming to the last slide, and that is the take-home message, which is very important. I've been talking for last, I think, 15 minutes or so, but we really need to find the important things. The current evidence, it suggests that early mobilization is safe and feasible and may improve functional recovery at hospital discharge. However, ICUs are still very conservative in mobilizing mechanically ventilated patients with some potentially avoidable barriers. So what I can say is just make a protocol, remove all the barriers, discuss with your caregivers that this needs to be done, and make a mobility team, and let's move them. That's what we have to do. Coming to an interdisciplinary communication and a clinical lead or champion, you can identify the champion. It need necessarily not be the IT doctor. It can be who wants to do these things. If you do all that, I think it will really help. And last but not the least, proper equipment. Because in this era, if you see now the nurse, she's trying to pull this heavy patient, but she's cracking her own bone. So please don't do that. Make their life easier. Buy whatever equipment you think is good for your ICU, and go ahead with that. With this, I would like to say thanks to all of you for your patient listening. And again, I would like to thank the organizers for inviting me. Thank you.
You, Dr. Shikha, task of mobilizing our ICU patients. I think it could not be done in a more simpler way. Thank you so much. Now we are open for You can put the questions in the chat box. I'd all do so.
Any questions from the? Yeah, we have 2 minutes. Always said if a life is however critical to think about early and Shikha, how can local solutions be taken? And he showed high-tech equipment also, very costly, which are ready to help cost options in India. Yeah. Other questions, Dr. Kamalpreet?
We can close the session. For such a wonderful talk. Thank you so much.
Thank you, Dr. Kaval. We move on to the next session. We have Dr. Pradeep Bhattacharya. Dr. Pradeep Bhattacharya as the chairperson for this talk. Dr. Pradeep Bhattacharya is head of critical care medicine at RIMS Ranchi. He is vice chancellor of Indian College of Critical Care Medicine. He has been vice president of Indian Society of Critical Care Medicine. We also have Dr. Prashant Saxena with us, a very dear friend of mine. He is director and head pulmonology and sleep medicine at Max Smart Hospital, Saket, and he is a very, very thorough clinician. His both are very chairpersons. Session in this will the previous session as Dr.
First,
Dr. Paulo.
Madhusudan. Achha. What is this topic? I couldn't see that topic.
Yeah. Dr. Paulo will be talking about COVID-19. Dr. Paulo and intensity of hemodynamics. He needs to know University of Geneva. Follows. Yeah.
May I request? Please.
Welcome to everybody. Today I will talk about hemodynamics in a critically ill COVID-19 patient. I have no conflict of interest in the lecture. SARS-CoV-2 organ impact. In fact, we know that not only the lung is affected, but also other organs, including the brain, the kidney, the gut, and the liver. Also, great importance is related to the heart. And this is a tip in the intensive care unit, with full support from respiratory system by a different and renal support case support. Also echography evaluations. We performed a model evaluating the comorbidities and cardiovascular therapies effects on COVID-19 mortality. What we increase in the number of comorbidities was associated with an increased risk of death. Also, the hypertension medication, and in particular, diuretics and calcium antagonists, with a significant other older than 65, while excurrence movement risk of death. Among different factors, we also found that previous cardiomyopathy was associated with an almost twofold increase in the risk of death, as well as the presence of hypertension in the anamnesis. Among more than 300 patients aged 71 years old, the main complication during hospitalization and outcome were related to the RDS development and the use of non-invasive mechanical ventilation and ICU admission. Few patients presented septic shock or CRRT at ICU admission. The ICU length of stay as well as the hospital length of stay was quite long, while in-hospital mortality was high, around 40%. Among risk factors associated with hospital survival were the presence of inflammation, so higher interleukin-6, higher risk to die in the hospital, almost 4.4 times more risk when patient developed RD, same odds ratio, but most importantly, again, in the presence of heart of dying in the hospital was more, at a lower level as compared to inflammation. RDS development of heart disease was associated with increased risk of death. Further, the age was very much related to the survival or mortality probability. And as you can see here, survival probability was much lower when patients were older than 80, and the survival probability was around 50% in patients aged between 70 to 80. So we can conclude from here that patients with heart disease and older patients, mainly those older than 75 years, are at high risk of dying in COVID-19 pneumonia. We look at the effects of higher cardiac troponin at hospital admittance, and as you can see, the troponin higher than 0.05 microgram per liter increase. So we believe might be a factor related to survival. In this study, different responders from different geographical areas in the world were asked the main hemodynamic monitoring and management in COVID-19 patients admitted to intensive care. And the different responses were separated in the very frequent use, infrequent, or rare. As you can see here, almost 56% of the responders are using vasopressors in a very frequent or frequent way. Inotrope was much lower, less than 1 to 3%, and the use of almost 50%. In echocardiographic findings were almost normal of the patients, while with hyperkinetic function in 53% due to hyper or right ventricular dilatation. The fluid response unit was predicted mainly by use of echo and less frequently by use of pulse pressure variation or leg rising, while the stroke volume variation of other methods were used. The cardiac cathode was measured and monitored mainly by echo again, while other methods were less used, even if methods with transdissolution were used in almost 43% of the cases. The SVO2 was mainly measured by the CBC sample, while other methods were used very rarely. Another very recent study confirmed our results, showing that almost 66% of patients with COVID require a vasopressor therapy, with some difference between. Look at the used to monitoring of fluid again that echo was used of coagulation for blood. Mostly confirmed also in terms of North America, where only were a little bit used less frequently radial catheterization, as well as in South America, where, however, the use of echo was a little bit less than in North America and Europe. And again, the radial catheterization was used less frequently as in Europe. So we have to consider a hard and different and the situation from home, out of hospital, in emergency, and in intensive care might be considered. One of the major issues, not only in perioperative, but also in critical patient in general, is to balance the possible effects of hypovolemia and hypervolemia with altered tissue perfusion, renal failure, possible anastomotic breakdown, confusion, and splanchnic ischemia and multiple organ failure if hypovolemia occurs, but very similarly also in terms of hypervolemia. So we have to find a system to monitor adequately the volemic status in order to optimize it. There are three factors that are efficient: flow and flow adequacy. Then we can optimize and personalize treatment by using fluids, inotropes, or vasoactive drugs. These are the different components related to oxygen delivery and oxygen consumption. We know that we have oxygen uptake and oxygen transport and other in terms of oxygen. The SVO2 or SCO2 and lactate are metabolic indices of the balance between oxygen delivery and oxygen consumption. Oxygen delivery, which trait related to the preload possible presence of pulmonary edema and extravascular water. Other factors influencing the stroke volume are the afterload and the systemic vascular resistance, as well as the contractility. Among the arterial oxygen content, which is the other factors associated with cardiac delivery, is the oxygen level of hemoglobin. Of course, all these factors might be treated, individualized, and personalized according to the vasopressors, eventually transfusions. Simplest pulse pressure is the difference in diastolic pressure. arterial pressure below 9. The stroke on the other side, a low below 40 millimeters of mercury suggests that the vascular tone is low. A low pulse pressure, 30, 40 millimeters of mercury, stroke volume. So mean arterial pressure less than 75 millimeters of mercury might increase the risk of complication of 12%, less than 65 millimeters of mercury, around 55 millimeters of mercury, 30%. So these four pressure values may provide extremely useful information. The monitoring of preload is very important. And this is the relationship of stroke volume and ventricular preload in the normal heart and failure. Here, associating. If we consider the ventricular preload alone to predict possible, you see that the increase in ventricular preload is associated with an increase in stroke volume, which is minimal increase in case of failing heart. So assessing the preload is not assessing the preload responsiveness. And the static measures of preload cannot reliably predict fluid responsiveness. The central venous pressure does not predict fluid responsiveness. And we know that the summary OC curve for these parameters is around 0.56. So this means that predicting fluid responsiveness through the use of CVP is like to drop a coin. However, central venous pressure does not predict fluid responsiveness, but we have to consider between right ventricular volume and again, this might be associated with the correlation between the stroke volume and the right ventricular volume. So, in other terms, variation in CVP, and not the absolute value of CVP, might reflect preload unresponsiveness. Fluid to be considered a possible parameter preload variable per se. However, CVP during is in CVP other dynamic parameters have been investigated for polemic monitoring. Inspiration, as you can see here, we have volume through the left half. We have an increase. That during continuous variation of pressure, and this might be in the stroke volume. And thus, we can predict and use this variation of pressure by using the variation in stroke volume induced by differentiation in pressure by mechanical ventilation in the preload responsiveness and in preload unresponsiveness. And this is mainly characterized by PLU-PV. There are different parameters that might be considered, so the systolic pressure maximal or minimal, and the differentiation between the both two, you can see is called the pulse pressure. Also, the stroke volume might be higher or lower according to the cycle in inspiration or expiration, and the variation is another important parameter. You see from the formula that SPV is SP maximum, SP mean. PPV is PP maximum minus PP mean divided the SVV mean divided, and the threshold are respectively -5 or -13% or -10%. The different IOC response for these different techniques are shown in this slide. And you see that most sensitive and specific is the PPV, and also SVV at a little bit less. Other parameters like the global end-diastolic volume index or CVP are much, much less accurate. If you look at this clinical scenario, we know that, for example, the ratio between lower than 3.6 may be associated with major false negative. The presence of arrhythmias might be associated with false parameter. In presence of lower tidal volume, again, we can have false negative. The abdominal hypertension with false positive. Open thorax, this is mainly related for surgery, is associated with false negative, and spontaneous ventilation markedly affects the interpretation of dynamic variables. The different thresholds are for pulse pressure variation, around 12%, stroke volume variation, 12%, the diameter of inferior, 12%, vena cavity, the passive lag rising, and we will discuss these parameters shortly, is 10%. The end-diastole occlusion test is around 5%, while the fluid challenge at 500 milliliters in terms of change of cardiac output, the threshold is around 15%. So different threshold for different parameters used for functional hemodynamic. This is for fluid administration from acute respiratory failure with evident or not fluid loss or early phase of sepsis. In case of yes, fluid administration. In case of no, we have to evaluate the presence of spontaneous breathing, cardiac arrhythmias, or low tidal volume and low lung compliance. If these are present, it is suggested to use passive lung test, end-diastole occlusion test, or mini fluid challenge. If they are not present, so during control mechanical ventilation with higher tidal volume eventually, or absence of cardiac arrhythmia, stroke volume restoration, again the passive leg rising, end-diastole occlusion, and mini fluid challenge. The end-diastole occlusion test is a very interesting system to evaluate the preload in our patients, and this is due to the fact that we have a cyclic decrease in the preload, and when we have a occlusion at end expiration, we have a transient increase in the preload, and so in cardiac output, in case, of course, of responsiveness. And so fluid responsiveness should be identified by an increase in the cardiac output during end-diastole 5%. This is also a flow chart that has been suggested for non-intubated COVID-19 patients, again related to the level of perfusion and the presence of shock. And it's suggested to use passive lag raising as a first maneuver, echocardiography evaluation with presence of A-line or no presence of A-line, different others methods of analysis. However, the passive lag raisings has risen its importance in the last years, and the rationale is that we have a change in the intrathoracic volume passively by the use of lag raising itself. and not by administration from outside of additional fluids. So PLR mimics a fluids challenge, but unlike the fluid challenge, no fluids are infused and the effects are promptly reversible and transient. So the hemodynamic response to PLR can predict the hemodynamic response to volume infusion. Performed as shown here, and very importantly, we have to remember that we have to use the bed adjustment and avoid to touch the patients. And further, we have to measure very accurately the cardiac output. So the maneuver is not so easy to be performed at the bedside in a routine maneuver. We performed a recent study by looking at passive leg raising effect, fluid challenge, and norepinephrine in COVID-19 patients. And we were particularly interested in patients. You see here that the passive leg raising markedly reduced the cerebral autoregulation, while the use of fluid challenge was less relevant in this setting, but the use of noradrenaline was the most important to preserve hemodynamics by minimizing possible inevitable effects on cerebral autoregulation. So our suggestion from this and other studies from our team was that we should not routinely use passive leg raising for intubated patients with measurement is extremely important. And we believe that we should use the calibrated system, particularly in patients admitted to intensive care, because this might allow to measure the preload by PPV or SVV and the output, an important measurement of the lung. And water according to the. And so if we increase the volume expansion extensively, especially in patients with very high permeability, this might be associated with a major increase in extravascular water. And different decisional algorithms have been proposed by using intrathoracic blood volume index, cardiac index, and extravascular water index with different actions. A study by the French team showed that COVID-19 RDS patients might be characterized by higher extravascular water than non-COVID RDS patients. However, as you can see here, the difference was minimal. This is in contrast with our studies performed by CT scan and looking at the overall lung. This is the lung weight in the normal lungs, which is around 800 grams. In traditional RDS, we found the lung weight is around 1 kilo 800 grams. So with an excess tissue mass of around 1 kilo, which is equivalent to around 125% compared to the normal lungs. We individualized two different phenotypes in COVID-19. The so-called phenotype 1, which responds very well to non-invasive rescue treatment, in which the average lung weight is around 1 kilo and 100 grams, with an excess tissue of around 300 grams, which is an equivalent of 37% higher as compared to normal lungs. Then we identified a second phenotypes of patients which require immediate and lung weight is around 1 with an average excess tissue mass of which is equivalent of. So the excess tissue is higher and in getting tissue to edema out of recruitment. To better interpret and estimate the pathophysiology of the increased tissue mass, we performed another study in which we look at the effects of different level of PEEP from 8 to 16 on potential alveolar recruitment. And as you can see here, most of COVID-19 patients are not recruitable patients. And the alveolar recruitment was equivalent to 2.7% of the total lung in a total alveolar recruitment of around 39 grams. This suggests that there is poor alveolar recruitment in COVID-19 patients in both less and more severe cases. And most importantly, the excess tissue mass is equivalent to the recruitment tissue is equivalent to only 3% of the excess tissue mass. So means that the excess tissue mass is not due to lysis and with possible. Differently from which the recruitable tissue is equivalent to so a completely different pathophysiology in the excess tissue mass in traditional RDS, which is due to edema and further atelectasis, and COVID-19 patient, and particularly in phenotype 2, with pneumolysis, vascular lysis, and alveolar consolidation. There are other systems that were quite extensively used in COVID-19 patients, like uncalibrated system, which might allow of preload and data with, and also possible flexibility from calibrated to non-calibrated system, as well as other uncalibrated systems with no preload data, which takes into account the area under the systolic part of the arterial pressure curve and the mean arterial pressure, with no need of any calibration or adjustment based or using instrumentation. Other devices investigatively track changes in arterial pressure from finger probes, and early hemodynamic intervention is possible, and more invasive monitoring modalities are not really available. And this might also be used, especially when patients are monitored outside the ICU. The Doppler echocardiography examination for cardiac artery and cardiac chambers for preload is another important method that I showed you that was extensively used outside and in the ICU COVID-19 patients. Remembering that by using the LVOT area and the velocity time integral, we can have a measurement of the stroke volume. It's very important that the LVO2 area is directly measured and not calculated a priori. The flow adequacy is also very important, and remember that at least 3 parameters has to be always evaluated: the SCVO2, the PVO2, CO2 minus PSCO2, so the PCO2 gap, and the amount of lactate. When SCO2 is below 70%, or the PCO2 gap is above 6 to 8 mmHg, and lactate is above 2 to 4 milliequivalent per liter, we have to take care that the flow adequacy is likely not optimized. Just at the end of my talk, I want to propose you to very recent. This is the possible use of metoprolol in a limited number to reduce the as now We also with a oxygenation. However, and the enrolled, there were no clear significant and ventilation. Another important issue to be considered is the acute pulmonary embolism. Our study, very selective cases might be helpful to improve hemodynamic and rescue function. But this should be carefully performed, discussion and clear evaluation for accuracy. So to patients, important risk factor for happening is an important biological marker of admission. Hemodynamic in patients, invasive mechanical ventilation, preload weighted always at the bed. Hemodynamic monitoring is so very important both outside and inside the ICU, and local guidelines for hemodynamic monitoring as well as treatment are strongly recommended and should be adapted to local organization. Thank you very much.
Thank you, Dr. Pelosi, for your talk. May I request Dr. Prashant Saxena to invite the next speaker?
Yeah, thank you, Yash. And it's a wonderful experience sharing the thoughts of such eminent speakers and excellent presentation by Dr. Paulo. I would like to invite the next speaker, Dr. Himanshu Diwan, a dear friend and colleague. And he's going to speak on a very important topic, which is COVID-associated pulmonary aspergillosis. And I believe this is such an important entity, and he should be able to highlight the key important issues we face on a day-to-day basis regarding this problem. Over to you, Himanshu.
Recording, please.
Hi, everyone. Share my thoughts on COVID-associated pulmonary aspergillosis. So, in the past couple of years that we have managing these flu epidemics, starting with and then now COVID, we have seen 2 waves in India. What we have learned is that post these viral pneumonias, sometimes alongside these viral pneumonias, we see a very high incidence of secondary bacterial infections. Now, these secondary bacterial or secondary fungal infections that we see very often, one of them being the direct damage to the epithelium because of the virus, or the dysregulated immunity during these infections. And more so in COVID, it could be partially because of the high use of high-dose steroids to treat COVID pneumonias. Now, or it could be a combination of these three. But one thing is for sure that with the pneumonias, we see invasive what to highlight is and manage very clear-cut situations. You may not have all diagnosis proven, and you might have to cut some cost. Let's start with the case.
Recording stopped. Recording in progress.
A week it had become better with his hypoxia, his cough, his fever settling down. But then on day 8 or 9 of his illness, he started again having fever. He started getting progressively short of breath with cough, with some phlegm. By the time we got him, he was febrile, he was normotensive, needs around 8 liters of oxygen by a face mask. He had a noisy chest, diffuse wheeze and crackles all over. At this point in time, he was on steroids and a broad spectrum antibiotic. A CT scan done 2 days prior to the admission at our hospital showed a CT score of 17/25. And this is his X-ray on day of admission. You can see that he's got bilateral infiltrates and possibly 2 cavities developing on each side of the lung. As he was ending or almost ending his second week of his COVID journey, the number one possibility for his current worsening of respiratory status was a very high likelihood of a secondary chest infection, which could have been very, very bacterial or fungal. As these patients tend to have a very high D-dimer, very high thrombotic load, we thought this pulmonary embolism is a decent possibility. Patients tend to have cardiac worsening in the second, third week. A lot of patients, even though they're not on any NIV or invasive ventilation, by spontaneous breathing, end up having barotrauma. So that could have been a possibility. But then on the X-ray, we could not see any major evidence of barotrauma in such patient in this particular patient. In a lot of patients, we thought we see very often that you have a dysregulated hyperinflammation, which actually, initially gets better with steroid, then again gets worse, and then continues to get worse by the second, third, and fourth week. This is not a possibility. So with these 4 possibilities in mind, we progressed. We did his initial labs. What we could see is that he's got leukocytosis. But very importantly, what we could see is that he's got severe and marked lymphopenia. Uncontrolled blood sugars with an HbA1c of 9.29. He was not a known diabetic. So possibly the uncontrolled sugars along with the steroids were playing a role. High CRP, a high IL-6, decently high D-dimers. His initial cardiac evaluation showed that he's got a normal cardiac ejection fraction. His filling pressures were normal. His cardiac enzymes were normal. His sputum culture actually showed carbapenem-resistant Pseudomonas aeruginosa. And on these stains, we did not have any evidence of tuberculosis or fungus or any other organism. So at this point in time, we thought, why not image him? And we went in for a contrast CT with a pulmonary angiogram. The pulmonary angiogram was normal. And when we saw the CT scan, you could see that, both the sides, you got typical COVID features with ground glass haziness, interlobular thickening, 2 consolidation. The bigger one on the right side has got a breakdown in the middle, a cavity developing. And on the left side, we saw a consolidation with a fleshy material inside the cavity that was developing and air around the cavity, something like a crescent sign that we see in some fungal infections. And at this point in time, we were still battling in our mind between a secondary bacterial or a fungal infection. And we were, as we are in India, we always think of reactive tuberculosis in such patients. So that is where we were at this point in time. His cultures, blood and urine, came out to be sterile. The fungal evaluation gave us negative. Was not do any reasons, as you could understand, the infection control issues. You have a hypoxic patient. The family was very concerned about doing anything invasive and making it work. Needing or post bronchoscopy, so we were not allowed to do. With this data, at this point in time, sterile culture, some evidence in a carbapenem-resistant Pseudomonas aeruginosa and a positive galactomannan, we thought we have enough evidence to say that we could treat this patient with an antibiotic and possibly put him on an antifungal, realizing very much that this galactomannan may not be a true reflection of the invasive fungal infection, but the radiology was more suggestive. So we thought we'll start this gentleman on voriconazole, treatment with voriconazole. Now, at this point in time, we also thought of devising ourselves that how do we normally see pulmonary aspergillosis in ICU? So we have basically 2 varieties that we see. One is where you have angio-invasive. It is where you do not have any angio invasion. So of course, when you would have an angio invasion, that would be a patient who's markedly immunocompromised. So you see it very often, if you just go to the left of my slide, patient with prolonged and profound neutropenia. As there is a component of angio invasion and cognitive necrosis and hemorrhage to worsen much in patient side. And inflammatory necrosis tend to get, and you see it very common in stem cells transplant recipients. The other variety of aspergillosis that we see in practice would be with no angio invasion, and the hyphae are confined cavities and pre-existing lung diseases, patients such as COPD. These might harbor these fungal hyphae for years before becoming symptomatic or seeking treatment.
Recording
so
stopped.
These are broadly 3 types.
Recording in progress.
And in ascending order of duration, and possibly the angio-invasive form being more virulent and the high likelihood of such patient landing up in ICU. The gold standard to document or demonstrate invasive fungal infection would be to show that the fungus is there in the tissue. And if you take a biopsy from such patients, and this particular biopsy, as you can see, that you have typical branching septi hyphae, suggestive aspergillosis invading the mucosa as well as invading the blood vessels, and such that will seem to have clots in them. And these are the reasons for the necrotic inflammation that you see in radiodiagnostics can be varied. This could vary from a near normal CT scan and X-ray where you just have a high degree of suspicion and no radiology support, or you could have a full-blown radiological nodules, necrosis in the consolidation, a halo sign around the nodule, so forth. To aspergillosis. In case of our patient, COVID, as the COVID progressed, he and necrosis in the consolidation, possibility of. Now, this algorithm is what we normally do. It is not particular to COVID patients. So we have a thought that this patient could have invasive aspergillosis. If the chest X-ray is normal, we order CT scan. The CT scan at times is normal, and with the normal CT scan, you have an option of giving empirical mold-active antifungal therapy, or you have the option of repeating the scan a little later. If the scan now shows you focal infiltrator nodules and things suggestive of some invasive infection in the chest, you are obliged to send microbiological samples of sputum for bacteria and fungus. You are okay to do a serum lactomannan assay, serum beta-glucan assay, and at this point in time, you're okay to consider empirical antifungal therapy, and voriconazole might be a good choice for fungal infections. If the sputum culture is positive aspergillosis, or you have a positive lactomannan assay, this both gives you a diagnosis of a probable invasive pulmonary aspergillosis, a probability that is invasive pulmonary aspergillosis, because you may not have invasion and may still have aspergillus positive in culture. So that is where we are. It is a decent level of evidence, and you're okay to treat with antifungals. If you are negative for lactomannan and positive for beta-D-glucan, now that's a tricky situation, and that is where we will see in the next slide how we proceed. If your cultures and serum lactomannan assays and serum beta-D-glucan are all negative, so you have no evidence whatsoever to show that there's a possibility of invasive fungal infection, then you might have to go more invasive, do a bronchoscopic guided sampling and a biopsy and try to prove your diagnosis. But as you can understand in COVID, going invasive a lot of times with a bronchoscope is not a feasible choice. You have infection control issues in patients. You have patients who are worsening. You might have to tube them, and a lot of people are not patient on key in of invasive sampling in such patients. So the current guidelines for COVID are suggestive of these 3 categories now. So previously, for invasive pulmonary aspergillosis, you either had a proven category
recording
or a probable
stopped.
category. You did not have this
Recording
third
in
category,
progress.
possible category of invasive pulmonary aspergillosis or kappa in the setting of COVID. So what happens is all 3 categories tend to have the right clinical features and the radiodiagnostics which are supportive of a diagnosis of kappa. But in all the 3 categories, you have different levels of proof, a microbiological or a histopathological proof, to prove your diagnosis of kappa. So starting with the highest level of evidence for kappa would be a patient who's got the right clinical factors. That basically means that you have a COVID patient who is either or he's persistently febrile with persistent worsening of respiratory failure. He's got hemoptysis. You starting getting pleural rub in his chest. So you have clinical features suggested that this patient continues to worsen in COVID. So the clinical factors are there. Then you do a radiological test in the form of CT scan where you can demonstrate that the chest findings are getting worse in the form of worsening consolidation on the chest. So anything that actually fits in with the diagnosis of invasive fungal infection. And the best would be that you took a sample and you were able to show this in the tissue and with a possible invasion of the fungus into the blood vessels. So this would be the highest level of evidence. This may be supplemented with a positive culture or a PCR. But just a biopsy showing invasion makes a diagnosis of proven aspergillosis. The second lower category, all the clinical factors that I have previously mentioned, you have supportive imaging findings, but here you have the advantage of doing bronchoscopic sampling. With the bronchoscopic sampling, if you're able to show that there's a fungal stain of aspergillus, any combination of these, then with the help of this invasive sample, your level diagnosis becomes slightly higher and you have a probable diagnosis of kappa, COVID-associated pulmonary aspergillosis. Now, as you could understand in our case and in a lot of COVID cases, you do not have the possibility of invasive bronchoscopic sampling. So here, this third category gives you non-fiber optic bronchoscopy lavage that can be done easily in an intubated patient. And here, if you are able to demonstrate the similar findings of microbiological proof in the form of a stain, a culture, a galactomannan, any combination of these, you are okay to proceed with the presumptive diagnosis of aspergillosis, a possible diagnosis of kappa, and treat the patient till the time you are able to go invasive and further get a further to diagnose this. Once you have rises in, have to treat such patient upon your, which is more in tune with fungal elements being azole sensitive, then the choice is pretty obvious. You would like to go with voriconazole. Now, the voriconazole in a critically ill patient, especially in the setting of COVID ARDS, has got some drawbacks. So, voriconazole is notorious for drug-drug interactions. And the biggest drug that interacts is with remdesivir. So, if you're giving voriconazole with remdesivir, that would create a challenge. Now, voriconazole again it has a narrow level of safety, so it needs therapeutic drug monitoring. And most of the centers where we work do not have this privilege. So using voriconazole has got its pharmacokinetic disadvantages. And this is where isovakinazole scores over voriconazole. Now, the problem with isovakinazole is it has lesser drug-drug interactions. It doesn't need therapeutic drug monitoring, but the availability of this drug is an issue with us. So if go with voriconazole, and if I have the possibility of having enough availability isovakinazole, I might have that as a choice. Now, if you have given your patient as an azole and this patient continues to worsen or he is not improving, then you might have to escalate your patient to amphotericin B. And what amphotericin B? A liposomal variant of amphotericin B to decrease the potential of nephrotoxicity in COVID patients. Because as you know, that COVID virus itself is nephrotoxic. And if you add a drug over it, you might create further problems. In areas where you have more azole resistance, then your use of voriconazole or isovakinazole might lead to treatment failures. Here you might use echinocandins along with azoles as a salvage therapy. Or if you have a higher level of evidence, you have less possibility of with lipo, and of course follow the pulmonary function, the renal function for such patients. Now these are the doses that we use in such patients. Voriconazole would be like 6 milligram per kg twice a day on day 1, and then you get down to 4 milligram per kg from day 2 onwards. All the doses I won't go through, but basically what I'm trying to do is you should try to use the maximum recommended dose if possible in any particular patient, the maximum recommended dose in any particular patient rather than going for the lower dose. Now, in our case, we started treating this patient in the second week of his COVID illness with voriconazole, but the patient continued to worsen. And if you can look at his x-rays, his infiltrates are getting worse. He tend to have more leukocytosis. His repeated cultures were coming negative. He had a rising procalcitonin. So at this point in time, we did escalate his antibiotics and we escalated from voriconazole to liposomal amphotericin. Now the patient on day 10 with us got intubated and ventilated. Though we understood that this is third week of the illness and he was getting worse, we had refractory hypoxia. We gave him 2 sessions of toning. We did not have much variable. His tracheal secretions, even on day 10 of admissions, did not reveal any fungal element. So there were no positive cultures or stains on the tracheal secretions during the stay with us. He went on to develop barotrauma. We put in a chest tube and that actually complicated with a bronchopleural fistula. And he kept on worsening on his hemodynamics and respiratory parameters. Later on, we actually did an echo. We saw that his right-sided pressures are going up from a baseline where we measured on admission. He had rising D-dimers to more than 5,000. He had S1Q3 T3 pattern on his ECG. Now, the reason to mention it here is in a lot of COVID patients who are refractorily hypoxic on ventilator, you see these abnormally high and rapidly rising right-sided pressures with high D-dimers. So you really don't know that is this pulmonary embolism because of high clot load, or is it pulmonary vasoconstriction due to the hypoxia in the chest along with the positive pressure ventilation. And a lot of time you would be tempted to be taken on case-by-case basis. So this case basically highlighted the difficulties that you have, 1 in suspecting kappa, 2 in diagnosing kappa, and 3 of kappa. How do we go about it? COVID starts to worsen. You should think of a secondary infection, aspergillus or any invasive fungal infection. This is more common in patients who are uncontrolled, who are possible means that you have the lowest level of evidence or you have a suspicion. It's an acceptable diagnosis. You should not delay your antifungal therapy because that delay okay to treat. What to treat? Azole first line. Azole resistance. You have a treatment. Switch over the kind of monotherapy to at the base we use as a salvage therapy along with azoles in certain group of patients. Though posaconazole has an excellent in vitro activity against aspergillus, the optimal duration of therapy for COVID-associated pulmonary aspergillosis is between 6 to 12 weeks of drugs. Of course, the clinical features would tell you that he's improving or he's becoming febrile, his phlegm is better, he's no longer having hemoptysis. You can follow him up with serial CT scans and you can follow him up with progressive lactomannan index in his invasive bronchoscopic sample, better lower and lower. That means you're on the right track, the patient is getting better. So this case basically highlights the difficulties in diagnosing and treating COVID-associated pulmonary.
I think we'll take the questions at the end of the session, isn't it?
Yes, sir.
Dr. Yash?
Yes, sir.
Straight away, we go to the third session, that is on the role of amphotericin B in the management of invasive fungal infection. I know that old is gold, and it will be taken by doctors from Sun. And we see what Dr. Madhusudan Jaju has to say about amphotericin But as per me, amphotericin B is the oldest molecule, and that is still date it is the best molecule available. Dr. Jaju, is available?
Yes, sir.
Good afternoon to everyone. Thanks the Indian Sepsis Forum and in particular Dr. Yash for giving us opportunity for talking about the amphotericin B. I think in the COVID, a lot of people are aware about this fungal infections which were making an havoc, and about a lot of shortage was there about the amphotericin B. The amphotericin B, which is there available in the different forms, people have a lot of confusion when to use, what to use, and what time you have to use. So that in nutshell, for next 15 minutes or so, I'll try to explain about the amphotericin B in the management of invasive fungal infections. If you talk about the invasive fungal infections, which is there, we have the various different infections are there. The individual practice about the Candida, the Aspergillus, the mucus, and so on and so forth. Particularly when we talk about the antifungal medications, we are aware about the azoles are very common, and then we see about the other thing about the amphotericin B deoxycholate. But as the days over, as the years going on, we see about the newer forms of amphotericin B, particularly liposomal amphotericin B, which is available. Now, what is the difference between the old amphotericin B and new amphotericin B? Particularly, the toxicity is less of the newer amphotericin B, the liposomal. We can use increase the doses about 5 to 10 ml per kg, and the resistance is less. But definitely the cost of liposomal amphotericin B is more than the deoxycholate. Now, if you see the structure of the fungal cell wall, is made up of the ergosterol and the 1,3-beta-D glycan synthase. The cell wall, particularly the fungicidal antibiotics which are there, particularly the echinocandins of casofungin, micafungin, and lofungin causes, and the acting on the 1,3-beta-D glycan. The azoles acts on the cytoplasm, and the amphotericin B, particularly the polyenes, acts on the cell membrane and causing destruction of the cell wall, having a fungicidal effect, particularly the amphotericin B and lipid formulations and steroid. The reason is important for destroying the cell wall of the fungus and become a fungicidal drug. If you see the activity of the antifungal medications which are having available with us in the practice, particularly the fluconazole, itraconazole, posaconazole, voriconazole, amphotericin B, and echinocandins. As we know about here, we can see about the Aspergillus fumigatus and flavus. They are more sensitive for the voriconazole, the posaconazole, and the amphotericin B, and of course, the echinocandins. The Candida albicans particularly will be sensitive for the azoles and the echinocandins, but particularly will be not. Zygomycetes media COVID. The reason fungal infection to amphotericin B, but depending upon what infections, or at least high degree of suspicion. Pattern of see infection the biomarkers are not because the infection that what is should be an fact. See the hospital receiving having very and total dialysis surgery organization infections therapy. Candida network the incidence and characteristics of the outcome of the ICU acquired Candida in India. They found that almost 6 cases per 1,000 admissions of ICU is the fungal infections. Common studies of India found that the fungal infections are common in India. A lot of work from Chakrabarti, and they found that the most fungal infection happens after a period of week admission. Even the patients having an Apache 2 score of admission around 17, they're getting the fungal infections, and 31 Candida species causing candidemia have a high rate of isolate of Candida tropicalis, and they found that resistance is almost of the and Candida rugosa found that of candidemia to 20%. The selection of the treatment is very important once we know about the which are getting an the diagnosing criteria. What are the important cost help of the see the suspicion of same one hand candidate the persons which working in the hospital, we should have a high degree of suspicion, and then for this patient and limited experiences there, but patient is fitting into high risk criteria. As I told, patient receiving hand antibiotics, uninvasive lines, post-operative patient, TPN, and so on and so forth. We can start. The approach will be an empiric approach for the patients. So that the first line treatment is very important, because heat hard and heat fast, not only for the antibiotics, the same true for the antifungal medications also. So that particularly the echinocandins, nicafungin and lafungin, we first-line treatment, even including the hematological patients also. The liposomal amphotericin B also comes in the grade 1 recommendation. The other amphotericin B deoxycholate and fluconazole or other azoles is in recommendation, provided that patient does not receive previous azole exposure. And if catheter removal is there, is important whenever any high degree of suspicion of fungal infection is there, that remove all lines and tubes and change it. If you are not able to remove, then the medications will be different. The reason the liposomal amphotericin B is recommended if you are not able to remove the catheters, or if the patient having the sensitivity for the amphotericin B, some reactions, we can use an echinocandins for them. The invasive molds infections in the ICU is also very common. The Rahul Chakrabarti has published in Journal of Critical Care in 2019. They included 11 tertiary care centers ICUs across India from April 2016 to September 2017. There are 300 and odd consecutive patients with proven or probable invasive mold infections. The risk groups who are there about particularly the patients of neutropenia, patients of malignancy, the transplant recipients on immunosuppressions, and the patients of the non-classical like a COPD patient and controlled diabetes, patient having an underlying liver disease, or patient receiving steroids. And they found that almost 9 out of the 1,000 admissions in the ICU having the fungal infections. The Apache score and admission around 14, and they took around 4 days for the zealous around 15% of the cases. The other thing, other people of like I told, COPD, the diabetes and liver failure and chronic liver disease, India are development of causing an invasive mold infections in the ICU. And they found that mortality at the end of 1 month and 2 months, 2.5 months is more than 60%. And the time to hospital mortality is significantly lower in the non-classic risk for the classical. and the patients having a high aperture to score an invasive mold infections significantly reduces the mortality for the patients. Now, if any patient suspicion is there and subsequent, so that prophylactic antifungal medications, particularly for the high-risk patients of the organ transplant. As I told in the previous slide, the neutropenic patient going for organ transplant, patient on immunosuppressants. And we start about the preemptive treatment where markers are positive, like beta-D-glycan or galactomannan antibody is there for the patient, where the patients were having the colonization of the fungal infections and maybe having the point of care testing of monoclonal antibody. If the patient develops infections, we start high risk. We start with the patient already on the antibiotics, and if of infection start, the important to understand preemptive treatment in cases of antifungal. The IDC guidelines, they told about the tissue diagnosis either in the form of CT-guided biopsy or bronchoscopy, and they verified the serum azole levels if you're having therapeutic drug monitoring for the patient receiving mold active triazoles. And empirically, we can change to the azoles which are covering for the aspergillus infections. And if possible is their underlying immunosuppression, we are able to come down, we should able to come down. The empirical antifungal therapy for the high-risk patients with prolonged neutropenia who remain persistently febrile despite the broad-spectrum antibiotic therapy is important to start an antifungal therapy for them. The most commonly, the high degree of recommendation is there for the lipid formulation, amphotericin B. The echinocandins, either the micafungin, caspofungin is their strong recommendation of oruconazole, a strong recommendation because having a moderate quality of evidence for them. The very overall fungal, and it was published in New England. The problem is comparison of favorable response was not good for horiconazole, is good for the liposomal amphotericin B. Successful treatment of the baseline infection, complete treatment in or resolvable B. The reason for the horiconazole. Yes, about the liposomal amphotericin B. They are intercalated into the lipid bilayer of the unilamellar liposome. The other thing is about the ribbon-like particles, the carrier lipids which are there, DMPC, and the other is emulsion droplet of the drug molecule, particularly the liposomal amphotericin B. They are incorporated with the hydrogenated soy phosphatidylcholine. Liposomal amphotericin B, fungal infections who are refractory or do be for between 5 to 10 mg per kg. Only the liposomal deoxycholate we use 1 to 0.5 to 1 mg per kg. If you have the lipid 3 mg per kg for that. So the formulation, the study has been done from 1997 to 2001 from Prestine, White, Walsh, and Fleming. They found that the liposomal amphotericin B related toxicity, renal toxicity, and overall, if you're using a liposomal amphotericin B as patients of lipotericin, that what they told that liposomal amphotericin B is much better as compared to the amphotericin B deoxycholate in the and overall in clinical recovery. Mycosis in India and there is published the various from 20, a lot of around 3 patients, and they found that male to female ratio, male persons are more infections than the pediatric. The having diabetic keto, underlying chronic of factors, ketoacidosis having some suppression, causes for them. Reactive oxygen species is also responsible for causing responsible for the mucormycosis, more complications and more susceptible for COVID, particularly having hypoxia, having an leukopenia, where CD4 and CD8 cell counts are less, endotheliitis, leading to all this thing, leading to metabolic acidosis, leading to endotheliitis, and leading to increase in the mucorals adhesions for protein homologous, leading to mucormycosis. That's the reason why we are seeing more and more cases of mucormycosis in COVID-19. The optimal treatment pathways for mucormycosis in the adults is very important. We should have a high degree of suspicion, and we should start a treatment as early as possible. It's important about the surgical debridement with the clear margins. Is important for the disease control by knowing histopathology and microbiological diagnostics, plus immediate treatment initiation is very important in cases of the mucormycosis. Important is there in cases of the mucormycosis to avoid the slow escalation of the dose starting from 1 mg or 3 mg. Directly start about liposomal amphotericin B. Liposomal amphotericin B about 5 mg per kg of the dose is very important for them. If the patient having and brain involvement is there, directly start with 10 mg per kg from the day 1. If the patient having solid organ transplant, also recommendation is there to start 10 mg per kg of liposomal amphotericin from day 1. If the patient having pre-existing renal compromise is there, and if the other options are available of giving an isoconazole or posaconazole, we can do an isoconazole 200 mg IV start dose 12 hours apart, 3 doses followed by 200 mg OD from the day 3. If you are using posaconazole, we can use 300 mg dose at 12 hours apart for day 1 followed by 300 mg OD. If possible, if patient having and other problems are there, we can use the other things are there for the patient for using liposomal amphotericin B 5 mg per kg per day, or we can use posaconazole oral suspension. But the first and foremost will be there to using liposomal amphotericin B starting from 5 mg per kg. If involvement of the brain is there, straight away for the going out 10 mg per kg is important. Once we given all these things are there, we have to assess how is the response to the treatment every weekly by doing a various imaging. If the patients are stable, the patient having a partial response, we can continue the treatment for 3 weeks or at least 3 to 5 grams of the amphotericin B, how the patient tolerates, and then we can change to the long-term continuation treatment for at least for 3 months, either isoconazole or posaconazole. If the patient having a progressive disease, we can do an addition of the along with amphotericin B, we can do an addition of isoconazole or posaconazole combinations we can do. If the patient developing a toxicity is there for amphotericin B in the terms of patient getting an renal impairment, severe hypokalemia, other things are there for the patient, we can use an IV isoconazole or posaconazole we can use. Or in the dose of the amphotericin B lipid complex or liposomal amphotericin B from 5 mg per kg per day from the day 1 is very important for using. So that important thing is there about the amphotericin B to use proper doses and proper duration is very important. If you think about in summary what we've spoken for last 15 minutes or so, the efficacy of the liposomal amphotericin B is much better, nephrotoxicity is much less, infusion-related toxicity is much less, cost obviously because of all these things is high. So that the guidelines also recommends the first-line treatment of canademia in cases of the patients of neutropenic or patient of persistently febrile in spite of the broad-spectrum antibiotics, and in the first-line treatment of mucormycosis. Thank you. I think we'll take 1 or 2 questions from the chat box. Here we can see about people asking about mucormycosis from the base of the skull. Yes, the base of the skull always for in the patient of mucormycosis with base of the skull is required about the multidisciplinary go for surgical we have to see everything has to be done in terms of endoscopy, if bedside possible, or in taking an operation theater. And as we require this liposomal amphotericin B for a period of 2 to 3 weeks, always we prefer for putting in PICC line and regularly monitoring about lipid is there, checking about the triglyceride level once in a 5 days to 1 week, and check about the renal parameters along with the sugars and along with the potassium. Though the chances are very less for causing an electrolyte disturbances and for the nephrotoxicity, but as a protocol, we make it a point once in 3 to 5 days, check for the renal parameters and control of the sugars properly. Thank you. Thanks a lot for patient hearing, and thanks Yash for giving us opportunity.
Would request Ashutosh sir to please take the stage and
invite the next chairperson, Dr. Ritesh Shah, Director Critical Care Unit at Sterling Hospital, Baroda, and my dear friend Dr. Ashutosh, heading Critical Care at Dharamchila NH Hospital, Delhi. Over to you, chairpersons.
Thank you, Dr. Yash. Thanks a lot again to give all of us this opportunity and the platform to share our ideas on this World Sepsis Day. So in this session, we will have two very important and pertinent topics from care perspective. The first topic will be cost of sepsis diagnostics in India, which will be taken by Dr. Bansidhar Tarai, who is Principal Consultant and Head, Microbiology and Infection Control, Max Super Speciality Hospital, Saket, New Delhi. The second topic will be taken up by Dr. Anirban Home Chaudhary, and the topic will be cost of sepsis therapeutics in India. Dr. Chaudhary is Director Professor and Critical Care Expert at GB Pant Hospital, which is also known as GB Pant Institute of Postgraduate Medical Education and Research in Delhi. So we all know that India is in a developing state, and lots of its people are below poverty line. A lot of poverty is there, and most of the tier 3 or the advanced care we talk on the webinars, it is there in the metros, and that too in the private sector. Now, most of this care is not amenable because of the cost involved to the large population. I hope that this session brings some clarity and give some insight on the alternatives we can have, to better this inequality and ways to cap or limit the exorbitant costs which are involved in the sepsis care. Over to you, Dr. Bansidhar Tarai, for the first topic.
Good afternoon, everybody. So today I'll speak about the cost of sepsis diagnostic in India. So there are a lot of tests. The cost is very it can be laboratory diagnosis, or it can be radiological diagnosis, ABG, microbiological diagnosis, or clinical diagnosis. So all will have an impact on the cost diagnostic of sepsis. So we all know sepsis is a medical emergency, and fast recognition of sepsis helps and early survival of lives. Sepsis is very difficult to diagnose. So it can be difficult to recognize and diagnose. And early sepsis symptoms are non-specific. Sepsis happens diagnosis. These are the clinical, some quick clinical diagnosis like fever, chills, or altered mental status, difficulty in rapid breathing, low blood pressure, low urine output. All are basic clinical diagnosis, which I will not go into details. These are the simple tools for clinician to recognize sepsis. And the SOFA score and the SOFA score, like in ICU settings and the non-ICU settings. This I'm just going through the brief because see, all the things will be impacted in the cost of the sepsis diagnosis. The patients, whenever the patients in say, ICU setting, the cost will be higher. Or the sepsis, those who are in non-ICU setting, the diagnostic cost will be less. And how often we are giving the test like the early blood culture or like this. So all will be impacted, and depending on the complication, the length of the stay. So all depends on the cost of the patient's diagnosis. These are the sequential organ failure assessments. So this I am also highlighting because there are a lot of multiple organ parameters monitoring will be happen. It can be hepatic parameters, the LFT, renal, RFT, and the respiratory parameters, the neurological, coagulation parameter, cardiovascular parameters, all will be done once the patient is on different settings like the ICU settings, and this will be a continuously monitoring things. So all will be impacted in the diagnostic costs. So we all know as a basis, 80% of sepsis come from outside the community, and the source can be anything. So it can be, the sepsis can be due to the lung infections. The source can be urinary tract infections, or it can be intra-abdominal infections or the skin subtle infections. This I am saying because we have to not only do the blood test, we have to also simultaneously do the pneumonia infections. So everything we have to look into when we are calculating the diagnostic cost of the patients on sepsis. Right. Then sepsis definitely is a costly thing, and sepsis, if you see the length of stay is increases, the hospital admission cost is also increases. As long the patient stays, then the multiple tests will be done, and the cost definitely add up the cost. So and the different complication of sepsis, that will also increases the cost. So by in the simple, I have gone through a lot of literature, so I could not find a basic cost sepsis. This is, I think, a new topic to me. Treatment cost, there are a lot of papers are there, but in diagnostic cost, I could not find much publications on this or presentation on this. So what I feel, the cost can be vary depending on the mild sepsis or a moderate sepsis, or it can be a severe sepsis. You all know mild sepsis can be in the IPD patients, and we only need the basic diagnosis of sepsis. Monitoring is the cost is will be a little impact on this. Then the moderate sepsis and the severe sepsis, we all know the ICU settings, all the organs will have to be monitored on the cost basis. And the diagnosis, which is very important in the molecular, the newer molecular test has come up that I'll explain to you. But microbiology is the main mode of diagnosis, then molecular and biochemistry lab. This is very, very important when we are doing the radiology, CT scan, ultrasound, X-ray, all are important for diagnosis, initial diagnosis, and definitely the clinical. And the cost. WHO, the 8th priority identified by WHO, and they have mentioned support the use of appropriate diagnostic tools and further research on the sensitive and specific new biomarkers and microbiological tests for early identification of sepsis conditions. So when we are coming to the microbiological diagnosis, the most and important is the isolate the causative organisms. Identification and the resistance pattern, the sensitivity patterns, like the blood culture is the most important in the diagnostic settings. It can be a single blood culture or the paired blood cultures. So then we have a site-specific cultures, the urine culture, the CSF culture, and the skin and soft wound culture, respiratory secretions culture, body fluid cultures. This is also very important. Whenever you know the source of the organism, then you can treat very easily. Then the multiplex PCRs, which I'll explain about, the new multiplex PCR system has come up that can be help in the rapid diagnosis of the sepsis, but that depends on when the culture comes positive. Then fourth is the host response monitoring, the procalcitonin, CRP, lymphocytes, the CBC, IL-6, HLA-DR. These are the costs which we have to initially stage when the blood test has to be done, and this will impact the cost. Then the organ failure risk assessment when the patient in the ICU settings, the lactate, the blood cell and the platelet counts, bilirubin, creatinine, the coagulation factors, all will be added in ABG, everything will be added in the cost. So microbiological diagnosis influences 70% of the healthcare decisions, and the lab accounts of the hospital costs. In that context, improved lab process quickly have a great impact. So whenever you see the diagnostic costs, so if you exclude the radiological things, the laboratory things, and the ABG things, then the microbiology and the basic, the lab accounts only 5% of the hospital. But when the patient is on the ICU settings, multi-organ functions, then the cost will be little will be higher. The initial diagnosis only is the 5% of the total hospital cost. And microbiology diagnosis is so if you see the in vitro diagnosis, the cost is so wide, topic is so wide. In India, the cost is vary from different states to states. The PCT cost can be vary from thousands to 3,000s. CRP also, CRP is not much, it is less than 800, 500. It varies. It's a quantitative CRP or semi-quantitative CRP or the normal qualitative CRPs, the lactates, blood cell counts, platelet counts. We all know this is the CBC basics, the RFT, that are not much cost. Blood cultures we'll discuss in the details. That is important, which is a little bit costly. Then site-specific culture, urine culture, CSF culture, wound culture, respiratory secretion, all the blood cultures. So wide. Because what will happen, those who are monitoring with automated systems, identification systems, sensitivity automated things, advanced multi-top, or the advanced sensitivity systems, so then the cost will be very, who is using the paired blood culture or single blood, was going one culture test comes in various Indian cities. There are almost 103 cities. So I could not gather all the cities, only the top cities I have taken it out. The blood culture, if you see Agra, the average price is 679 rupees. The starting from 250 to 1100 price. So it is basically manual. Some setup do the manual blood culture, some are doing the automated blood culture. Ahmedabad, the average price is 888 to starting price 400 to 3000. Then if you see Aligarh 390, 208. So manual blood culture, Allahabad 647, 350, 1300. So Amritsar 537, 200, then 1200. So basically the cost can vary. Like in Delhi, what I practice is the paired blood cultures. Two blood cultures, one from central line, one from peripheral line. Or if it is no central line, so I ask for two paired blood cultures. One from left hand, one from right hand. So I have deliberately kept the blood cultures, both paired blood culture and single blood culture same. so that most of the clinicians send the paired blood cultures. So the price will vary from Indian cities, from different Indian cities. So we have a complete blood cultures. We have a complete diagnostic system. So we have a multi-top, we have a blood cultures, we have a biopreliminary multiplex PCR systems, we have a Vitek to Excels, Vitek. So we have a complete automated systems in our lab, so which can identify and give the sensitivity within 24 to 48 hours. So that's depend. The cost factor is varies depending on the what systems you have, what automation you have. Can be manual. So the cost will be vary from cities to cities, the hospital to hospitals, the patient condition, mild sepsis. It's all the basic test has to be given, the blood culture, the source of the other source of cultures, and then BC, CRPs, and these are the basic tests which has to be ordered, and the cost, it's all coming around 5 to 10% of the total cost of the including the radiology, 5 to 10% of the total cost of the patient's admissions. So this is the multiplex PCR. What I am saying is that we have a multiplex system. This is direct. We can identify to 5 patients. So this is the most advanced model. And do the gram neck and stop KP. Hospital end user segments account the largest share of 2019, and this will grow up to 2025. So diagnostic test market will go up, and this is this sepsis diagnostic will be very, very important. So I'll summarize the cost, diagnostic cost. The diagnostic cost include the lab, radiology, and the ABG machines which are there in the ICU setting. So all will be diagnostic cost. It can be vary from 5 to 10%, 5 to 10% cost of the total patient's cost, depending on the mild sepsis, moderate sepsis, and the severe sepsis. So overall, and depending on the clinician's order, so and the different cities, different type of hospitals it is. So diagnostic steps cost will be vary from all over say, but it will be accounting around 5 to 10% of the total cost of the patients. So, right. So thank you very much. Thank you very much.
Thank you, Dr. Bansidhar, for kind of briefing us about how much the cost may be. Definitely, it's a variety as variable cost as per ICU to ICU, CT to CT, and the type of patients. So we'll take questions at the end of the session. So I would invite Dr. Anirban for his talk on cost of therapeutics. Dr. Anirban.
Sorry, I could not hear you, like some problem.
We'll be taking questions at the end of the session, Dr. Bansidhar.
Dear friends, hello. At the very onset, I wish to thank Indian Sepsis Forum for giving me this opportunity to share my thoughts and perspectives on the cost of sepsis therapeutics in India. I know it is very difficult to make a good conclusion based upon the studies available so far, because the studies are not so sound in their conclusions or in their methodologies, but I will try to do justice to the subject by trying to rely on the data that is available from a large part of the studies which have looked upon this issue with dexterity. Let us begin with this case. A 70-year-old male having fever, drowsiness, and difficulty in breathing for emergency, and based on the Q-SOFA score is shifted to ICU for further management. Based upon the SSG guidelines of sepsis 3, the patient is diagnosed as having sepsis, and the patient is planned for immediate fluid resuscitation, hemodynamic monitoring, further investigations to determine the extent and severity and the source of sepsis, is begun broad spectrum antibiotics and other supportive drugs. The nursing care of fast hug is implemented. At this point, after making the counseling to the relatives about the condition, the physician faces the question that seeking to know the approximate cost of treatment and the duration of stay. Now, this is where the game starts and the ball gets rolling. And with time, the situation can become so complicated that it becomes beyond our imagination that how much variation can it impose. Now, why is cost so important in sepsis therapy? It has been seen in 2011 in a very large study in US that it is one of the most expensive reasons for hospitalization, because in US, they have spent $20.3 billion in hospital care for patients with sepsis, which amounts to a huge amount of dollars every day, the figure you can see. More importantly, the annual rate of growth of sepsis in the hospitals is 3 times the rate of overall hospital cost. So even if we can assume for a while that the hospital costs for a particular year have not increased and the same as that of previous year, the cost of sepsis would still go up by 3 times. And so that would also put a considerable burden on the cost of care. Thirdly, hospital stay of septic patients is 75% longer than that of other non-septic patients. And this may be because of the very high rate of complications requiring prolonged stay. Furthermore, the survivors of sepsis are more likely to be discharged to a place other than home. It is a known fact that in US, they have other nursing homes and long-term treatment facilities, and such patients who cannot be cured at home are shifted there. We have home care, and home care is mainly provided by
I think there is some technical issue.
Sachin, it again. Sachin. From the same point, yes. Thank you.
Okay.
We can't hear anything.
Hello.
admitted into the ICUs of India had sepsis, and 1 in 3 out of those died. There is also a huge burden of sepsis in pregnant mothers in the to the all know of the medicine medicine and a huge amount of these medicines are actually born out of pocket, covered by the, that is also has a and all sepsis, particularly the level is, and how before what types of costs? One is the direct cost, another is the indirect cost. Direct costs are the ones that are traceable to the specific cost for direct patient care. For example, a patient may have pneumonia, so he will be using one type of drugs. The pharmacy will provide him that type of drugs. A patient may have abdominal sepsis, he will have another kind of drugs. The respiratory care will change, the laboratory investigations, microbiology will change. So these are the specific costs that are because of the disease process, and they have a lot of variations. Out of this direct cost, there are certain direct variables. The variables include drugs, consumables, investigations. So these are most responsive to individual patient characteristics. So for a clinician, if it is possible to rule out certain conditions, avoid certain investigations, or start some new drugs, it can influence the direct variable expenditure to a significant extent. Another aspect of the direct cost is the direct fixed cost. For example, the consultation charges for consultants coming to the ICU for references. Now, these are fixed charges on intensivist ones which are not directly linked to the patient care. For example, the IT services, the patient's relatives using elevators. So all those kind of services which the hospitals are providing to the patients and their relatives are indirectly borne by the patients because they are also divided in some indirect form as establishment charges. So these are least amenable to change based on patient characteristics. So we can't do much about them. So clinicians have some control over the direct costs. Among the direct costs, the direct variable costs are the ones on which one can consciously apply
Allow me 1 minute, I'll start.
The lesser chance of complication. And we find that there is a huge difference between selling price, as we can see, of the fluids that are available. They have compared between 3 brands. So the percentage difference of selling price is as high as 100% for some to 4%, as low as 4% in some. And somewhere it is staying in between with 5% dextrose, it is 35%, 10% it is 80%, so on and so forth. So it shows a huge difference. The profit also varies with and it has been found that where in post-op patients, it makes 1/4 of the total cost of medications is borne by the fluids. And the selling price difference, that is the difference between the highest and the lowest, was highest with Ringer lactate among its competitors. And therefore, if we can choose the right brand of fluid, probably a lot of expenditure on fluid can be minimized. This is also another study which looked into the use of balanced salt solutions, because balanced salt solutions are preferred in some patients of sepsis because of multiple reasons. There are split trials, SMART trial, the salted trial. Some of the trials didn't find any difference. Some trials found some difference, but because of the benefit incurred in a composite outcome, and particularly with a lesser chance of complications, so in certain subset of patients, it may be more cost effective to use balanced salt solutions, because the experts advise against the use of Coca-Cola type of fluid, which means that those fluids which are not physiological can actually increase the total cost overall because of complications. Looking into the antimicrobial agents, we can see that there is significant difference or cost variations in the use of antimicrobial agents available in India. For example, if you try to figure out the ones that are used in the ICU, ceftriaxone, the minimum from 35 variation is 180. With percentage of the cost ratio becomes almost 1:20. It is much less. Have caused need to do a fair amount of cost for antibiotic variation. When so much of it to of variation by antibiotic variation in this group, it is the price range is between 525 to 2625. The cost variation is 500% because the cost ratio is 5. So when piperacillin tazobactam is used, one again can be reasonably judicious in choosing a brand so that the excess cost can be reduced. So with tigecycline, it is much less. With linezolid, it is moderate. So likewise. So this is one very nice study published from AIIMS Bhopal, which looked into the cost of treating bacterial infections in India, a cost minimization analysis to assess the price variations. And if we see two important aspects, in enteric fever, the use of ceftriaxone 2 gram IVBT for 14 days, there was a variation of 200% turned out branded. The 7 for 200 difference in the max price. So likewise for diverse therapies can be seen sometimes even due to the malicious type that as also looking we use a quite with lot like so with amphotericin liposome potential 177% is much maybe less in caspofungin because the again this can be also used while choosing because considering such wide variation and the longer duration of antifungal use, probably it would be a prudent decision. If we talk about the adjuvant therapies, not much of evidence of cost effectiveness is there in India. In India, almost there is none, but in this study, the UFA study, they have found cost effective intervention shock, something which no level from anywhere. Again, with a similar drug, cytosorb used in the context of sepsis, there are 4 trials, 3 trials and 1 case series, and which significantly mentions its role in reducing the IL-6 levels, improving mortality. But none of these 4 studies have established any cost effectiveness with the use of this drug. But one thing is sure, that the case of early mobilization in sepsis has to be kept in mind, because huge difference in cost has been made by early mobilization, which reduces the length of stay in the ICU, reduces the length of stay in the hospital, and brings down the cost significantly in terms of admissions per year. So early mobilization can reduce length of stay by a very large amount. This is based on US study, but it won't be different, because in India also, the practice of early mobilization can be practiced as intensely as it is done elsewhere. Now, looking into one important group of patients with sepsis are the cancer patients. And this important study showed that this is a population-based case control study. Sepsis imposes substantial economic burden and can result in doubling of cancer care costs, particularly during the first year of cancer diagnosis. Because the first year of the time when patients usually tend to receive the chemo, and once they receive the chemo, they are prone to develop neutropenic sepsis. So that's where once they incur huge amount of cost already due to the chemotherapeutic agents, they are again forced to spend much more due to sepsis. So that becomes a huge burden. And this is again another study which is also not from India, but from one of the Middle East countries. They have found one serious significant that how treatment decision can affect the cost. Glycopeptides are the most commonly used type of antibiotics, in reaching almost more than 80 to 90%. But only 30% of patients have gram-positive infections that are sensitive only to this group of medicines. They found it out, and then they changed their practice. But this is something very important and a lesson to be learned probably for everyone, that the use of the choice of antibiotics can make a huge difference to this cost in the cancer patients. And again, they have found that antifungal therapies are the most costly medication in sepsis treatment. However, less than half of the patients have fungal infections, and only about half of them have Candida albicans, although the antifungals are used in such a huge quantity, adding to the huge expenditure. Now, this is a very important study which has overall discussed about the cost perspective. It has seen that medical and mixed ICUs typically had more uniform daily costs throughout the ICU stay. Although at times there were peaks patients that occurred following usually was uniform. Surgical ICUs had high first day costs. Once the post-operative maximum cost of the ICU admission. So length of stay as a surrogate measure of ICU cost is actually imperfect, because not all ICU days are equal in terms of costs and are treated with respect to actual cost. So they have concluded by saying that our understanding of ICU costs is still superficial and needs drivers of such analysis. Very true. Expenditure has not has found a mention, not been done. That is produce its message would be that cost of variable and largely out of the pocket. That is the patient bearing the cost. More than 2/3 and fixed among cost interventions, but an intensivist can play an important role and help by trying to reduce the length of stay in the ICU by proper and careful judgmental antibiotic and antifungal stewardship and timely de-escalation of antibiotics, and of course through the rational use of adjuvant drugs and fluids. Thank you very much for your patient hearing.
Thank you, Dr. Anirvan, for a wonderful presentation. We can keep on talking about this cost, and what I like the most about the direct variable cost, which is a key thing that nobody can judge, and as like diagnostics, it's also variable from patient to patient, ICU to ICU, hospital to hospital, and maybe city to city. So very, very difficult to give a range of, we need to give a range of ICU cost whenever we talk to our patients. So Dr. Yash, if any question, we can go ahead.
No, we will go ahead. We are a little ahead behind the schedule. So
okay, fine. Thank you,
chairpersons.
Okay.
Thank you, Dr. Anirvan, Dr. Balsi.
Thank you very much. Thank you.
Thank you so much.
Thank you.
Thank you, Yash.
Thank you.
And the chairpersons.
Yeah, I have a
question. You are looking great, Ashutosh.
Thank you very much. I'll call you and have my questions cleared. Thank you.
Thank you. We move on to the next session. The next session is a joint symposium between Indian Resuscitation Council and Indian Sepsis Forum. I'd like to invite Dr. Chakra Rao. Dr. Chakra Rao is the... I'd like to invite Dr. Mohit sir. Dr. Mohit sir is my teacher. Dr. Mohit sir is professor of anesthesiology. He is a key person in All India Difficult Care Association, and he's a great human being as well as a great mentor for most of us. So I'd like to invite Dr. Rashid Diwan. Dr. Rashid Diwan is a national council.
Good evening. It is a real pleasant afternoon that the Indian Resuscitation Council and the Indian Sepsis Forum are sharing the same platform. Express that are actually in every sepsis, there should be some resuscitation, and of course, our Indian Resuscitation Council has formed as a unique one to resuscitate any victim when they are in trouble. So now I request my colleagues to talk. Dr. Mohit, please say a few words.
Good afternoon, delegates and the faculties, the speakers. It's really a pleasant weather today, and it's really a wonderful experience sharing the platform, both the IRC and the Indian Sepsis Forum. Certain salient features which IRC really has come up with in the last 3-4 years is that one of the most important things is we, as a country, we did not have any resuscitation guidelines in India as such. But IRC has taken the lead and has taken the responsibility, and they are doing a wonderful job to establish a guideline, which is you can say one of the most important achievement as far as the ISC and IRC is concerned, because it's under the supervision of ISC that we have established an IRC, which is Indian Resuscitation Council, and we have come up with the guidelines. Most important, the 3 guidelines, which is COLS is for the lay person, BCLS is for the paramedics and medics outside the hospital, and CCLS is primarily for the medics inside the hospital. Most important thing today we would like to highlight here is in relation to today's CME, based on especially cardiac COVID patients, and they came up with the guideline in 2020, which was published in Indian Journal of Anesthesia, and which was really very critical and was very taking a very serious people how to deeper in especially COVID patients. And I think some sort of insight on that as well, touching a bit of it, Yash, and giving us a platform to show what the IRC is doing, the ISA IRC is doing as far as resuscitation is concerned when we talk about any critical ill patients. Thank you so much, and over to you, Dr. Ashish. Ashish, you
yeah, thank you so much, and I must thank Dr. Yash and the whole team for inviting us to chair these sessions on the, it is I would say a great gesture of having a joint meeting of global summit on the infection and sepsis and Indian Resuscitation Council. We have taken enough time. We are already late. I think we should go to the lecture straightway. Thank you so much.
The first speaker is Dr. Rakesh Devan.
Rakesh.
Rakesh Garg. The anticipating the collapse in COVID sepsis. Actually, Rakesh Garg, all of you know that he is the additional professor of anesthesia and critical care and pain in All India Institute of Medical Sciences. He has a lot of publications, more than 280 publications, and he has authored about 4 to 8 chapters in different books. And he is a gem of a person. And Dr. Rakesh is one of the lead directors of the scientific committee of the Indian Resuscitation Council. So with this introduction, I request Dr. Rakesh to present how he anticipates the COVID. You can share, sir.
Now we will be talking about anticipating the collapse in COVID sepsis. I bring greetings from my institute, AIMS, New Delhi. Now, we are very well aware of the various concerns which has been raised by this COVID disease, which is caused by virus 2. Into the research for various evidences, including the resuscitation in the past couple of weeks and months. When we talk of COVID-19, we know that whenever a patient comes with COVID-19, it has to have an initial assessment. We make a diagnosis, and then we assess the patient further on based on the clinical manifestation and investigation, and then try to manage it. And this is a very conventional for any of the disease. But the point here is some of the complications or some of the events that can happen in certain group of patients. Are there factors that we can identify them, that this patient is going to get sicker, this patient is going to get some event, significant event like cardiac arrest or cardiac morbidity or a respiratory compromise. So based on this, can we assess them? That we'll be discussing in the next 15 minutes or so. Now, when we talk of the COVID-19, we know that many of these patients who suffers with COVID-19 are asymptomatic. Some of them are symptomatic almost to a tune of 40% versus 60%. And in case of symptomatic, most of these, almost 3/4 of these patients would have mild disease. They will not require hospitalization. They will be taken care of home only, and they recover very nicely. But almost 1/5 of these, 1/4 of these patients would be moderate to severe. They will require hospitalization for various reasons, primarily for the respiratory issues. But yes, they can require hospitalization because of the and would require
video is not working.
Rakesh,
why can't you speak straight away? Actually,
Dr. Mayuri, any issue with the presentation? Kajal?
yes, sir.
Sir, I'm taking it off.
Directly?
But yes, it requires early taken care of strategies, and hence the chances of recovery, chances of improvement becomes better in case we can anticipate them, and that is what we parameters, manifestation, examination for a specific group profile that we can to stratify management strategy. We very well know that the timeline of COVID-19 disease, the exposure after an incubation period, patient starts manifesting symptoms. Once the symptoms are manifested, patients may require the critically care support system. They may have an early pulmonary phase because of the hyperinflammatory phase. They can have cytokine storm or macrophage activation syndrome or multi-organ failure. And in case if they are not being managed, their patient shows multi-organ involvement also. Data, we have some emerging things are emerging. We do not have a robust these manifestations. So when this we have some data. We know that when a patient gets infected with SARS-CoV-2, the overt disease, most of them recover, some of them that we need prognostication, we need therapeutic monitoring, we need categorizing them. And that's why this will help in some aspect of prognosticating, some aspect of, you can say, we can anticipate if we know some of these factors that are going to influence the outcome. Regarding the pathogenesis, we are now have a fair idea about the various markers that are involved into the manifestation of the disease, and these the biochemical markers that are released are primarily responsible for causing the severity of the disease. And then subsequently, patient starts developing its own antibody, and these things are taken care of. Now, apart from this, there are many unknown factors that affects the severity of the disease. Those are not very well known, but yes, many of these markers are well known. They have been found to have relations with the severity of the disease and outcome of the patient, but the robust evidence is still lacking. We are very well aware that the COVID-19 is just not a pulmonary disease. It is affecting the various other organs also, specifically the cardiovascular system, the pulmonary system, and the CNS system, which is of a concern to us because the sudden compromise in these organs, the heart, the respiratory system, the brain, in these patients, and the outcome is affected if affected by see the way in duration these was another patients, and those factors which were present next to severity will be having when patient is being admitted comorbidities, asthma, diabetes, cardiovascular disease. Now, whenever is one or more or the lymphocyte count found to be have related the counts, more the LDH levels. These patients at the time of admission, if they manifest these things, the prediction was that this patient probably would have in coming times more severity of disease and hence require more aggressive management. We also know that the COVID-19 and heart is involved. It has been a viral disease. Pro-BNP level, the D-dimers levels are raised. The interleukin-6 and ferritin levels are raised. The CRP levels, procalcitonin, are raised. And these all factors would have impact on the cardiac functioning also. They can cause myocarditis. They are associated with coronary thrombosis. They are affecting the electrophysiological system of the body, maybe because of the myocarditis, maybe because of the direct leads to ventricular ejection fraction and leads to multi-organ failure also. So this means the involvement in the heart is very well seen. The sudden cardiac death has been seen in these patients, and the mechanism for involving these patients primarily is related to the myocarditis, the acute coronary syndrome, or the arrhythmias related to thromboembolism. So these are the involvement of the heart that can lead to sudden collapse. Now, whether we can predict that which group of patients probably would be manifesting these events more, so that these patients may require the resuscitation with regards to the cardiac arrest victims, probably the underlying comorbidity like hypertension, coronary artery disease, diabetes mellitus, these patients were more prone for increased susceptibility and severity of the disease, and the involvement of the heart also. Thromboembolism remains one of the important issues. So cardiac involvement and level of biomarker events, both prevalent and apparently are prognostic in COVID-19, so they can predict it. You can, if these levels are increased, probably the cardiac events are supposed to probably would happen in these patients. Thrombotic and thromboembolic event is one of the very, very important issues that needs to be taken care of. We know acute illness, bedridden stasis, genetic factors, fever, diarrhea, sepsis, liver injury, kidney injuries, patient with respiratory disease, heart failure, malignancy. These are the risk factors wherein various inflammatory response, including endothelial dysfunction, happens in these patients. And these can lead to various hemostatic abnormalities, and that can lead to venous thromboembolism, coronary events, or DIC also. So this means the hypercoagulability and thrombosis is one of the issues, one of the concerns in patients with COVID-19. The duration of increases of clotting in recovering COVID-19 patients still remains unclear, and these patients can even have these phenomena of thrombotic phenomena even if they start having an improving trend. The mechanistic understanding continues to evolve. Many factors, especially the inflammatory cytokine release, is one of the important factors. The virus binds cells expressing angiotensin converting enzyme 2, and this may mediate further mechanism of injury to the organs. The venous thromboembolism, the arterial thrombotic events, and other factors like DIC, which has come up and studied not only with biochemical markers, the blood investigations, but also with pulmonary angiography and other findings. And these remains an important phenomenon that needs to be looked for. The other concerns in the respiratory system is the delivery of the oxygens and the modality that we use it. That's a bigger issue. Various COVID-related ARDS has been found to have pathology different from conventional sepsis use ARDS, and that also needs to be looked for. We also need to be looking for various management strategies, because in these patients collapses, then we need to have certain fixed protocols which are a little different, require a modification because of the risk of contamination due to aerosolization, and hence we should be very careful when we anticipate some of these complications and require resuscitation. We should have a plan for airway management in these patients so that these patients can be managed successfully without affecting healthcare workers. And different guidelines are already published with regards to the airway management protocols. We also need to anticipate these things because the airway management strategies or the oxygen strategies, oxygen delivery strategies would depend upon the severity of disease, whether it is by oxygen therapy using the conventional devices or to the extent depending upon severity if these patients would require mechanical ventilation. But yes, the presence of HFNO has proven its role in management of these patients without requiring mechanical ventilation because these patients have higher morbidity when they are put up on mechanical ventilation. And NIV is again an option, but yes, Thrive or high frequency nasal oxygenation, high flow nasal oxygenation has found to have an important role. We should be careful when these patient collapses with regards to the airway management and initiation of mechanical ventilation. We should be taking all precautions so that these patients do not become a source of infection to healthcare workers. And hence, we should be very, very careful during these procedures. Now, having said that, these patients do have cardiac collapse. These patients do have airway collapse. And hence, we need to look for the factors where we can anticipate so that we can manage them appropriately. So there are a couple of studies which has been done, and they have found that the risk factors for disease severity in COVID patients, this is one of the big study which has been published very recently. And they found that the SARS-CoV-2 may attack the immune system, the blood coagulation system, and the livers and heart of the COVID-19 patient. And when they were assessing these patients, the various risk factors which can lead to the compromise and the collapse of these patients, and they found that patients with older age, decreased lymphocyte counts, increased levels of procalcitonin, aspartate aminotransferase, and D-dimers. They were the predictors. And hence, looking on these parameters, we can anticipate that these patients may have issues with the blood coagulation, the liver, the heart, the respiratory compromise. And hence, once these markers are high, we can predict them and we can start arranging appropriate resources so that these patients can be timely managed. Now, this is a big data from our own institute of almost 2,100 patients. We look for various predictors of outcome. And we have found that various factors like leukocytosis, thrombocytopenia, elevated D-dimer, 6-C-reactive peptide, and creatinine at the baseline when the patient is being admitted is an independent predictor of mortality even when the baseline and treatment characteristics. So this means if the patient is manifesting this abnormality in these parameters, we should be very cautious. We can anticipate that these patients may collapse at some point of time, and hence the resource distribution can be done accordingly. And when we have tried to find out various factors with the development of hypoxia requiring oxygen transport, we found that the patients who are of more than 45 years, those patients are vaccinated. They are little protected. The symptom onset, especially those patients who are asymptomatic, 3 or more weeks of asymptomatic, patients who are having symptoms specifically like breathlessness, these patients would require oxygen therapy at some point of time, so we can predict them. Presence of comorbidities and the lab parameters, which I just mentioned, including the leukocyte counts, the D-dimers, the CRP, and the creatinine levels. These factors were able to predict the requirement of oxygen support in these patients, and hence we should be anticipating that they can compromise, and we should be ready with the oxygen delivery devices, including the mechanical ventilation. Also, those patients, we can predict those patients who can deteriorate even with no hypoxia at baseline. Certain factors were identified in our large cohort of 2,100 patients. Elderly patients, patients who are having associated comorbidities, patients who are having severe time of admission, GI symptoms of creatinine, they were found to be so they were admission. We can predict that these are the group of patients we should be more cautious. The other factors which shows that in overall they can deteriorate, we again found that the elderly population, the associated comorbidities, the absence of vaccination, the presence of baseline severity of the disease, and the lab parameters including thrombocytopenia, leukocyte count, D-dimers, CRP, and creatinine. these factors, if deranged, they were more prone for deterioration during the hospital stay. Now, when we put up the logistic regression model, again, we were able to find the factors which were responsible, and we can predict the collapse in these patients, age more than 45 years, those patients who were having symptom onset for prolonged duration, presence of comorbidity, especially 2 or more, the severity of disease at the time of presentation, and lab parameters. Thrombocytopenia, data they were found to have no predictors of the severity of disease or the critical illness in these patients. Another interesting study where they have found to they have tried to find risk factors for COVID-19 severity and fatality, and they have tried to compare various data. More or less, the data which will help us to anticipate the severity, the collapse in these patients. Age remains the consistent factor. The presence of comorbidities remains the consistent factor. The inclusion of underlying comorbidity like liver disease, heart disease, diabetes mellitus, COPD, these patients were more prone for various associated organ involvement and organ destruction. Another studies, which is a systematic review and meta-analysis, a very big study of almost 41 studies, including more than 21,000 patients. And the patient, the male patient, the advanced age, the diabetes, chronic liver disease, COPDs, these patients were found to have more concerns, more chances of deterioration, and hence the presence of these factors, we can anticipate that these patients are going to get sicker, and we can anticipate the responses accordingly. Another important study, which is a single center retrospective study, where they are found to look for the factors. The young adults, in young adults, they found that the presence of lymphopenia is one of the predictor which can predict the severe prognosis of these patients. Another interesting study where they have found risk factors related to severity of disease, and they found that the presence of chest discomfort, chest distress, and various laboratory findings like IL-6, TNI, PCT, CRP levels, and calcium, they were found to be the independent risk predictors for prognosticating the disease, the severity of the disease, and the outcome of the disease. So again, these factors are important, and we can predict the various parameters. So to summarize, COVID, we know it's a novel disease. We are getting more and more data. We are getting to know a lot more with emerging evidence. But then, based on this additional evidence-based practice, we can anticipate certain conditions which can lead to organ involvement and collapse of patients, and we can manage and allocate our resources accordingly so that we can prepare ourselves for appropriate management, and at times can prognosticate the patient also. And accordingly, the option for us to timely manage these patients much better. So thank you so much.
Dr. Rakesh, I think we have touched most of the most important factors, which is, which are the patients, COVID patient, COVID. But I don't have that much time. If by time, so to the next speaker, who Singapore, he will be speaking on need, assess, and administer. Is it a challenge? Dr. Kansal, will you take it over, please?
Good afternoon, everyone. Care special. I work at a tertiary care center located in Western Singapore, and like many of the participants, we have been looking after the COVID patients for the last 18 months. The topic of my talk is now. I start with my first question. Why do we need to be careful about fluids? Fluid overload is associated with organ dysfunction, including pretty much every single organ in the body. Fluid overload is associated with poorer outcomes in terms of longer ICU stay, longer duration of mechanical ventilation, as well as is associated with increased mortality. One of the landmark papers from the Arts Network Group in 2006 suggested that a conservative liberal fluid reduction in the duration of mechanical ventilation. On the other hand, too little fluid is detrimental as well and will lead to organ hypoperfusion. Paradoxically, it will worsen the hypoxia by decreasing the cardiac output and decreasing the pulmonary artery flow, which in return will cause an increase in the physiological alveolar dead space. A follow-up of the patients from the Arts Network Fluid Management Strategy showed that the conservative arm patients may be associated with. So what we need is neither too much fluid and neither too little fluid. Easy said than done. Additionally, COVID patients are quite complex. COVID patients could be from GI losses, volume intolerant because of impairment and a cytokine capillary permeability, and will all patients can develop COVID-19 patients prone to myocardial injury. 12 to 23% depends on the severity of COVID. A lot of these patients are elderly and likely to have the cardiac comorbidities. The guideline we in COVID-19 ARDS trying to assessment need of registration. How it is. Is my patient, even if they are fluids, is fluid response? Agree that a 50 cardiac situation suggests that the and by trying to predict with that, and therefore interestingly, only 40 to 54% of critically ill patients, including ARDS patients, are likely to be volume responsive. That means almost half of our patients will not respond to fluids. Fluid assessment methods have evolved significantly over the years, from clinical assessments, static measurements, to more dynamic measurements and functional testings. The simple bedside clinical tests do not help. The static methods do not correlate with fluid responsiveness. Interestingly, the landmark Arts Network study that compared the conservative and the liberal fluid management strategies did use these static parameters as end goals: dynamic tests and the functional hemodynamic tests. So dynamic tests really indicators take day and on for the heart-lung infections. We can divide the new tests into 4 categories. Let's start with the real-time heart-lung infection methods like the pulse pressure. Promise in the ideal setting, paralyzed, perioperative paralyzed ICU patients, but these tests patients have additionally likely to require low tidal volume ventilation, have low compliance, and likely to develop these responsiveness. Ultrasound drive, which includes IVC variability and the left ventricular outflow tract studies. Unfortunately, inferior vena cava variation does not predict fluid responsiveness, more so in ARDS setting with high peaks. LVOT studies, and on top, sound is a difficult technique to teach to juniors, to non-intensivist colleagues. It is resource intensive in terms of the need of equipment, and this will be technically challenging. We have been talking about for the prone patients as well. Techniques which seem to show most promise in mini and with these fluid bolus volume patients and right volume they cut off. However, these cardiac output variation and they have to be studied. We cannot systolic blood pressure or a change in heart rate as a surrogate for these techniques because the changes are too subtle. Mini fluid challenge is improvisation over standard fluid challenge of 250 to 500 mils. So in mini fluid challenge, we give a crystalloid bolus of 50 to 100 mil over 1 minute and monitor the change in the cardiac output, cardiac index, and the pulse pressure variation. A recent systematic review suggested a very high sensitivity specificity of mini fluid challenge to predict fluid responsiveness and the area under the curve as good as 0.9. Moving to the second test, passive lung raising has been used since 2009. There have been multiple systematic reviews which do show the validity of this test. Obviously, there are certain caveats. Passive leg raising cannot be used with abdominal compartment pressures and in patients with traumatic injuries to the lower limbs. One of the improvisations of passive leg raising in our prone COVID patients is the trend walls up by 13 degrees and then the tilt down by 13 degrees. This test reliably predicts fluid responsiveness even in prone patients, and this probably is one of the only tests to do so. The third test in this category, which has shown promise, is the end expiratory occlusion test, which includes a 12 to 15 second end expiratory occlusion, prompting an increase in the venous return. And if the patient is fluid responsive, they will have an increase in the stroke volume or its surrogate. This test is accurate in cardiac arrhythmias, patients with low compliance, although the only caveat is that patients need to be ventilated with 8 ml per kg tidal volume during the duration of the test. The test shows wonderful sensitivity, specificities with area under the curve as high as 0.96. One of the limitations of an expiratory occlusion test, however, is that it cannot be used in prone patients. It does not seem to correlate very well with fluid responsiveness. Also, this test cannot be performed in a lot of spontaneously bleeding patients because they will have an effort against the occluded airway. So while preload challenge techniques show the most promise so far, let's move to preload modifying techniques. Here, the idea is to increase the airway pressure, which will reduce the stroke volume and predict responsiveness. The two tests are a tidal volume challenge and a lung recruitment. Tidal volume challenge involves increasing the tidal volume from 6 to 8 ml per kg and looking for a variation in pulse pressure. Increasing the airway pressure to 30 centimeters. These tests are accurate. There is no risk of fluid overload and they are valid and they may even be accurate in prone position. The issue with these tests are that even though they look promising, the science is still evolving. So watch out this space. In next few years, these tests, which are modifying the preload, may become the standard of care. So to summarize, we can say that the preload challenge test, including passive leg raise or a modification, mini fluid challenge test, and expiratory occlusion test hold the most promise. But remember, you do need a cardiac output monitor, a pulse pressure variation monitor with these tests. Now that we have answered the first question of, is my patient fluid responsive? The second question is fluid responsive. What is the risk of giving them more fluid? And that comes to our basic bedside assessment, including the pulmonary congestion, lymphedema, pulmonary congestion on the X-rays and the bedside ultrasound, looking for B lines, and as simple as looking at the input-output charts as well. Now, once we have decided that patient is fluid responsive on assessment and they may benefit from the fluid challenge, next comes the question of what exactly do we. Fluid administration has evolved as well over the years from recommendations for a stat 30 ml per kg fluid bolus to use of static goal-directed therapy to use of dynamic functional hemodynamic tests to guide fluid therapy. The recommendation is to avoid fluid balance and that may require early use of vasopressors. A recent systematic review suggested that use of fluid responsiveness for the goal-directed therapy in fluid administration improved 30 minutes guidelines do suggest be used in within crystalloid. Light may be better than the what we for fluids, why it is important to assess for fluids, and now moving on to some of the specific challenges in as 19 patients evolve in the same patients. Patients present in different with the evolving strains, this thing may change. Right. in a large number of patients who are overwhelming the healthcare system. Unfortunately, there is none, but we are close. What an ideal test should be, it should be performed with minimal contact with the patient. It should be easy to be interpreted by junior staff, and it has to be valid in patients with very, very low compliance, in prone positioning. What we know so far is there are certain tests which can help in this situation, although they will require a special monitor. Now, that is an interesting consideration which I want you to think about. If careful fluid management, avoiding fluid duration of mechanical ventilation by 2 days, as shown in the ARTS network study, and may be associated with improved mortality, is that cost justified? So to summarize, conservative avoid fluid overload. We are walking on a tightrope here, and that definitely requires use of careful monitoring to the functional and the dynamic hemodynamic testing to guide your therapy. Using balanced crystalloid in favor of colloids and maybe in favor of unbalanced crystalloids may be the way forward. Thank you.
Thank you, Dr. Amit Kansal. You have very well elaborately highlighted how to assess what fluid and what technique. It was a wonderful lecture. If we have the time, we'll have the question answers at the end of the. Before that, we have a last lecture in this session. Dr. Anushka Mandalig, she is visible here, or only video lecture is coming? Anushka, please be visible. Yeah. Thank you so much. So she, in fact, the 1.5 years, the COVID has taught us so many things.
Recording stopped. Recording in progress.
The COVID experience has taught us so much, and we had to modify with the limited experience and experiments in our curriculum of various managements. So she, as a topic, is resuscitation different in COVID-19? Dr. Anushka is the senior registrar with in critical care medicine, NHSL Hospital, Colombo, Sri Lanka. Thank you so much for joining us.
Hello, thank you. I hope you can see my screen.
Yes.
Yes. Sure. I'm trying to get it on full screen. Yes. Okay, yes. Thank you for that very kind introduction. Yes, I'm actually a consultant intensivist. I work at Colombo North Teaching Hospital, Sri Lanka. But thank you for introducing me as a senior registrar. I feel very young. And thank you again, the Indian Sepsis Forum and the Intensivist group for giving me and Sri Lanka this opportunity to represent our country in this very prestigious forum. It's quite an honor. So going in succession with the previous speakers, I'm actually happy to say that most of the things that I were planning to say were covered by the previous two speakers. So they have made my task easy. So my topic is resuscitation different in COVID-19. So we have already gone through this, the epidemiology, and as also I heard the previous speaker saying that of all the infected patients with COVID, 5% will have critical illness, which is defined as severe hypoxemia and or the presence of other organ failure, including shock. So now shock, the definition of shock in the same. It's a circulatory failure characterized by impaired oxygen delivery or utilization at cellular level. Basically, it's a systolic blood pressure of less than 90 or mean arterial pressure of less than 65 with evidence of organ hypoperfusion or abnormal cellular oxygen metabolism. So the prevalence of shock in COVID patients is highly variable. It depends on the population being studied. In simpler terms, in which part of the globe you're living, the severity of the illness, and the definition of shock that you're using. But roughly, it is estimated to be around 20 to 65 among the critically ill in the ICU. Of all the deaths that occur, 7% are primarily due to shock, whereas 30% it is a contributory factor. So shock in COVID-19 could be due to many reasons, but the predominant causative factor is sepsis. So this sepsis could be due to the virus itself most of the time, or it could be due to a secondary infection, bacterial or fungal. So, as the previous speaker also spoke about, Surviving Sepsis campaign was the stakeholder of defining sepsis. So, the definition of sepsis remains the same. It's only the causative factor that has changed from bacteria to fungus into a virus this time. And the management of sepsis is also according to the Surviving Sepsis campaign, which was revised last in 2016 with an update in 2018. Until the COVID pandemic came up. And in 2020, they gave another guideline based mainly on the COVID management. And there was an update in 2021 March. So from this point onwards, I will be discussing, actually comparing the difference between the two guidelines in 2016 and 2021. So the definition of sepsis, as again speaker spoke of this earlier, is sepsis is Q-SOFA or SOFA score with evidence of infection, and septic shock is a subset of sepsis where there is hypotension or a rise in lactate. So apart from this definition, the COVID update surviving sepsis guideline has taken up the WHO classification as well, where there is severe and critical COVID patients, severe being signs of pneumonia with one of the following, that is respiratory rate of more than 30, severe respiratory distress, or a saturation of less than 90 on room air. So mainly focusing on respiratory component. And critical is when there is ARDS or respiratory failure requiring ventilation sepsis. Once that is taken as time, a series of actions that we have to take in order to reduce mortality. So the 2016 guideline, as the previous speaker, Dr. Kansa, very correctly said, it gave this volume of fluid, 30 milliliters per kg to be given over 3 hours. And then there are other recommendations as well about this fluid management. But the major difference in the COVID update is that instead of giving a direct amount, they have emphasized more on using these dynamic parameters to assess the fluid necessity. And also they have gone towards more of a conservative type of a fluid management rather than going for a liberal fluid strategy. So this is kind of a major difference comparing to the previous guideline. So why is this? And the WHO also released their guideline in 2020 March, and they said to give fluids in small boluses like 250 to 500 ml and reassess after each bolus, because there's always a risk of fluid overload because ARDS. So too much fluid will increase the ventilatory days and increase the ICU stay days. So again, emphasizing the fact that kind of. And again, the previous dynamic assessment of therapy reduces more. And all study again compared lower versus higher fluid volumes during initial management of sepsis and showed that the relative risk is only 0.87. So there was no change in morbidity between higher or lower fluid volumes. And again, this study where conservative fluid management is against liberal fluid management is compared in a meta-analysis, showed that the mortality is actually not, it's the same between liberal and conservative fluid management. So why should we give too much fluid and make the lung condition worse when the outcome is actually the same with the conservative fluid management with dynamic fluid assessment? So that is about the amount of fluid to be given. Next is what is speaker talked about this, whether and if it's balance and if it's column. So since he's, I would just be already said difference in compare, and there difference between acute kidney and unbalanced, but there the cost is go for balanced grades if you don't sodium chloride. And again, starters, as the previous guideline said, it's a big no-no. Although the mortality is same as you can see here, the risk of renal replacement therapy is statistically significantly high in the starch group, as well as the transfusion of blood products, it's higher. So there is a recommendation against use of starters. And the same is there for gelatin, there is no more mortality benefit. And for the dextrans, again, there is no mortality benefit. The only difference is this albumin. In the Surviving Sepsis Campaign 2016 guideline, they have suggested using albumin in addition to the crystalloids for that initial fluid resuscitation. But in the COVID update, they actually have removed that and they have suggested against using albumin in the initial resuscitation. This is because it's because of this the same meta-analysis where they compared albumin against crystalloids, and they showed that there is no mortality benefit here as well. So why go for something which is very expensive and which again causes a sodium load instead of going for something which is cheaper and which does not cause a change in the mortality? So that comes to about what, so we have covered how much to give and what to give. So moving on to the vasopressors. So the next line after fluid correction would be to use the date has suggested using norepinephrine as the first line vasoactive, which is a weak recommendation. It is based on the Scandinavian clinical 2016, where norepinephrine was compared to phenylephrine, and as you can see the effect, there is no mortality benefit in using norepinephrine over the others. As a result, we have been using norepinephrine for sepsis for all this time, so we are going to continue to use norepinephrine for shock. Now, this there is one change in the guideline in vasopressors, that is against dopamine. In the 2016 guideline, there was a recommendation to use dopamine as an alternative vasopressor in selected patients. But in this update, they have actually recommended against using dopamine for the shock. And this is actually a strong recommendation. And why is this? It is because of this study by Gamper et al., which was published in 2016 on vasopressors for hypotensive shock. And here, what they showed is, again, when dopamine was compared against norepinephrine, the mortality, there was no difference. But if you look at the arrhythmias, the risk of arrhythmias, dopamine had much higher rates of arrhythmias, which was statistically significant. So ultimately, there was no mortality benefit of using dopamine over norepinephrine, but there was increased arrhythmias. So they have made a strong suggestion to not to use dopamine in septic shock. And then the 70th recommendation in hemodynamics is they have suggested to, apart from norepinephrine, you can use vasopressin and epinephrine. Or if you have gone up on your norepinephrine dose, you can add on vasopressin to reduce the norepinephrine dose as well. So these both of them are weak recommendation, and it is based on the same study. As I mentioned earlier, norepinephrine was compared against vasopressin as well as epinephrine, and the mortality, there is no difference. So it can be used instead of norepinephrine. And again, on this, based on this practice guideline, the Canadian Critical Care Society Clinical Practice Guideline, which was published in 2020, which they compared vasopressin against catecholamines. You can see this top column shows that the mortality, the relative risk is not difference between the two, but the grade of certainty is low. Whereas for stroke and digital ischemia, vasopressin actually caused higher levels of stroke and digital ischemia, but the grading, severity grading was moderate. Whereas atrial fibrillation was much less in the vasopressin group. And there was high certainty on that. So what you have to use, remember is you can use vasopressin, but there's a caution that there could be digital ischemia as well as there's a risk of stroke, but the atrial fibrillation rate is much reduced. So now we have talked about the vasopressors. Noradrenaline comes first, adrenaline and vasopressin comes second. There's no more dopamine. And the target is 60 to 65. Gone again, less than guideline, which was actually a map of 65 was the target in septic shock. But in that guideline, they made this comment saying that a subgroup of patients with previously diagnosed chronic hypertension had a higher map. So they use thinking that maybe for chronic hypertension we should do it. But then came this study, a randomized control study in 2020, where they compared permissive hypertension, that is a blood pressure map of 65 against usual care patients over 6. As you can see, the mortality at so the ultimate conclusion among patients who are 65 years older, permissive hypertension can be a difference. And in lower blood pressure target shock, 18. The ultimate mortality at days is all limb ischemia. There's no all limb ischemia versus lower. It's a treatment effect, that is before the patients were on, if the patients who were on higher vasopressors to maintain a higher MAP, and they found that the death rate was high, not because the patients had chronic hypertension or had congestive heart failure or were elderly, but because before randomization they were on higher vasopressor doses. And also the risk of arrhythmias was 2.5 times higher in the higher MAP group. So our target MAP about 16 in part. This update also suggests dobutamine if they, despite using fluid, but this suggestion. Scandinavian clinical practice, dobutamine was compared against and milrinone, and the shorter data is quite scarce. In the only day there is no more women over the other. To go through the dobutamine difference, or there is a change, or there is effect or kidney reasons of physiological dobutamine. So we can use then another from 2006 it is the use of corticosteroids to under recommended resistant shock. Actually, in the to use a short course of systemic corticosteroids using corticosteroids. There's weak dexamethasone. One might know that according to this meta-analysis, where there was significant, you can see the 0.86. There's a high quality evidence to use to reduce patients. 6 fewer deaths who were treated with corticosteroids. This is so powerful trial to use, unfortunately, moderate quality data for dexamethasone only. Prednisolone, the quality of data is low or very low. Recommendation for dexamethasone. Then there is another major change that is recommended using appropriate microbiological cultures within the first hour. Virus rather than in case there is infection cultures. Microbial therapy, telling again the patient update. This is invariably due to an antiviral. Any antiviral remedies where that mechanically ventilate COVID actually do not have a straightforward treatment. Sepsis. Come to the end of my talk, where I stabilization of critical guidelines we followed earlier with therapy and taken and the steroids. At it, treat during organ failure management. Thank you. Thank you.
Namaskar. First of all, I apologize for wrongly introducing you.
No, that's fine.
Get you that it's a complete review of collection of the list. Said more than
yes, yes, would say, would you like to go ahead with it, or you come? If you see discussion clear, and we had all anything to discuss on that, on the perspective on that. Certain things are very, of course, it's still not robust data are available, but of course, as far the guidelines are concerned, we are the evidence you got to accept. They can go ahead, protocol what going. Some people. So something which local protocol to certain extent are still yet then as per certain things on and the depending upon resource, don't have instruments with you, the dynamic still stick on aspect of the measurements as well. Fluid therapy on the basis condition, I can still, but again, keeping in mind the limitations of your institution or where you're working, it depends upon that what you're going to use. As far as Rakesh was concerned, Rakesh, I think excellent. You said all the predictors which are which will preempt you or which will help you out to go ahead with the early management. We know that you should be very you should preempt or you should always predict that these are the people who's going to you got to take an aggressive management. Certain they are all, there's no predictor to early management. Single predictor that is the finding, and you have to collect all those. The more the number of your assessment. So instead of number of predictors, to certain extent, these patients who are stressed, so that management on these patients guideline where that these are the patients where TLS we saw so certain changes I think we should need to which the guidelines say, and these are the certain things which probably I can understand. Otherwise, it is absolutely must have learned quite a lot. So much. Go ahead with the
See any questions? We're only running late.
Fairly analyzed completely. Enough.
Thank you, sir.
This opportunity.
Thank you. We move on to the next session. I'd like to invite the chair, Neeraj Tyagi, from Hospital, a very dear. Dr. Nath is Professor in Lucknow, and CEO at Eminent. Over to you, Chair. We have only one talk because later in the evening because of scarcity of time. Over to chairpersons.
Thank you. Congratulations. I mean, we have been talks in organs, and I really appreciate this effort of yours, which has multiple. When we talk about, it's a privilege to invite a young speaker who is a research fellow in critical care program for global health in Sydney, and he's going to talk on a very exhaustive topic of managing pandemic and preparedness in terms of ICU in Asia Pacific setting. When we had, be it generalized 1,000 population or intensive, far less as. So over to you, Dr.
Hello, everyone. It's good to be here. Disaster. Sepsis medical condition, organ dysfunction, dysregulate. The availability of the organizational support, resources, clinical standards, lab, as well as therapeutic options in Asia Pacific region to manage this condition. Asia Pacific Sepsis Alliance, known as EPSA, it's a regional network of global sepsis alliance, which conducted a survey across the Asia Pacific workers, policymakers, facilitated. This survey was adapted from a similar survey which was done by Latin American Intensive Care Network, and it was developed by a working group of critical care clinicians as well as researchers, both from LMICs and HICs. A survey included questions broadly in critical care resources, sepsis guidelines, with an obvious focus on COVID-19 pandemic. Now, the survey was approved by the Chinese University of Hong Kong, which represents India, Vietnam, and Hong Kong. Survey was conducted during early part of COVID pandemic in the month of April and May in 2020. Asia Pacific shared this survey, who then shared with their contact. Survey was administered via SurveyMonkey, and on an average, it took complete. The data was stored by the Chinese University of Hong Kong. Coming to results of the survey, the right geographical distribution is weighted or were high and 7 were low middle. Total 50 by India. There's a hospital population, whereas hospital hospitals in or either touch, whereas it was and the majority hospitals, number of hospital beds and hospital admission as well as ICU and HDU beds were comparable among the three cohorts. Whereas the IC level, again, as we can see here, highlighted in the red box, the majority were level 3 ICUs in HIC and LMICs, whereas in LMICs, as we can see here, so it was more evenly split between level 2 and level 3. This slide shows the back. Workforce. And nurse ratio in HIV in LMD caters to patients. The below chart shows the percentage of ICU on y-axis and really how many ICUs had access to intensivists as well as other allied health care. As you can see, the presence was about overall and slightly low in LMI and case of presence of 20, which was but to the diagnosis, left 7 in viral. So the RT-PCR was not universally available, and one reason could be because the survey was conducted during the early phase of COVID pandemic. And as a side note to that, the median time for RT-PCR was 50% higher in LMICs compared to HICs, which is shown here. Now, coming back here, LMIC out now they were mostly available, maybe procalcitonin, and in various screening like tox screen and other tropical diseases screening, it was not universally available. Now coming to the various clinical interventions and monitoring, as you can see here, conventional modalities like non-invasive ventilation or invasive ventilation were universally available, but not the basic modalities such as high flow nasal oxygen, which was very low in low middle income countries and about 50% of ICUs. The good thing is that the advanced modalities like ECMO and CRRTs were available in 60 to 70% of ICUs overall, and they are expectedly lower in LMICs compared to HICs. In terms of the various monitoring, as you can see here, so was highlighted in monitoring device such as end-tidal CO2 was available only in about 60, slightly more than 60% of ICUs in LMICs. In terms of fluids and vasopressors and steroid use, it was fairly consistent and used in most ICUs. Whereas the lower chart, which shows the uses of antimicrobial agents, so again, the use of remdesivir was very low, potentially because the survey was conducted during early part of COVID pandemic, whereas the use of other antivirals was fairly high. As we can see here, the essential antibiotics, the uses was fairly high and the availability was fairly high, whereas the access to the reserve antimicrobial was inconsistent. Some were, the access was very good, but for others it wasn't. Now coming to how these ICUs they follow and what's in high-income countries followed any sepsis guidelines, which means that there were 23% of ICUs which sepsis guidelines. Again, highlighting adherence, so lower in high-income countries ICUs and upper middle income. That is another in LMIC, 1% they use LMIC. ICU then sepsis management. In terms of quality improvement, as sepsis control measures such as infection control, universally done by more, whereas the antimicrobial stewardship program was 90%, which is a routine ID consult for sepsis patient. So that is something which needs to be looked into, how that can be improved. In terms of various kind of research, as you can see, so most research were able compared to LMICs. It could be because of the resources and other factors. Likewise, the slightly higher proportion of ICUs were involved in multi-center as well as industry-sponsored research in high-income countries compared to middle-income countries. In terms of disaster preparedness or COVID-19 pandemic preparedness, the PPE availability was very good, both as in LMIs, the availability or access to the respiratory disaster. Again, access to PPE guidelines or the screening or isolation guidelines or the search management. It was done in almost in all ICUs, but the search choice guidelines were not followed by all ICUs. Whereas the workforce staffing and the training is something which was lacking for the workforce. In terms of the ICU, expectedly it was low in ICUs compared and difference was ICU beds with the type of theirs, ICU beds capacity. So ICUs in LMICs, they are able to add a lower number of ICU beds in case of a surge. Peak ICU is LMICs compared to HICs. So those were the key findings me providers. So these findings can really can help in improving healthcare delivery in the management of sepsis. Whereas for health policymakers, they can facilitate optimal allocation of the scarce healthcare resources, particularly in low and middle income countries. For researchers, these really give some food for thought and really deep diving into the areas which need further research and then generate evidence in those areas. Just a wrap on key survey findings. So as we saw, the critical care management of sepsis is varied across Asia Pacific region, particularly around nurse to patient ratio and the allied health. Conventional organ support modalities like mechanical ventilation were commonly available, and advanced life supports like also available in about 60 to 70% of the surveyed ICUs. But the essential monitoring devices like end-tidal CO2 was not universally available, which needs to be looked into. The adherence to sepsis guideline is better in LMICs than high-income countries' ICUs, but only 21% of LMS ICU use a sepsis management guideline specifically prepared for these countries. Essential antimicrobials were accessible across most ICUs in the region, but availability of reserve antibiotics was inconsistent. In terms of pandemic and disaster planning, well, the PPEs were widely available, but LMSs had much lower provision for isolation and surge capacity. End of my presentation, and I'll be happy to take any questions. Thank you.
Thank you, Dr. Ashwini. That was very eloquently put. And I think if one take-home message that I can endorse from your talk is on their geographic per capita income as low and middle income or high income, it's better now to have guidelines based on ICU resources per se. So there are ICUs which are there in metropolitans of low middle income companies which have resources as exhaustive as any other high income ones. But in the same city, you may have an ICU which lacks even a basic non-invasive ventilation facility. So when we are designing and trying to collaborate about formulating any kind of guidelines or position papers or even recommendations about, we should rather give it, be it human resources for these ICUs or in general for the hospital. I think this is we are running short of break into the from
any comment? Dr. Yash.
Audible, yeah. Audible.
Am I audible now? Dr. Ashwini, that it you see very rightly pointed till the point available in most of the thing is that we don't use them. We can cut down on the need of AVGs in a big way. And we should sensitize our staff to it's only a PM line that is needed. Just you have to connect values. So this is a very important point. And the other point, what I would agree with my that Asia Pacific region, so it's very difficult to Asia Pacific regions and talk, and it's a eye opener for all of us. Thank you, and I'd like to congratulate Dr. Ashwini for this exhaustive research he has done, and thank you, Dr. Yash, for.
And yeah, I just like to say, thank you, Dr. Yash, for inviting me. For the
Dr. Ashwini, I just want to ask you one question.
and exhaustive survey. The versus urban.
So the only Dr. Sanjay, so that's a good point. But it's the in LMICs were tertiary care or the that's the one indicator. HIC, most were actually the regional hospitals. So which kind of, the point, which was brought by the first chairperson in terms of the disparity, because, and that's absolutely correct, even in country like Australia, in the regional hospital, they are not, very resource full ICUs or hospitals. So that needs to be, kept in mind while comparing.
Yeah, that's.
Chairpersons, thank you. We have devised a new sepsis survey, and probably within a week we should be able to launch it. Dr. Ashwini has been guiding us for that survey, and Cipla will be helping us. Thank you, Dr. Ashwini. We move on to the next session. Next session is again a joint meeting between American Society of Microbiology and Indian Sepsis Forum. I'd like to invite Dr. Priyam Batra. Dr. Priyam Batra is Assistant Professor, Department of Microbiology, All India Institute of Medical Sciences, Delhi. Over to you, Dr. Priyam, for this session. The first,
I think you can start with the presentation. Yes, Dr. Priyam is little occupied.
No problem, madam. So we have Dr. Sarita Mohapatra as the first speaker. Dr. Sarita Mohapatra is a senior microbiologist. She will be talking about gram-negative sepsis in COVID. She's additional professor, Department of Microbiology at All India Institute of Medical Sciences. Over to you, Dr. Sarita. Can you please play the presentation? The person you are calling is currently busy. Please. Dr. Sarita Mohapatra, stop please.
Good afternoon, everyone. Dear participants, I, Dr. Priyam Batra, on behalf of the AIMS, welcome you all to the American Society for Microbiology session. ASM is playing a key role in advancing microbial surveillance in the first Sarita Mohapatra. Negative sepsis in COVID. LG aims new. She has various to her of Lancet. I request Sarita's video.
Dr.
Dr. Sarita.
Okay, meanwhile you try to locate the video. We move on to the next topic.
Is available.
Do you have Dr. Ramachar? I would just like to Dr. Rama.
Yeah, I think Priyam, they are starting with Karnikas. That's fine.
Okay. Will be delivering her lecture on neonatal assistant professor. This is and she is this fellowship program.
A very good afternoon, everyone. I, Dr. Karnika Sehgal, will be discussing with you topic neonatal sepsis. Before starting with the topic, let me introduce you to my hospital, Chacha Nehru Bal Chikitsalaya, located semi-urban of Delhi and adjoining to and it has a dedicated NICU 20 3 care as well as a kangaroo mother care. Now, when we start managing a disease, we have 5 areas. There is a features of a disease, there is a lab parameter, diagnostic algorithm, sepsis. 5 areas are the gray areas of neonatal sepsis. Till date, there is no sepsis. The clinical features are really tricky to diagnose. Physiology. So the is a diagnosis. Diagnostic clinical view. Sepsis such limit as the they are on with the remind than us. Sepsis has we have with the tiny bugs and dealing at when they are really love them. So first, starting with early onset sepsis, we will be case old female was admitted with the child was pulse was and the were deranged. Other was antibiotic. D was also cry diagnosis of meningitis with septic shock was there. The child was there in the NICU, and after 3 days, the CSF also, the CRP was very high. Others were in normal limit. The treatment of cefotaxime was initiated as per a hospital antibiotic policy. Isolate, which was only sensitive to colistin. Now, day 5 of life, the child has Klebsiella and meropenem was the child have coming to from we need early onset there in the neonate and was sepsis screen was positive in this child when he was there in our emergency. Were there any lab parameters which would have directed me on day 1? Yes, it is cholesterol. The right choice. Unexpected, and how a delay of 3 days A rapid diagnostic test, was it not available? So, it's a case. Sepsis is it is a hemodynamic change due to a pathogenic virus to CSF of life. It is occurring. That is first 72 hours. It will be early onset, late. But many of more than 7 days will be late onset sepsis and less than 7 days. So this was obviously a early onset neonatal sepsis. Present in the early onset child is this is word. The streptococcal develop, that is amnitis are word. Amnitis, if you see, there has been paper published on immune response, fetal immune response. It modulates the fetal immune response paralysis due to chorioamnionitis are highly exposed and case we could not elicit this as mother could not tell us structured. So it was difficult for there was important risk factor. If you see cause in the would have having certain nutritional deficiencies and child to acquire. These kids smart functional immune response. This distinct will be altered if there is nutritional flora or prolonged antibiotic. We looked in future in developing nations. Now, what is this EOS? As the little the child, a neonate, the more chances are there. In a preterm and the 2 years of age. But globally, there are neonatal sepsis cases, clinical sepsis, which lack live birth. It on case fatality, approximately 23 range to 25 to 65% as per the latest review article which has been published. So was sepsis screen positive in our case? What is say, because there is no very well defined sepsis, we should have a certain or a hospitalizational specific character, the lab parameters and the clinical parameters, and train all the GRs, the SRs, and the doctors working in the triage area so that they can identify neonatal sepsis on one go. A set of abnormalities, basically we want more than 3 system involvement along with the you should think about neonatal sepsis. So in our child, the case which we are dealing had apnea, had poor perfusion, and had instability body temperature. Along with the lab parameters were 2 lab parameters were also deranged. That is, the platelet count were decreased So yes, like the word have developed these types and there to stop the misuse of antibiotics. Diagnostic septic shock so far scoring on a very large parameters diagnosis is all other model toward positive predictive. CRP, total neutrophil ratio, platelets, all these are just support to a blood culture. The PCT, if I tell you, PCT should not be done in neonates because in as well as preterm infants. Depending, the child has meningitis, CSF sample should also be taken. Concept neonatal sepsis is generally not recommended. We screen positive itself. Was cefotaxime the right choice? If you see the Western world, they say their major causes are gram-positive and streptococcus %, but this is not the data which our hospital says. In our hospitals, of the total over we of which was gram-negative bacilli. So accordingly, our antibiotic policy says clinical sepsis with a moderate illness, as was this case, with amikacin, and wait for the published in Lancet in year 2000. If you see, cefotaxime is of has been decreased from 17 to 20, of which drug resistance. This is the paper study which was published in Delhi, was conducted in Delhi. It was a large cohort, which also mentions that gram-negatives dominant. Likewise, the South India also says the gram-negatives MDRs are common. So yes, line was a good choice. Was the etiology expected? Klebsiella pneumoniae, only sensitive to colistin, that too in a day 2 child, early onset sepsis. If you see the Southeast Asian neonatal sepsis data tells in Klebsiella, meropenem resistance is 0%, but that is not the case which we see in our center. In our center, if we see of the total cases, the gram-negative, the predominant are Klebsiella pneumoniae, of which caused 25 cases throughout 2016 to 2020. NICU BSIs were due to Klebsiella pneumoniae. And if you see the sensitivity pattern is really alarming. Paper which had our center on this that year. Klebsiella, the 54. Expect how laboratory we tactic BD, we have Malvitic and giving sensitivity. So require the bed there, people say they are, then there is PCR, RFLP, they are chip, all have a all and the profiling, RNA profiling pipeline blood culture. So this was the minimum There are certain biomarkers like serum lactate, role. These are very role is seen in neonatal sepsis. Now, answers which I have already given you, that is late onset sepsis. Now, this was child delivery, small for gestation, in our hospital on day 4. This was our aspiration maximum on that is on the day of child was transferred to me. The respiratory in line of policy, the child was shifted to 5%. Please, again a repeat sample which was done 2 days later, but he still continued with piperacillin tazobactam. There was right hypochondria, hyper reflexes and tone have decreased. There is lot of distension on blood culture. On X-ray, abdomen, there was a duplicate tazobactam along with amikacin was 24. The child worsened. Hypothermic, ultrasound, periculture grew candida pelliculus. Present day 36 of life is still continued. The patient is admitted in a NICU. The clinical condition has improved. The CNS has come with a clean. So was sepsis screen positive on admission? That is it true? Late factors predispose the child to LOS. Was this ecological agent expected and was this a hospital acquired? Let's have an answer to these. Was sepsis screen positive? No, the sepsis screen was not positive because the lab parameters were not deranged on the day of admission and the child only had one system involvement, that was apnea and respiratory distress. So was hemolyticus a true pathogen? If you see, hemolyticus is coagulase negative staph are considered as one of the most common causes of late onset sepsis in the developed world. But in our case, that is not the case. The most important cause that isolate 2 days to be a or septic culture at time. This is the etiology from negative predominant in late onset sepsis, but the DDD of vancomycin and cloxamine, that is, they are not considered. This again highlights the lacuna of blood culture techniques and a disadvantage of using automated blood culture systems which are highly sensitive. Did child develop late onset sepsis during the hospital stay? That means, yes, the child developed late onset sepsis because I told you as per the definition, they can develop it up to 3 months. There was involvement of 3 distinct symptoms, altered lab parameters, and developing within 3 months of life. So yes, it was late onset sepsis. What risk factors pre-sepsis? Obviously, the paper it says immune during gap all predisposed a child to late onset sepsis has microbiome is totally altered. They clearly tells you in 750 gram or 750 gram to 1000 rate how much grows. So now, was this etiological agent alarming rates of antimicrobials in outborn neonate? This was paper only from Earth. The importance of Candida species. This is the 20 from a % of late onset Candida. So was it a hospital acquired BSI? We know as per the definition at BSI because it was acquired after day 2 of hospital admission. Etiology of BSI. These are the rates of BSI in our NICU. Throughout 2020, there has been a uniform trend line. We have ranged between 2 to 3.5, the BSI. And these Candida. Luckily, we have not isolated. So in that case, our hospital these early empiric management, which is started, and like the first says that we have to administer microbial prophylaxis. That case that only has to be given when there is a prophylaxis is given in a NICU as well. When birth weight or for early neonatal sepsis, it is recommended when there is a known case of mother given. Sepsis, depending on the staff and the doctors to wash their hands. There should be proper catheter care bundles, and the mother should again and again be told about breast milk feeding, the importance of probiotic therapy to counsel might sepsis when the patient. So this is just some. The red ones tell partum should be done to prevent early onset sepsis, and the purple one tells to prevent the healthcare associated or the late onset sepsis prevention should be done. So the key message with my talk was definition of neonatal sepsis still doesn't exist. The incidence of neonatal sepsis is high in low income and middle income countries. Etiological agents of death vary. MDR pathogens in early onset tests are required. Infection control practices needs to be practiced with full hygiene. Implement antibiotics toward breastfeeding should be promoted. Now these are the warriors. The first is the nurses and trying to there is of helping come and the last the most guiding. So let's try to catch a healthy bug, not an MTR. Thank you.
Thank you, ma'am. Now we head to the next session. Now we've heard so much about MDR, so now we have to learn about things, that is the alternative strategies to combat the MDRs. Will be Dr. Rama Chaudhary. She needs no introduction. She is the professor and head of the Department of Microbiology, AIMS, New Delhi. She is the international ambassador for the American Society for Microbiology in India, and she is a member of the ASM ambassador. She has mentored many students and the MD students. Now I hand over to. Can you please play the talk of Dr. Rama Chaudhary?
Good evening. I will be talking about alternative strategies to combat antimicrobial resistance. As we know that antimicrobial resistance is becoming a worldwide problem, and we are facing a real public health crisis because most of the organisms in the hospitals, they are becoming resistant to all readily available antibiotics. There are hardly any antibiotics in pipeline, and there is a rising mortality and cost involved in managing these infections. So if you see, these superbugs are just tip of the iceberg. There is a lot of accumulation of resistance to multiple antibiotics. There's self-medication and poor compliance, inappropriate use of antibiotics, weak surveillance and regulatory systems in place, and continuous natural evolution of resistance in bugs, which is leading to increasing problem day by day. If you see to 2000, no major classes of antibiotics were introduced in the last 55 years. And it was only lipopeptides and oxazolidinones which were discovered between 2000 to 2010. So with such a limitation where these antibiotics have been working at all levels, whether it is at DNA or cell membrane or working on the ribosomes and leading to development of drug resistance, this is becoming a major problem day by day, and we need to look for other strategies which can take control of it. So if we know that, as we know that it is usually the overuse, underuse and misuse of antimicrobials, which is happening in clinical medicine, it is happening in veterinary medicine, in agronomic and industrial practices, control infection. This is how the cause of antibiotic resistance is. As we know already, overprescribing of antibiotics, poor compliance, unnecessary antibiotic usage in agriculture, poor hygiene and sanitation practices, poor infection control, and lack of rapid diagnostic tests, which is leading to increasing drug resistance. And in India and developing countries, there is no restriction of over-the-counter dispensing of antibiotics, especially given without any prescription, and that is where the problem keeps increasing day by day. So what are the other prevention strategies before we go to others? Like we know that whenever there is infection, there is antimicrobial use, there is antimicrobial resistance, there is MDR and XDR pathogens coming up. And unless we break this circle by preventing infection, by having effective diagnosis and treatment, optimizing the use, and preventing transmission, we cannot really control AMR problem occurring worldwide. So what are these alternatives to antibiotics? These can be in the form of probiotics and prebiotics. They can be antimicrobial peptides. They can be certain other strategies like using viruses such as bacteriophages for killing bacteria. Some enzymes and certain other plant products have also been used. So I would like to share have some experience into it. Of life, they are given in our body, the benefit response, please stabilize the gut. This is the intestinal, vaginal enhance innate and adaptive immune response, which in turn aids to the eradication of pathogen infection. They also diarrhea and patients who have been taking antibiotics. Probiotics do not contribute to and may even reduce it, like lactobacilli, safe to be given to the patients. They have minimal intrinsic resistance, and the spread of this resistance is again minimal. And even CDC is now actively researching on this subject, if probiotics can be given to the patients, and in addition to antibiotics or as an alternative therapy, so that the risk of developing antibiotic resistance can be minimized. So if you see the probiotics, they can prevent antibiotic resistance because, as I said, there is a clear association of microbiome alterations with a progression from health to disease. And of course, you need to have a definition of validated biomarkers. The precise benefit in probiotic-induced microbiome also needs further studies, and probiotics are very strain-specific. So therefore, usually they do not act on, you cannot use every probiotic for all the conditions. So you have to really determine that which particular strain or which particular probiotic. So that kind of information needs to be probiotic. So we did a randomized among infants in rural India. This study was NIH funded, and it was one of the global network project which we did with University of Maryland, and is occurring in early infancy, which resulted in 1 million annual deaths worldwide, was the subject of the this particular project. And since there are no efficient means of prevention early infancy, or what we call it as neonatal sepsis, we conducted this randomized double-blind placebo-controlled trial of an oral symbiotic preparation which contained Lactobacillus plantarum plus some fructo-oligosaccharides in rural Indian newborns. And we enrolled around 4,500 cases. And in this, we found a significant reduction in the primary outcome, where both in the treatment arm was much less as compared to the control arm. And there was significant reduction also seen in culture positive and culture negative sepsis and lower respiratory tract infection. So this particular trial showed that outcome variables, death and sepsis, were significant, and also the culture positive septicemia was much less in the treatment arm, that is the probiotic arm. So this was one of the bigger study which has shown the benefit of using symbiotics in rural population, and was a very effective strategy. There have been many other reports of probiotics, but I'm just giving few examples because of lack of time. Then we have other strategy as antimicrobial peptides. These are peptides which can be, which are small peptides which are abundant plants, and of antibiotic resistance concern about development of different antimicrobial peptides which can be used in different fields, whether it is medicine, food, etc. And they also use certain strategy to kill the bacterial or fungal or whatever microorganisms we are using. The source can be, as you can see, can be from different variety of living organisms. Then the activity can be antibacterial, antifungal, anti-inflammatory, antiviral, and so on. There can be different types of antimicrobial peptides, and they have a different structure, which can be alpha helix, beta sheet, linear extension, etc. So coming to the action, as we know, the antibiotics acts either on the cell wall, cell membrane, or certain ribosomal units like 30S or 50S subunits. And antimicrobial peptides, they really act by membrane disruption. These are some of the examples of those antimicrobial peptides. They can even nucleic acid. So been used by different mechanisms to of microorganisms. So how this AMP works, these amino acids work inserting into membrane bilayers to form certain barrel stave, carpet, or toroidal pore mechanism, and they lead to inhibition of nucleic acid synthesis, protein synthesis, etc. And these are certain examples which are given here, that some of the anionic peptides, they may act having intracellular action. There are others which are acting as transmembrane pore forming mechanism, and these are important mechanism of action which can lead to the killing of the target cells. So if you see, these antimicrobial peptides have already reached the clinical phase of development, and some peptides like isiganin has been used in external otitis, mucositis in patient receiving radiotherapy. So this is a common problem which occurs when patient is on radiotherapy. Then there are some gram-positive skin in Staph aureus. They are associated with antimicrobial peptides. This is the formulation, clinical range of clinical studies. This is actually a review article which talks about that the new era of antibiotics is actually the clinical potential of these antimicrobial peptides, as the development of resistance is not there to these antimicrobial peptides, and many of them are the natural, they may be. Another example where a novel peptide BF2 has been used against VRE. So this is study from AIMS only. Then we also anti-proliferative property from AIMS, and our lab also did a study on ST8, a novel therapeutic agent which is used against multi-drug resistant gram-positive foci. So some of these studies which have been done at AIMS have given good result that these antimicrobial peptide may be a good alternative to other conventional antibiotics in certain situations where we are left with no choices after using almost finishing all the battery of antibiotics we have. So the like receptor on the bacterial cell, they attach to that cell, and they inject the generation of bacteriophages inside the cell, and ultimately leading to the lysis of this bacteria. It was very popular even in India, and again after this era, because we have hard prevention of human infections. Even in veterinary medicines, these antibiotics have been used, agriculture, food safety, and even in environmental protection, like for sewage treatment. Some specific example, so bacteriophage therapy has been done for treatment of multi-drug keratinosa infection in cystic fibrosis patient. It has also been used in engineered bacteriophages have been treatment of bacterium abscess. So in treatment, it is a very big challenge. Microbial etiology, antibiotics. So this chronic bacterial treatment. The perfect predator, doctor, and the struggle against a deadly superbug infection, which was treatment with bacteria. This person could survive, and we were happy to hear the couple when they came to India. This research and using the as a source of looking for these phages, drug resistant. We may these bacteriophages to look for whether they have any lysogenizing genes, because that gene can only lytic action can be there. Coming to this is the research. Since the molecules which can be used, shown that functional diversity of antibiotics discovered, and these by bacteria against other strains of bacteria, like the same species or different species, and can be used as an alternative treatment. Coming to fecal microbiota transplantation, I am sure most of people are aware about this, especially in Clostridium difficile diarrhea. This is used as one of the alternative treatment. And in fact, in the recurrent C. difficile infection, which is one of the good strategies, microbiota transplantation has been, this to the patient major limiting factors. And as I said, for C. difficile, a trial has been done in Portland and some other countries, where they've shown that in the large multicentric retrospective cohort, FMT is effective and safe for the treatment of CDI in children as well as young adults. So with this, I would like to thank the organizers for inviting me and sharing my thoughts on different antimicrobial strategies. Thank you very much.
Thank you so much, ma'am. Now I request the organizers to please play Dr. Sarita's video. Dr. Sarita is working in the Department of Microbiology, and she has poster credit. I request to please play her video.
Good afternoon. First of all, I thank for giving me the opportunity to speak in Indian Sepsis Forum 2021. I'll be talking on gram-negative sepsis in COVID. So in my lecture, I'll be basically covering the epidemiology of COVID sepsis during the first wave, during the second wave, its impact on the hospital, and what are the future plans. The life threat by dysregulations such as bacteria, virus, or fungus. The mortality is very high in this condition. Treatment is generally supportive in nature, involving administration of IV fluids, oxygen, and antibiotic to eliminate. The identification of great concern urgently. What happens? It mainly infects the lung cell, which damages the lung infrastructure. They attract the inflammatory cell to the site, particularly the neutrophil and the macrophage, thereby promoting the inflammation. There is epithelial damage at the site, which further at the site. Thereby, there is invasion of the bacteria into the cell. Proliferation leads to low depending and several literature, the emerging evidence on superinfection. There is increasingly raised hospitalization of COVID-19 patients. The specific nature of these infections are not very risk of and super with AMR. These patients found to have increased level of infection-related biomarkers and inflammatory cytokines, which are as a part of dysregulated immune system. However, they were not very helpful to differentiate a viral sepsis from a bacterial sepsis. Literature on fungal and bacterial co-infections in hospitalized patients were published from different geographical areas. This is a report from New York City where they found the infections were found from the bloodstream infection as well as from the respiratory infections. Majority of the patients were having devices, especially the central line, and 51% of the total patient having central line were having bacteremia. The mortality was found to be 57%. This is another meta-analysis which consolidated the result of 30 studies where they found 7% of the total patient were infection. It was 15 to 20% higher in severe COVID-19 patients. Among them, 50% are non-survivor and 31% belong to the ICU. Majority pathogen belong to the escape group of pathogen having very high resistance. Both GNB as well as GPC were isolated from this infection. However, this is the first report which says the emphasis on GPC infection in these SBIs, and Mycoplasma pneumoniae was found to be present in 11.7% of total infection. Other rare pathogens such as Legionella pneumophila, Haemophilus influenzae also found to cause SBI in this group of patients. More or less, the SBI infection were caused by the pathogens which are causing HAP or VAP, particularly the carbapenem-resistant Enterobacteriaceae and the carbapenem-resistant Acinetobacter baumannii. However, people also realized that there are several limitations in the initial studies which were done by September 2020. There were variable rating, there were high proportion of patients who are already in the empirical therapy, retrospective nature of current literature, no clear-cut definition for critical and non-critical patients, and no information regarding the hospital care, healthcare facility, length of stay, risk factors, or exposure to any other risk factors or device use. So later on, people try to look at this, addressing these questions, and this is a study targeting the severe COVID-19 patients. Here, severe category mainly defined the patient who required mechanical ventilation, and they found that 60% of these category patients, they developed secondary bacterial infection, and 90% culture confirmed after intubation. After approximately 18% were having multiple bacterial species infection, especially in VAP, and there is a high rate of antibiotic prescription in these patients. However, the challenges that the authors made during this study were regarding the diagnosis and management. There were prolonged culture positivity was found with the same bacteria despite of proper treatment, and it was difficult to distinguish between an active infection and a colonizer due to persistent raised inflammatory markers. These were the list of etiological agents which are found in different specimens. As we can see, the respiratory specimen was the commonest infection, followed by the blood and others. The golden tone were representing the gram-negative infection, and the purple tone were the gram-positive cocci infection. So we can say that in respiratory tract infection, the gram-positive as well as the gram-negative play almost equal. However, there were more dominance of gram-positive cocci in the bloodstream infection. The point among the institute, it has we could able three other apart from SARS-CoV-19, and we found that bacterium were most common etiological agents for this secondary infection, followed by virus, fungus, And many patients, they are having co-infection with bacterium virus or bacterium fungus. And if we'll see the etiological agent, Staphylococcus aureus predominantly found in this respiratory tract infection, followed by Klebsiella pneumoniae and other infection. And majority of our patients were on combination of antibiotics. There were also reports that increased secondary infection due to usage of steroids, whether it is a bloodstream or respiratory infection or urinary tract infection. And it was concluded that increase in the bacterial and fungal infection was there in COVID-19 patients with steroid use. Apart from hospitalized patients, there were also reports from community onset bacterial co-infection in these COVID-19 patients, which later on required hospitalization. This is a study catering 38 hospitals, and here the community onset SPI was found to be 3.5%. Though the culture positivity rate was low in this group of patients, a very important finding, what was more worrisome, was found that most of the patients, they were having empirical antibiotic treatment as a part of management. Also, there were various reports characterizing the bacterial and fungal infection prior to COVID-19, and they tried to see the community and hospital-associated infection progression during the pandemic. And it was found that the co-infection in the community-associated group by the community-associated patients are 6%, whereas HAI was found to be 12%. Important finding what found in this study was majority of the infection were caused by GNB, that is 57%, followed by 19% by the fungi. And the rate of infection by the GNB as well as the increased rate of antibiotic resistance was found with longer hospital stay. Also, variation in the etiological agent for the bacteremia were found from different geographical regions. This is a multicentric study from UK, which found that enterobacterials, which are usually the common organisms or the common etiological agents causing bacteremia, were found historically low across London during this pandemic, while the coagulase negative staphylococcus were found to be historically high for these infections. The increased number of coagulase negative staphylococci in non-Klebsiella bloodstream infection during the pandemic may reflect the increased rate of contamination during the collection of samples, and this highlights the challenges of aseptic techniques in full PPE and potentially impact the antibiotic stewardship as well as resistance emergence in the hospital. There were also reports from national surveillance for bacterial and fungal co-infections in COVID-19 patients, and it was highlighted that high proportion of the COVID-19 patient received empirical antibiotic therapy irrespective of their bacterial etiology. ICMR has also published a literature where 10 hospitals were analyzed for the COVID-19 patient. This is a retrospective study. The 10 hospitals participated here, which are already there in the ICMR AMR surveillance network. And it was found that most common infections caused in this cohort of patients were caused by Klebsiella pneumoniae, followed by Acinetobacter and Pseudomonas and E. coli, which is slightly different from the earlier published AMR report, where usually E. coli was the commonest etiological agent for most of the infections. If we'll compare the Klebsiella pneumoniae resistant pattern with the Acinetobacter baumannii resistant pattern, both the bugs were highly resistant in these patients. However, Acinetobacter baumannii found to be more resistant for all class of antibiotics, whether it is carbapenem or BLBLIs, third generation cephalosporin or aminoglycosides. They have also a 7 patient who died had gram-negative infection of the patient. Assess the empirical antibiotic category activity of the patient or reserve category. It was also observed that 10% of the total receiving antifungal without any prior diagnosis of fungal disease. Threefold of compared to the apart from increased incidence or superinfection, there was emergence of various resistance. The diseases produced by Entervac, New York City, of out fatal sepsis patients. So broad spectrum antibiotics should be in case of play as 19 antibiotic administration can help resist pandemic for understanding between a bad infection. International and emerging targeting compiling more than 9 data showed 90% of the COVID patient received antibiotic treatment without clear indication of necessity of antibiotic prescription, and more than 90% of the patient received antibiotics without a much lower incidence of bacterial co-infection. Towards the program in hospitals. As with the WHO in 2020, the mild and moderate should not antibiotics. The patient with antibiotics second. The factors which are excess of of contributed infection 19 compromised double doses of lab fermentation and patient likely is the creation of media staff to the ICU who are not fully trained for the ICU facilities, patients overwork and challenges in infection. Strategy in the post, there should be a very strict antimicrobials towards the protocol for every hospital. There should be behavioral change and continuous teaching and training regarding these protocols. There should be rapid, accurate, and prompt diagnostic services. There should be data sharing at the national and international level to have the knowledge about the current pandemic and research and innovations for the therapy to underline that and the bacteria agents, developing novel treatment and prevention strategies, which usually helpful to increase the survival of the patient and limit the spread of drug-resistant bacteria, to triage and isolate the patient with known bacterial infections in designated wards and infection control measures. Use panel will be helpful with approach such as next generation sequencing, for example, nanopore. There should be early and rapid susceptibility infection should be done. Adjustment of the of rapid diagnosis like procalcitonin and galactomannan for rapid detection of bacterial infections, thereby so conclude index and COVID. For other respiratory should diagnostic with should be there information from rapid PCR. A good sign dealing with the viral sepsis and subsequently landing in ARDS where supportive care is more effective than the pre-antibiotic era. A key lesson we must learn from this world is that redouble our forcing the practice of infection control measures to prevent the bacterial and fungal infection. Thank you.
Thank you for the session. Now I hand over the mic to Dr. Yash for the rest of the sessions.
Dr. Yash sir is in. Sir.
Dr. Lalit. Or Dr. Kapil Gupta and Dr. Venkat.
Hi there. A very good evening to everyone. We had wonderful sessions today. This is Dr. Kapil, anesthesia and critical care in Safdarjung Hospital and BMMC. I did my critical care fellowship from Australia, Sydney. So I would like to welcome the speakers as well as the delegates. First of all, I would like to invite the next speaker, Dr. Rahul Kashyap. A very important aspect of research, that is research networking, which is foremost important. So I welcome you, Dr. Rahul, to enlighten us on this topic so that we can have a better networking.
Welcome, chairpersons. We have Dr. Kapil Gupta from Safdarjung, Dr. Raman from Yashoda Hospital, is Director of Critical Care Services, and we have Dr. Lalit Singh. Lalit Singh is Professor of Pulmonary and Critical Care Medicine at Bareilly SRLU. We have 3 sessions in this, 3 talks. The first one is from Dr. Rahul Kashyap. May I request Dr. Kapil Gupta and Dr. Venkat Raman to take over the proceedings.
Yeah. Thank you so much, Yash. We just missed you by a frisker. We're waiting for you. So we just invited Dr. Rahul to give us to enlighten us on this most important topic, that is research networking, and show us the way how we should network with the other colleagues in other countries and other places. So Rahul.
Hello, my name is Dr. Rahul Kashyap. I'm an assistant professor as well as the principal investigator for virus COVID-19 registry. I would like to thank the organizers to invite me on India Sepsis Forum on World Sepsis Day to talk about research networking, global research 101. So next 15 to 20 minutes, I would like to talk about the research is a big change. And this quote from Charles Darwin is my famous quote. It says, it's not the strongest of the species that survives, nor the most intelligent that survives. It's the one that is most adaptable to change. So research is important for our clinicians, for doctors, for nurses, for residents, for faculty members. That is the way we improve our knowledge. That's the way we enhance our patients' recovery and then save many more lives. Today, we will cover these three things. I'll talk about why the research networking is important. How can you do it? And what are some examples we have done in the past in the last several years? I'll share some of those examples. And they're just at the tip of the iceberg. There are so many examples beyond that. This is something I was involved in the last several years. So let's start with why. This goes back to a story when we were young. I grew up in India, we were young. It was shared that how one father had 3 sons and they were always quarreling, and he wanted to teach them a lesson. He gave them a big bundle of the sticks. And then when you put together, they asked them to try to break it, could not break it, and was to take them out. His sons were able to break that bundle, each stick at a time. And then lessons was learned that unity is strength. And that's where I come up this whole collaboration networking idea since early childhood. And then you have seen some of these things on this forum, the excellent Surviving Sepsis campaign, Society of Care Medicine, ESICM, and other partners. It is a great example of having the networking and collaboration. And recently, unfortunately, this major pandemic of our lifetime, the global response to COVID-19 in terms of data, people sharing the resources, the information, knowledge, the protocols, it has led us to think that, yes, we can work it out, even the biggest pandemic of our lifetime, which has happened once in 100 years. Those are the reasons I think we should do it. Or not only we get quality publication out of it, our enhanced patient education enhanced, and then there are opportunities to seek funding and apply for funding together as well. Many of you have seen this evidence-based medicine pyramid. My purpose of bringing it here is in top of the pyramid, there lies the systematic review meta-analysis, randomized controlled trials, cohort studies, analytical studies, and case control studies, and a little bit of case reports and case series as well. All of these things could be enhanced and amplified once we work in collaboration. Once we do regional, national, international collaboration, you can amplify all the work you're doing it and probably go to a high impact journal, as well as you can deploy the best to other country and sharing our experiences, the Mucor microsystem team that we could share with the rest of the world, what is working, what is not working. So now I'll move into why we should do it, to how to do it, how to start. The one personal experiences, you always start with your personal network. What mentors your mentees to see who they have worked internationally, and professional societies and work together. And I'll share some. That is an excellent resource. Your national society, going to these meetings or attending them in person, online, that's a great place for you to just drop in an email ID or chat box and then talk to people you want to work on in area of sepsis, septic shock, fluid antibiotics, whatever it is in that regard.
Recording
Social
stopped.
media has come up.
Recording in progress.
Well, especially LinkedIn and Twitter. If you are not on these two platforms, you are missing out a lot. I only use it for professional development for these two of them. So please make sure that you are in these platforms, as well as you are collaborating and networking in those areas as well. Be aware of what people are publishing, reach out, send them a direct message, like it, retweet it, so on and so forth. And publish literature. Ultimately, you can go to the literature and see what people have published, and you can go out and reach out to the primary author or senior author if you know them, or their email IDs are there, and you can reach out to them. You can seek out these things on Google Scholar Profile as well as ResearchGate, and sometimes you can seek the full papers as well. These are very few initial points how to start your research collaboration or research networking. Now, my second thing is you should apply with a refined approach. Many of you are esteemed researchers and clinicians, but you can use this approach to teach your trainees, your residents, your fellows, anybody you are mentoring in that regard. Or if you're a novice researcher or investigators, use this approach. You may have an idea, and I'm just throwing it, smoking causes lung cancer. When you're going back to bed, seeing a patient, you have all these research ideas, turn them research ideas into your hypothesis. Now talking about incidence of lung cancer is higher among smokers compared to non-smokers. You have a control group right here. Then make it as a primary aim. When you want to compare in a case control study or cohort study, retrospective cohort study with and without smoking history to see how many of them develop lung cancer. Do not approach. My personal suggestion is do not approach people with the research idea. Approach them with your hypothesis or your primary aim and saying, this is something I would like to collaborate with you. Once you have a little bit of refined approach, then chances of people responding back as well as inviting you to on their projects is really, really high. So they will work on your ideas rather than you working on their idea, which nothing is wrong with that. But then if you have a refined approach, then you can invite people to work on your ideas. And that's what we have done both ways. We have worked on people's ideas and we have worked on our own ideas as well. I'll give you this small checklist or a decision tree in case if you're wondering how to decide which is a case control study or cross-section study. If you're not comparing two groups, you're basically working on the case report case series, you can collaborate on them. If you're working on identifying an exposure and outcome, and they're based on what you determine first, let's say exposure is determined first, them by yourself, you're looking into clinical trial, or it has been already assigned, happened in what study. If outcome is determined first, and then you're going back and checking the exposure, that it is a case control study, and if they're done both at the same time, you're looking at the cross-section study. So this branching tree can suggest you what kind of study you're looking into, and you can reach out for collaboration accordingly. This figure comes from Designing Clinical Research book by Stephen Hull. For your, if you're an working doesn't apply just to the clinical trial or analytical studies of case control or cohort studies. You can apply them into survey-based research, which I'll share an example with you later. Field observations, simulation study as well. It can apply to any, even a Delphi process. We did it. We will let you know with Dr. Javeri and other group. We did that study and we end up publishing that. Let me turn my talk to the second part of it and sharing some of this collaboration, national, international projects we did it. Certain was one project which I'm really, really proud of. We end up creating a checklist for early recognition and treatment of acute illness. And you can check out on www.icertain. Dr. Publishing that 13. So each into a journal. And that's why I want to share that if you work in a research collaboration networking, you have all these ideas that you can turn them into multiple publication and ultimately your project improves upon. This is interface. Many of you might have already seen it. We had a paper checklist. We have electronic checklist as well, where the initial A, B, C, D, E, the reason for admission and so on and so forth. I'll not go into detail, but this was one thing we deployed as no cost whatsoever to our institutions. Many of the sites in India as well contributed. We have like 21 ICUs from 14 or more international sites at the time. We end up publishing these things, opinion articles in a Brazilian journal. Then idea of looking into simulated environment, we end up Aysen and Dogan from Turkey was a primary author. She published that in another journal. Then we went to designing and alpha testing into pediatric population. Dr. Mansi Hulialkar and Dr. Tripathi was the primary and senior author on that project as well. Then Dr. Savia looking into prompting by electronic checklist as a high fidelity simulation study. As you will publish in a different journal at a different time. Ultimately, ability of international remote China was able to publish that. Ultimately, we have the full manuscript, 5 or 6 years of work in critical care medicine. Again, Dr. Maria Bukoya was the primary and we end up publishing that as an exploratory multi-center international quality improvement project using the checklist. I showed it to you right away. Mortality was not the main goal. We wanted to improve the process, but we end up checking the pre-certain implementation and post-certain, and mortality was decreased significantly. ICU mortality from 29 to 24%, hospital mortality 34 to 29%, and 31%, and each has to prove was able to in SCCM 2019. Towards build, and it's a lot of work. That's why you can work in large teams and get it done with that. I strongly encourage you to check out at www.icertain.org. Send us an email, and if you still want to use it, those checklists are still available to you. That was one of the main goals. In the middle, respiratory illness universal study. Check it out at sccmcovid19.org, the dashboard. I'd like to share this humongous project, which is a perfect example of research networking in recent years. It's less than 18 months. This study, this is a dashboard which kind of tells you the total number of countries, more than 28 countries and more than 300 sites. And you see it's very well represented across North America, South America, Asia, Middle East, India. There's so many sites. Japan, we added one site from Russia as well. So many sites are contributing data to make it as a national, as a global project. We have pediatric sites as well from 12 countries and more than 75 sites. It's becoming one of the largest data set of COVID-19 positive hospitalized patient. This project has started publishing quite a few of them. Couple of method papers as well as the guiding principles came in critical care exploration journal, the Society of Critical Care Medicine journal. The main paper with outcome, which was a late breaking session during COVID SCCM meeting in 2021, was able to publish that paper by Dr. Juan Pablo Domecq and Dr. Alan Walkie. And this paper was able to establish the practice variation among hospitals, and that was one of the most significant factor came out, which affected the mortality as well. This was the infographic which tells you COVID-19 hospitalized patient with no organ support, mortality was roughly 8%. With one organ support, mechanical ventilation jumped to 40%. Mechanical ventilation and vasopressors jumped to 53%, and 3 vasopressors. So this infographic decreased failure. Range was somewhere from 40. Difference of hospital which data from involved in social media. This one tweet from 100,000. This you can have you work in tools prepare media platform. More than 3,027 other submitted, and more than 65 manuscripts published so far. 25 highlights the data that 60, put them and then answer, and then other societies register radiology still going. I'll talk based India to get practice of us that all available. This could be something pretty high. It was delirium, palliative care. I would ask design a good part. Now we work from us. All of that comes up. One as and then his conclusions, the 2 rounds of Delphi, giving the early recommendation of pharmacological therapy, of initial antiviral medications, early prophylactic dose of anticoagulation, and no resuscitation for immunomodulation therapy as well. Things will change, of course. Not all things will be true, but this gives you the power of teams coming together online, going through a Delphi process, and having some of these publications out to provide some light on the ongoing projects, ongoing pandemic, as well as providing some of the help there. So with that, I just would like to finish my talk. These are some take-home messages. Why research networking is important. It brings unity and strength, power of data, publications, patient lives, as well as some of the grant opportunities. You can share resources, publications, papers, and other things. You can start with your personal and professional network. Social media is a great place, especially LinkedIn and Twitter, and then have an informed approach as you go along. And what I've shared with you examples of the certain global project, the checklist ICU checklist project, the virus COVID-19 registry, that in projects of ICU need a certain national ICU need assessment survey, as well as the Delphi process as well. So I hope that you liked, and if you have any questions, please let me know. That's the email ID, as well as you can reach out to me on Twitter, and then please let the organizers know. They will have a way to reach out to me as well. Thank you so much.
Well, thank you so much, Rahul. That was a wonderful talk, wonderful presentation. I think another big advantage of research networking, as I can see, Yash has done a lot of research with you guys, is that the results are really generalizable. We can generalize it to different kinds of population. Because after working in 3 other continents, I realized there's a little variation in different population, whether it's Indian population, Chinese, or whether it's Black Americans, or even white Americans. You would see that, right? You would see that in your country when you're working in US, that the way patients behave, the drug requirement, everything is different. So whenever you do networking, the results are much better, and they can be much more valid and appropriately used in various kind of populations and more generalizable. Right?
Can I have a question to Dr. Rahul?
Please go. Yeah.
Yeah, Dr. Rahul, that was a nice overview of that. Can you just give us a little maybe information related to this currently ongoing platform trials? If you see, many are happening like they are adaptable platform trials, something like recovery, which starts with something, takes some drugs, keeps some drugs on, dropping the other drugs on, adding the new drugs coming in, and that trials go on for a period of time. So just an overview of this platform trial and adaptive trials, which has been the current trend.
Absolutely. Can you hear me well, Dr. Rahul?
Yes.
Yeah, no, I think that's an excellent question. It's a tough question. We can talk for 1 full hour, but let me give you some of my personal involvement as a PI of COVID-19 registry. So this is actually the future of clinical trials. as we realize that the observational data, the retrospective data can actually tell you what has happened. Changing the field is that, can you design some of these clinical trial, actually test it out. As a healthcare community, we failed, and I have no shame in saying it. This pandemic was an eye-opener globally. I'm talking about global healthcare community, that we were not ready. We should have had some of these things in place. And recovery is a great example, and other things as well, that, we can quickly test out things and actually see what is working, what is not working. Now, you brought up a couple of good words. Adaptive platform trials kind of thing in there, and many, almost, I expect all of anyways, that it takes time to design a single study, single drug-based trial, planning, the approval, the IRB, the ethical committee, DSMB, everything else, and funding for that part of it. If we keep on doing that way, our capabilities of testing multiple medications, especially during these emergent time. This is not the last pandemic we have seen in our lifetime. Our next one will be before us, before 2030. That kind of limits us in studying it. Remember the days of hydroxychloroquine testing in Brazil and other things as well, steroids, you name it, till ivermectin till now. We're just publishing a systematic review on that as well. So the point is that these platform trials, adaptive trials, allows us to test multiple agents in the same time in a pragmatic manner. I will add one more point is automatic. Means once you do a one-on-one cluster randomization, the electronic it powers in a data collection, cut the cost, and test multiple agents at the same time. There has to be a robust method, and at least a master and PhD statistician should be involved, because as you mentioned rightly, that adding one agent, not contaminating our results, and then we can say that this pilot of 40 patients in control group, and then when I say control group, standard of care plus something else, you can't deprive patients from something which we already know it. So it's a very complicated topic. I invite you all to join. We're working with FDA right now. This group called Predict and Predoct. Predict is inpatient adaptive platform trials, and Predoct is outpatient one. Anybody who has interest and share your expertise, we need people from infectious disease, statistical background, critical care, pulmonary, whatever, please reach out to us and I'll be happy to connect you with the working group.
Thank you so much for your talk and for answering the questions. We'll move on to the next speaker. Our next speaker is Dr. Manu Shankar. Again, another very, very important topic, COVID-19 immunology. So I welcome you.
No, there is a change. Sorry, Dr. Kapil. The next talk is by Dr. Deepak Govil and Dr. Sheetal Verma. Dr. Sheetal Verma, they will be talking about prevalence of MBS in India.
Sure. Go ahead.
Play the recording. Hello. We have Dr. Sheetal Verma as prevalence of MBS in India. Microbiology. Also pleased to have needs to get today. Short talking about doctors.
Dr. Say, and I would like to a sepsis expert meeting which is being organized today, which is one of the very important our audience without waste. I'll just share my presentation. Can sir you see my presentation?
Yeah, we can.
Okay. So today we will be and the CSE 1034, and I will be taking my audience with an introduction about it. And regarding my small introduction, I am working as associate professor in the Department of Microbiology. I have previously worked at the SGPGI and the WHO and the CDC, and it is my honor to
present something and some important facts regarding the MBL before our very esteemed audience. So if I would like to introduce, I think most of us are now aware that the modern medicine is now threatened by the global rise of the antibiotic resistance. It can be VRE, and the doctor basically the resistance they are using carbon is a very but is a very the time is now set of different by different application, and there is a hydrolysis of these broad range venoms due to these metabolites. So if just a small classification was classification and as A, B, C, D. So based upon what is the active site. So if we talk about metal, zinc, and the class is a class B Ambler's classification. We talk very briefly diversity. So now we know that this is a class B, and it actually B1, B2, and B3. Important ones, WIM types, and all the currently except the. So this is the very from one of the review. This is the intro panel for the in most. But if we India, like India and the which is the most prevalent memory, and in our the KPC around 48 like prevalent are also prevalent, but not to that extent. This is about this aeruginosa, which is again one of the set. NDM is India. If we talk, see the US IMP. So if we just focus, so the NDM types prevalent, as I told you, like the are different are there, and I think everybody remembers paper when in 2000 who was NDM 1. After that, this be transformed and abundant activities, and they have been. So NDM 1.6% is the most as per the literature to 80% if we is again 15 to 20, and there is IMP, and then plasmid mediated this has a strong holding in countries. Talk about from the clinical perspective. There is a limited data when they ask us what do we have to treat. So we have a limited data bacteria. Colistin as the mainstay for the especially when they are in the ICU set. Survey which was done, and this was published in the antimicrobial agents and chemotherapy, and in which you can see the so which variously strains more so is such a high rate, and then apart from the production, there is a state is being used, currently being used, and in other today in this particular topic I will be discussing on the CSE 1035, and I will be introducing it as we have used this in our current settings in the ICE salient points. So if you see, this is the what the ceftriaxone, this is the sulbactam and the disodium EDTA, which are in combination, and MIC is basically so the epsilon by the LRS, and you see them in the, it is quite low. So the inhibition MIC values are comparatively much lower due to the inhibition of the, and all these were the NDM1, which is the most prevalent serotype genotype in our country. Now these MIC results actually have been supported by, if you see that the constant KI values, and whereas the low KI values have lead to the enhanced susceptibility value. So that is the aim of, as a microbiologist, also what we want. And this is a very, very good thing which we saw, and this had been published also by Choudhury et al. So now it also acts as a good catalyst. So if you see in this particular table 3, which is actually showing that the catalyst, if we talk about the hydrolyzing ability of this antibiotic, this was the cat upon the KM was taken, and when the newer drug, this particular was taken, the range was between some 0.054 to 0.065, which is more than 165%, which was actually lower than the TG-cycline and colistin. So that was an interesting fact of this particular paper, which was published. And for the NDM1 enzyme catalytic efficiency was 6 to 9-fold higher for the imipenem celestin and imipenem pyrim, and 61 times like higher for the cefoperazone sulbactam and the piperacillin tazobactam. All of these are common antibiotics which are used. So the NDM showed a good affinity towards the antibiotic degradation for the carbapenems and the other drugs, and low KM was also seen. When then we talk about the fraction of the inhibitory FIC to determine the effectiveness of in vitro, what was seen now? So it was seen that the in CSC, if you talk about the E. coli, Klebsiella pneumoniae, the Acinetobacter baumannii is another very, very troublesome pathogen in the hospital, followed by Klebsiella pneumoniae and E. coli. And these different enzymes were studied, and it was found that the CSE 1034 had a good effectivity against the MBS in majority in most of the gram-negative bugs which we actually encounter in our ICU and our hospital settings. So this slide is basically quite an interesting slide in which the Vmax, if you see, this is attacked upon the V-sonicated of different drugs was taken, and these are the different drugs: meropenem, colistin, cefoperazone sulbactam, and piperacillin tazobactam. And this was the LRS. This paper also showed the differential in the membrane permeability. So we do not only have the drug hydrolyzing, but also a membrane permeability is also there. So this is a good physiological efficiency, indicating that the capacity of the beta-lactamase. So these are interesting figures, and definitely it comparatively lower physiological efficiency of the drugs is definitely worth examining and should be studied in detail. Now, if we see this particular slide, This is just to show that the again the permeability of the coefficient of different drugs was taken, and if you see the low risk, the efficacy ranged from something from 0.054 to 0.065, and which is if you compare with the TG cycline and the colistin, again it was more than 65%, and again lower than the TG cycline and the colistin. So why we were definitely most of the physicians and the intensivists, they do not want to directly go on the colistin and they search for the alternative for their patient. So it causes low membrane permeability, and which actually works synergistically with the other mechanisms of the bacterial drug resistance. Now, concentration, this is the different FICs and the periplasmic concentration of the different drugs was actually evaluated. I'll not go into this is a busy slide. So basically, it is how basically the alteration in the membrane permeability and the high periplasmic concentration of the drug. So it was found that the newer compound Loris actually was penetrating the outer membrane where the ESBL produced resistant E. coli with the permeability were not able to act. So the different coefficients, which was different, quite higher than the imipenem plus elastin, meropenem, colistin, cefoperazone, sulbactam, and piperacillin, tazobactam. So to conclude, we all know the different types of the MBLs are disseminating internationally, particularly in Asia, and often mostly it is by the GNB. And differently, we see sometimes the in vivo and the in vitro responses and the resistance are different. So the licensed beta-lactamase inhibitors, and I would like to say that the novel antimicrobial agent should be evaluated to see how good we can fight against this MBL, and the ability of the MBLs to confer resistance to the carbapenems as great as in vitro and vivo. So the positive aspect to conclude is that now diverse and the exciting pipeline of the potential agents for the treatment of infections caused by the bacteria that produce the MBLs. Thank you so much.
Thank you, Dr. Sheetal. We'll move on to the Q&A sessions. I'll start with Dr. Deepak Govil. So where will you like to use this drug, first line or salvage therapy?
No, till few months back, few years back, we were using this drug as a salvage therapy. But gradually, in years together, we build up a confidence, and now in many cases, we are using this drug as a first line therapy. Because what happens in, if you look at the hospital sensitivity pattern, it depends on the individual hospital to individual hospital. But if I look back at the sensitivity pattern at my hospital, as Dr. Sheetal has already shown, that pattern prevails almost every places. So the sensitivity to carbapenems is going down drastically very fast. And we don't have got much armamentarium in our pocket except using this combination or colistin. So sometimes we use this as a colistin sparing drug as well.
So if you are using it as a broad spectrum agent, especially for hospital-acquired infection, are you using it alone or you are using it in combination?
It depends patient to patient. If the majority of time we are using it in combination with either colistin or TG cycline.
Dr. Sheetal?
Yes, sir.
Is there any report of emerging resistance to Innovate so far?
No, sir, we have not seen any sort of resistance in our hospital against this particular drug. We have got good reliable data, and it was quite convincing.
Dr. Govil, sir, what are the clinical indications where you're using Ilores? Which subset of infections?
As we have already discussed, those subset who are, we suspect that are having hospital-acquired infection. So those patients who are already received the broad spectrum antibiotic and things are not working, or being shifted, transferred to from another center to our center, or we suspect some line-associated CRBSI or hospital-acquired pneumonias, or in those subset we are using this drug.
So what advantages, Dr. Sheetal, do you see with addition of EDTA in terms of increasing the antimicrobial activity of the drug?
Sir, if I talk about, there are different mechanisms of resistance. So if we add EDTA to the EDTA basically helps in adding even the biofilms which are found, which are actually formed by different organisms, it inhibits that also. And it also acts on the membrane permeability, which is also one of the important things, that the drug is able to penetrate better, and you will definitely have a better response then. And the biofilm also will not be response.
Always be used as an alternative to carbapenem in complicated UTI, and most of the times we are doing it. What is your take on this question, sir?
That is what I said, that many times if the patient is having already received multiple antibiotics and we feel that patient is having hospital acquired infection, then sometimes we feel that there is no fun starting carbapenem because the resistance pattern is already very much against the use of carbapenem, because if there is a resistance to almost 80% or 70% prevalence, then it becomes very obvious not to use the carbapenem in that cases. And in that cases, we use LORIS.
So LORIS can be an empirical choice in hospital-acquired infections in our ICU, sir?
Yeah.
Especially for the urosepsis.
Yes, can I have a question?
Yeah. And Dr. Sheetal, what other systemic infection do you see LORIS working well? Like skin and soft tissue infection, what all subset of infections?
So mostly it works well for the urosepsis, then for the septicemia, then especially the community acquired pneumonia, as Deepak sir was saying, in which you see the different MDR and the PAN, like the drug resistance. In those patients in the ICU setting, this is quite useful. And it can be
one last question. How to we do not know. Dr. Govind.
For using any molecule is, there are two things in the mind. One, are we using it at the proper place? And we are not using it, are we not missing the bus? So we have to consider these two things. So the timing is very important, whether we are using it at right time or early or late. If we are using any drug which is little early in that subset, then probably we are misusing it. And if we are using it too late, then it is already too late. So identifying that appropriate time is most important.
Thank you, panelists. With this, we'll come to an end of the session.
Thank you very much, Dr. Yash, for this.
Thank you, sir. Thank you.
Thank you, Yash, sir, for giving us the opportunity. Have a nice day. Good day. Bye.
Thank you. Bye-bye. We move on to the next session. We have Dr. Vinod Kumar SP with us for the next talk. He will be talking about public health perspectives of sepsis in India. He is professor and dean in charge of S.G. Gupta School of Public Health, IIHMR University. So he is one odd person amongst us because he is a public health expert and most of us are working as a clinician. So welcome, Dr. Vinod, to the forum.
Thank you. Thank you, Dr. Yash. Hello, everyone. And it's a privilege to be here. And I am thankful to Dr. Yash, India Sepsis Forum and the Intensivists group for giving this opportunity. I bring greetings from S.D. Gupta School of Public Health, IIHMR University. And this is indeed such an important and pertinent topic. And with the permission of the chair, I'll now go on to this talk on the public health perspective on sepsis.
Thank you. Please play the video.
Sepsis is an important public health problem which has been understood very well in specific settings and groups like maternal sepsis, neonatal sepsis, healthcare associated sepsis, and so on. But the real burden and impact of sepsis in the community settings leaves a lot more scope to be done. Today's presentation is an attempt to outline the various aspects of sepsis epidemiology in the light of available evidence and gaps. For continuity and completion, I may be touching upon some of the aspects which are already well known. Please pardon me for that. This slide emphasizes the progressive refinements in our understanding of the interplay of infection, host response, and organ dysfunction, and our graduation to quantify the condition in a better way. The first consensus definition of sepsis, Sepsis 1, developed in 1991, was based on the SIRS criteria in response to infection. Although it classified sepsis based on severity, it could not specify organ dysfunction that well. Sepsis 2, developed in 2001, tried to define organ dysfunction in a better way and also suggested a set of signs, symptoms, and lab values indicative of sepsis in presence of infection. But the set of values were considered ambiguous, leaving scope for a more specific definition. In 2006, the third consensus definition, Sepsis 3, defined sepsis as a life-threatening organ dysfunction caused by a dysregulated host response to infection. Sepsis 3 definition is more specific at defining organ dysfunction due to infection and has facilitated better quantification of sepsis. But then standard case definitions for infections to be used and specific infections which should be considered when causing organ dysfunction is a limitation. Epidemiology and burden of sepsis estimated close to 49 million cases and 11 million deaths due to sepsis worldwide in 2017. Coming to the contributing conditions, largest and lower respiratory tract infections, affecting mainly children under 5 years, 40% of global sepsis cases. At the mortality statistics, estimate was close to 20 among ICU patients. The same report estimates incidence of 100,000 person years among hospitals. Incidence being higher among women, the mortality men. And sepsis related death in the low and middle income countries in Africa and South. Let's look at some aspects of healthcare. It is to be noted that sepsis cases more than 3/4
Recording in progress.
Hospital pooled in per thousand, with a quarter of these cases ending up with a fate. It is also to be 1/3 of these cases are caused by drug-resistant pathogens, again emphasizing the importance in community and hospital-acquired sepsis. ICU patients are much more likely to acquire sepsis compared to others, and more than half of ICU patients with healthcare-associated sepsis die. Another area which and survival, it has been almost 17% have some cognitive or mental. A third survivors die with 40% re-hospital discharge. Most of the facility-based single facility study. Two relatively larger studies conducted in India. Prospective study, tertiary hospital, which found the prevalence of severe sepsis to be around 6.2%, where Indian intensive practice patterns, which was conducted across use and study of 4 in 2010 and 11. 3% variation for study designs put much studies to of sepsis. The second handicap published is another area is required. Widely used the presence of as criteria hours of hospital onset sepsis, but current existing evidence and there is wide and from the limited respect for community onset, lower education, lack of physical housing condition. Let's have a look at some key global here. It is estimated women per thousand a meta hospital around 1,000 live births have had a serious maternal incidence of maternal outcome is income countries. It is exponent deaths from India is mainly available through single such study. The incidence of 4 per 1,000 care center 22.7. Field report on released by in 2000 maternal sepsis for 11. There it's on this maternal in several national maternal response guidelines, maternal as well as community for reviews by a large proportion. The comprehensive abortion care Suman Matratva Ashwasan guideline also at danger signs for antibiotic. Let's have a look at neonatal to indicate of neonatal sepsis is preventable. Sepsis does have some large scale review published in is from 14 countries. Case mortality at while the estimates for the 2018 was 124,000 live births. Incidence of neonatal sepsis was more than 4 times higher in community-based multiple reasons: delay in care seeking, home dependence, and so on. Wide country variations in incidence was also countries have times the India has one of the largest burden of neonatal sepsis. Sepsis in neonates in India is estimated to be around 15,000 to 17,000 per 100,000 live births, with a variable case fatality of 25 to 65%, depending. Taking problem, the Ministry of India for the communicate the oxygen who is a place to administer the gentamicin amoxicillin are usually well trained in immunization. They have also CI program to detect ES in target for pre-referral dose of injection by ANMs detected sepsis. Intensified by there could be some pre-existing risk factors or environmental conditions, inadequately prepared referral levels, lack of post-discharge support, and transport and access. These may, as well as compounding effects to in a sepsis patient, using the susceptibility or delaying timely intervention. The overview on sepsis informs us of certain specific sepsis research. As far as there is most studies are either single facility observational cohort or cross-sectional studies. Primarily through there are limited countries are intensive studies. This is outside the hospital, not our understanding of community onset. Use of sepsis across studies limits comparability and some our understanding of data and of sepsis. Community on but very relevant to be explored. Management would hold the key burden of sepsis. Sepsis attributable mortality is not adequately known. Long-term consequences of sepsis and sequelae are not fully understood. Etiology patterns are not fully mapped. Screening is yet so what could be we should move towards increase and respond in a timely manner. Epidemiology for comparisons involving standardizing study design undertaken. Be taken up, strengthened, preferably integrating with existing programs and reporting networks. Follow-up of sepsis, long-term sequelae Standardized should be given to a screening set solely based facilitate the workers while sepsis. This will of course government of screening or diagnostic sepsis should be explored. Exist. An example is right biotic bit. This technology is able to in blood accelerated culture cells. Hospital care system line workers sensitize the community. The danger signs should be adopted. Include by proposing a community on-site sepsis. The coordinated facility the workers center with A&M proposed health and wellness center community level primary health center officer and the referral care facility including the district and district hospitals. The whole is presented by these five. The four train triage at sensitized on danger signs would educate focus on high risk individuals and women platform at Anga for health education screening. The center sensitized on community that these should be incorporated timely sepsis. Wellness centers will be co-locators or PSCs, but the CHO an ideal and screening. The health and wellness of communicable diseases in healthcare functions. Platform to do a point of sort of risk. Sepsis, for example, they have SOPs for sepsis screening and management, both on-site and should clear guideline across all through and surveillance system or the thank
Thank you so much, sir, for public health perspective to sepsis. I think it was very enlightening. Who have just joined us, we are going through a global organized by the Indian Sepsis. Dr. Yash, sir, do you have any comments?
We cannot take questions. And
sure, sir.
Beryl and Kathy are there. I'm very sorry about it. Thank you, Chairperson. Wonderful.
Sure.
Thank you, Yash.
It's a wonderful meeting. Thank you.
So moving ahead, we have the chairpersons for the next, none other than Sari sir, who's a director of the hospital Mumbai of medical affairs at FIA, who's a consultant in care medicine at Regency Hospital, Lucknow. Can I please ask the chair to introduce Ms. Kathy Wine?
Thank you, Dr. Charu, for the where all the share their expertise with Kishore is first of all, I would request Dr. Kathy Vare, who is the foundation partners from Beryl Oppenheim, who is London, the role of diagnostic. She will be talking to prevent sepsis. And yeah, so with that, Dr. Kathy, to please and enlighten all of us. Thank you.
Good afternoon, and thank you so much for the invitation. You presentation that you can.
Yes, please.
Good surveillance areas. I'm Kathy Partners. To present here today, it's a group of such distinguished experts. Here are my fees from Cepheid, but other than that, over the next 15 minutes, be a very powerful tool for you to, and also to maintain prevention of sepsis via early detection of sepsis. In study, the organism associated with sepsis, 30% of which that was in another large ICU, or Staph aureus, Pseudomonas species, in Enterobacteriaceae at 16%, with fungi. Acinetobacter was involved in found significant with a significant being Acinetobacter in Asia at over 19%. The majority of the bacteria, over close to 66%. Pneumonia is Bacteriaceae. % of the organism carbapenem resistant. So a primary concern. The team found that the most common microbe, Bacter beaumont, side of the slide focus on, and the fact that if you work at to prevent or detect very early on organisms of concern, you can reduce, because we know as a patient and then up through and potential that the clinical and economic consequences rise acute therapy. Screening is concerned of ways. And when I refer to I'm referring to symptomatic patients for the presence of a particular organism. So this is before patients symptoms of infection. Typically can be institutional risk assessment or baseline active surveillance patients from a high-risk health institution where a particular organism is highly on admission from a high-risk geographic location, often conducted such as in referring to screening of those patients, patient screening care institution. And once again, here on prevention of sepsis, the organisms that can cause sepsis, and this is where the role of in enabling us to do this. And we can also interventions quickly so that we ensure that transmitted to the environment, patients, thereby reducing, as I said, the organisms. The best illustration of the efficacy of active surveillance is in this 2000s when MRSA was all over the world, and the United Kingdom did in response comparison to the United States. On the right, the US represents the gray line, orange line. In the UK instituted, say, bloodstream infections, and that this had 5% decline as a result of that. But in 2000, ended a comprehensive national strategy. Core components of that screening. So this mission institution in what happened, the prevalence rate just, this was a comprehensive strategy, active surveillance, but it was really the new component to the program. Impact on the ability of the UK to. Now, in comparison, we never strategy, and in comparison, screening was subject to intent. Ultimately, landed on patients. They undertook universal active surveillance screening. Endemic in many. While rates have come down significantly, what the UK achieved. And prominent stated that if confrontation were equal to that of Northern Europe, MRSA infections might have been prevented. So that's a tremendous comment in terms of when we don't control the. So there were a couple of institutions that conduct universal active is the U.S. Veterans Administration is one of the very largest serving veterans. And in 2000, screening strategy on admission, so universal active on movement charge. And if you look at the graphic in the that by 2017, Affairs Department was able 55 reduce MSSA 12%. On the left side of the slide, reduce infections, but not, and they really, so this one of how particular can have a dramatic to implement a surveillance mechanism. The point where you would want to, and this would mean taking, including those in high-risk populations. For example, in the ICU. Transfers, for example, have come in from long-term care facilities, from other, particularly those MDROs are known. This perhaps with every third, a 1 to 2 week, that as long as you're survey at regular intervals. Or to use clinical because of discover any case, I should say. So upon case, you would want screening at the first appearance at your institution, or because prevalence is rather critical. Don't know any, and that program encompass which population or transferred patients. Rapidly identify, rather important, create infection control intervention, isolation. Now, if you get to the point where you need to escalate the program, you would expand your active surveillance program target populations as well as patients transferred or and at this the institute with an reducing prevalence sure a minimum of 85% colonization days in finding those patients quickly and getting what enables containment. And at this diagnostics, because of the rapid turn, U.S. our agencies have are endemic to epidemic. That these significantly reduce. So what would happen on clinical cultures? So until they exhibited some, well, that would significantly impair your ability. And once again, your clinical cultures alone, only to the known cases, all would exacerbate applied infection prevention strategies, such as isolation and contact precautions. You would only work if you relied on clinical of patients one as your own organism of infection. That really illustrates that point. Team at and did the spread and enter California over, assuming that only clinical cultures were used. The graphic below detected and undetected indicate those patients that were detected through the dark, solid gray area remain undetected. Alone, the team estimated that by of the daily that only 1 in would be spread. Surveillance. Well, we know infections in organ. It helps you know your base. It enables you to very early on your positive patients rapidly initiate, such as contact precautions and isolation, prevent transmission and spread, antibiotic. It enables you to reduce antimicrobial resistance overall. So as far as active surveillance is concerned, it is a powerful tool to enable you to prevent infections that can lead to sepsis. It enables early identification of the infections that contribute to sepsis. It will also help you reduce time to targeted therapy, which will improve your outcomes overall, both clinical and economic. So what I'd like you to take away from this is that active surveillance enables early detection of colonized but asymptomatic patients, early implementation of infection control interventions. It enables prevention of infection and transmission of multi-drug resistant and other organisms, including those primarily responsible for sepsis. It enables the identification of colonized but asymptomatic patients while incidence is still low, and that is critical to an effective infection prevention strategy overall. Now, clinical cultures, using those alone, enables you to identify just the tip of the iceberg. Without active surveillance screening, a significant majority of colonized patients will be missed. Finally, active surveillance screening is an effective strategy to decrease the clinical and economic consequences of sepsis, transmission of organisms of concern, and prevention of antimicrobial resistance. With that, I would like to thank you, and I think there'll be time for questions at the end of the panel.
Thank you so much, Dr. Kathy, for this wonderful session. Can I please ask Dr. Devkishore, sir, to introduce our next speaker for the session?
Yeah, thank you. So it's my pleasure to introduce Dr. Beryl Oppenheim, who is the Senior Director, Medical Affairs of Cepheid. So Dr. Beryl has years of experience, tons of experience, and from working from NHS Trust and various other fields. So she's a well-known name and editor of respected journals. So I'll request Dr. Beryl to, start her presentation. Over to you, Dr. Beryl. Thank you so much.
Thank you very much indeed, and a great honor to be here. I believe you also have a recorded presentation from myself, so perhaps you could start that. Good afternoon, and thank you so much for the opportunity to present at this meeting on World Sepsis Day. It's truly an honor to be here and to talk to you about a subject that I feel so strongly about, the role of diagnostics to support antimicrobial stewardship in sepsis. And I'm going to very briefly recap the problems associated with the management of sepsis, talk about the interaction between appropriate management of sepsis and antimicrobial stewardship, areas where novel diagnostic approaches may impact this, and give you some examples of initiatives in the field. So you don't need me to tell you about the importance of sepsis. Sepsis and septic shock are medical emergencies with high levels of morbidity and mortality. And improving outcomes relies on early identification and rapid initiation of appropriate management, including appropriate antimicrobials. But unfortunately, decision-making is complex. It's often performed under great pressure, and currently there's little decision support to clinicians. So mostly they are left to make a syndromic diagnosis, institute empiric antibiotics, and escalation and de-escalation, if it happens at all, often happens several days later after culture results become available. And that means that we're increasingly using more and more broad-spectrum antibiotics as we see more resistance, and we're heading for this vicious cycle, which in the end we know becomes a post-antibiotic era where we really don't have the antibiotics anymore and struggle to manage sepsis at all. So just a few quick definitions to remind you that stewardship is meant to be a coordinated program promoting appropriate use of antimicrobials, improving patient outcomes, reducing microbial resistance, and also decreasing spread of infections. And the program does, whereas diagnostic coordinated guidance to improve the from the very beginning, specimen collection, submission to the laboratory, all the way through to pathogen identification and timely reporting of results in time to guide patient treatment. And again, a reminder that empiric antimicrobial therapy is just about some likely cause of infectious disease before the patient-specific organism is known, whereas targeted pathogen-directed therapy is directed to the known pathogen or combination of pathogens and is really what we're trying to aim for as quickly as possible. And just another quick reminder that when we do use diagnostic stewardship for improving antimicrobial treatment, it does have another critical importance, integrating infection prevention into the whole pathway of managing that patient, so they have minimal unnecessary time spent in isolation, best use of infection prevention resources, and minimal transmission. So what are the questions that rapid diagnostics could answer? And we know that there is a great desire to start to address these quickly. Does the patient have sepsis? Is it a bacterium or a virus? What about pathogen diagnosis when the patient presents with a clinical syndrome, such as meningitis or respiratory tract infection? What about direct detection of pathogens from blood or a positive blood culture, rapid susceptibility testing, rapid detection of resistance mechanisms? These are all ideal solutions to the problem of getting rapid diagnostics to manage sepsis. And I'm just going to give you a couple of concepts and examples of things that are going on in the research world and the field as we speak. A couple of other considerations. These are complicated results often, so if they are going to come out quickly and require the clinician to change therapy very, very quickly in a septic patient, are we there yet? Does the clinician require more support to order, interpret, and action results? And are we starting to think that it's not just one test that's going to be the answer? Is a combination of diagnostic modalities, imaging, some chemistry tests, for example, as well as the microbial result, going to be helpful? And again, are clinicians going to be able to gather and interpret this data quickly enough? And maybe we'll need machine learning to support this process. So just some examples. So what about, does the patient have sepsis? What options do we have? And there are some exciting options coming out, and I will just mention a couple of these. So monocyte distribution width is a measure that can be made available from an ordinary full blood count done in some settings with some instruments, and interestingly, an abnormal monocyte distribution width. In other words, the size of the monocytes and the width of distribution of these is consistently associated with increased sepsis probability, whereas a normal one consistently with reduced sepsis. And this study just shows how that can be used in combination with different sepsis scores to give some added confidence in the outcome. So perhaps something very simple can be added to other information. Going to the other extreme of things that are really quite complex, what about looking at the host gene expression to try to classify whether a patient has got sepsis? And if so, what about whether it's bacterial or viral? And there are researchers now describing genetic markers which are associated in combination either with sepsis or particularly with bacterial or viral sepsis. And here's just a study from a few years ago showing that using these sepsis scores, usually in combination with other factors, could give a much better prediction of sepsis and whether the infection is bacterial or viral, such that we hope in the future clinicians may be able to make treatment decisions based on these sort of assessments of the host genetic response. What about when a patient presents with a clinical syndrome? That's quite easy for the clinician to identify, but they don't know what the pathogen is. And this is a good example when a patient presents with fever, headache, sore throat, cough. There are a number of pathogens that can cause this. We know that COVID now, influenza, RSV, can all present with very, very similar symptoms. And of course, management these days is different. And just an example of Cepheid's own updated SARS-CoV-2 flu RSV test, which does detect 4 pathogens, which are so important in this clinical picture: SARS-CoV-2, flu A and B, and RSV in just over half an hour. Again, giving the clinician the confidence to decide how to manage a patient with typical respiratory viral illness. What about detecting pathogens more quickly from positive blood cultures, or something we're all potentially very excited about, directly from the blood sample? So we know that there have been great efforts over the years to optimize every aspect of the blood culture process, from making sure that it's taken at the right time before antibiotics are given, that enough blood is added to the blood culture bottles, many things like this that as a bundle approach start to make a big difference. What about things that can improve the rapidity of the diagnosis, potentially based both on detecting the organism and the resistance mechanism? And how would these impact on patient management if these sorts of results were available quickly? So here's an example again of one of Cepheid's products, the Expert MRSA blood culture assay, which is able to take a positive blood culture with gram-positive cocci and detect whether it's Staph aureus is present, and if so, whether that Staph aureus is an MRSA in just over an hour. So that really allows more targeted treatment and stopping the necessity for always covering MRSA in patients where Staph aureus bacteremia is suspected. So there are a number of these rapid molecular diagnostic tests for rapid diagnosis of bloodstream infections. And the question is, yes, they're there, but how do they impact the patient? Because we're talking about really making some escalation, de-escalation decisions very quickly by the clinicians. And this is a meta-analysis done a little while ago that looked at many studies on rapid diagnostics for bloodstream infections, and they showed overall that the mortality risk was significantly lower where a rapid molecular diagnostic was used. However, the mortality was significantly lower in studies where there was an antimicrobial stewardship program going on. In other words, there was some added intervention by an expert who knew how to interpret these results and supported the clinician. And they showed the time to treatment and length of stay both decreased. And then, are we getting anywhere near identifying the organism directly from blood rather than waiting for the positive blood culture? It's early days, but here is at least one product that can detect candida pathogens directly from blood without culture or extraction. And there are a few publications, and this is just a pooled analysis, very heterogeneous, but showing some evidence that sensitivity and specificity are perhaps looking promising. So perhaps we are heading for days when we can just take blood direct and get an answer. What about detection of resistance mechanisms to assist with antimicrobial stewardship in addition to impacting infection prevention? And again, an example using Cepheid's expert CARBA-R assay, the resistance gene losses of carbapenem resistance. On carbapenem, we are able, not just for infection prevention, therapeutic strategies, that sort of. These days, you might to the diagnostic and then of making a decision patient who infection is, can we apply precision further with that patient rather than cover for to say, well, is a test with a high predictive question is likely mediated by metallic, because we know that the antibiotics are not for carbapenemases, but do not. Was making that there's a lot to the clinician very quickly when he's managing a patient with sepsis, for them to stop. And do they need, is just, I thought, a study looking at the prediction of sepsis. Lots of parameters are taken, heart rate, to platelet, to blood gases, and of course, perspective that it does everything about that patient, including we would logical information predict sepsis. Clinicians can do that. Factors. This is going to be, there's a wide array out there, and laboratory workers are very carefully is definitely going to patient in a positive result be available in. So novel diagnostics, making it difficult updating assets on board when you know perhaps that newer products are in the pipeline. Microbial stewardship teams are currently required to relay and interpret information to clinicians because I think they do find it very difficult to deal with all these diagnostics. And perhaps in the future, automated decision tools might be another way forward to help them making really quick decisions, not only about escalation, but also de-escalation. The acquisition costs of these rapid diagnostics are going to be high. We will have to do cost effectiveness studies, looking at the value of these parameters and the value of antimicrobial stewardship beyond the immediate healthcare institution. In other words, what's the value to society as a whole in preventing antimicrobial resistance? Are we going to be able to discard the current tests which we use in microbiology shown to be of little patient benefit to allow for this introduction? I think that's going to be really important. And I think this is an amazing opportunity now for microbiologists working closely with clinicians to rise to the challenge of integrating diagnostic and antimicrobial stewardship to support the management of sepsis. So thank you so much for your time and for your patience, and I'm happy to answer questions during the panel discussion. Thank you.
Thank you so much, ma'am, Dr. For this amazing talk. I'm going to give the stage to Dr. Dev Kishore Gupta to moderate the rest of the session with Dr. Beryl and Kathy Wine, please.
Thank you. Thank you so much. Really wonderful sessions. So my first question to Kathy. So, you spoke on this active surveillance, right? So we would like to learn from you what are the main takeaways during the COVID pandemic. And if we can learn something, if you suspect any particular bug from a suspected septic patients.
COVID-19 pandemic really created the perfect storm for increase in healthcare associated infections generally and resistant infections as well. So here in the US, we saw significant increases in CRE, MRSA, and Acinetobacter baumannii. So I think it was the combination of overcrowding, bringing people into the ICU that were not previously trained for that type of work. The chaos led to breaks in infection control practice, and in some cases, even suspension of active surveillance programs just because of the time and the, not having adequate personnel and that type of thing. And so all of that led to, the increases that we saw in multi-drug resistant organisms. And so I think that to the extent possible, we need to maintain our practices. Our basic infection control practices are critical, as well as our active surveillance strategies, particularly for patients entering the ICU, and even perhaps escalate active surveillance, because we know that in the chaos of something like COVID-19, that those organisms have an opportunity to, they're very opportunistic and they're going to increase unless we maintain our active surveillance or even escalate it.
Great, thank you. So my next question to Dr. Beryl. So generally we think of bacterial sepsis when we talk about sepsis, right? And plan for optimizing antibiotics, starting with an empiric antibiotic and so on. But do you think that respiratory infections can also lead to sepsis? And how does this early detection and differentiation of this influenza, SARS-CoV-2 and RSV, how do they help in preventing sepsis? And also if it has a role in antimicrobial stewardship program?
Thank you. And I think the recent experience over the last 1.5 years has taught us that absolutely viral respiratory and other viral infections can cause sepsis, very much like other infections, both due to the direct effects of the organism, but also very importantly to the host response. And for example, with COVID, we've even learned about the use of dexamethasone in some cases to dampen down the host response to improve the outcome from sepsis. I think there has been great learning, and when you see a patient with sepsis, we now know that you cannot just tell easily clinically whether that is due to bacterial viruses. So I think it is becoming really important. You saw that getting the right treatment makes a big difference to outcome, getting the right treatment straight away. And I think there are many good reasons why giving antibiotics when they are not required could actually be harmful both to that patient and patients around them and to the community in general. So I think it's a big part of our current understanding and something we really need to tackle.
Thank you. Thank you so much. This is really important for us to know. Kathy, so what are some of the advantages of active surveillance using molecular diagnostic techniques versus conventional culture-based techniques, especially when it comes to infection or sepsis prevention?
Well, certainly you have high sensitivity and specificity, but I think that the real advantage is the time. So we know that with sepsis, time to targeted therapy is the most critical factor in preventing movement to septic shock, severe disease, mortality. And so I think that time to therapy is critical. And with molecular diagnostics, being able to determine or to support the determination of the proper antimicrobial therapy is critical as well, in terms of targeting that therapy and improving the clinical and economic outcomes. So time is absolutely of the essence, and molecular diagnostics supports that critical parameter for treatment.
Great. Thank you.
If I may ask Dr. Gupta,
yes, please.
Dr. Beryl, Dr. Ansari here. So it was very interesting to see your talk and you speaking about reducing the lead time to picking up the deadly fungal infections in the bloodstream. So do you really think that we are there where we can pick up a real pathogen, especially fungal infection, where delay in initiating an empiric antifungal therapy could be harmful to less than 4 or 5 hours? Is it how close are we there?
I think we're really close to getting there. I mean, these are early studies and some very early products entering the marketplace. But, the concept is there. And I think because molecular, allows you to amplify up very small amounts of organism, as we learn some new molecular techniques, I think we will get there. And we are going to be, really, I think, fairly soon be in a position to perhaps give that first dose of treatment based on best guess. But in the interim between the first dose and the next dose, really target down. And that to me is going to be exactly where we're aiming at. So exciting to think, that within just a few hours of the patient presenting, we are in a good position to know what's wrong with them.
Thank you. And one question to Dr. Katie. Do you think that there is a way that we can really predict a good immune response early on? Because we know that the definition of sepsis is all about dysregulated host response to you. Do you think that we are heading towards really getting a good immunophenotype of the patient right early on, or it's variable throughout the clinical trajectory?
I do believe we're moving in that direction, but I would turn that question over to Dr. Oppenheim.
Yes, I think, again, it's early days, but we are starting to have the tools both to do these molecular detections, not only of the organism and sometimes the load of the organism, but also the host response. And the key thing is we will never be just looking at one parameter. They are starting to build, multiple parameters that you put together into some sort of learning tool. And so we will need the artificial intelligence as well as the molecular tools. But you start to see this coming, and I'm very, very hopeful that these tools aren't just around the corner.
Thank you. Thank you, both of you.
Kathy, I have a question for you. So you mentioned about the clinical economic consequences. So can you please elaborate what can be the most likely economic consequences if sepsis is not prevented or detected early on?
Yes. So in the US, the average case of sepsis costs $70,000 US. So if you compare that to the cost of your basic infection prevention and control programs and interventions, and the cost of molecular diagnostics and an active surveillance program that would either prevent or detect very early on the organisms that cause sepsis, you're looking at a far lower investment in prevention than the cost of treating those sepsis cases once they occur. So I think it's a very simple answer. It's a very simple business case in that the molecular diagnostics and the infection prevention program together is a much lower investment in prevention of sepsis. And I don't know what the cost per case is in India, but certainly it's significantly higher than the prevention measures that would include active surveillance.
Great. Thank you. Dr. Beryl, so, you definitely mentioned so nicely that, for this stewardships and for sepsis management, this CARBA-R is essential. But considering the kind of colistin usage we are having in India and also the carbapenemase consumption in India, so how we can better our management protocol based on this carbapenem resistance mechanism? Or if I extend this to one step ahead, that how we can find the best companion antibiotic with colistin?
Exactly. So I think, it's very easy, even after you've got an antibiogram, to suspect that a patient is infected with something that's carbapenem resistant. But there are a lot of other questions. Is that due to some other mechanism? Maybe doses of carbapenems, especially higher doses, may work quite well on their own. Or are we dealing with a carbapenemase, an enzyme, going to break down the antibiotics, in which case that's probably not going to work very well. And if it is an enzyme, then, which antibiotics or which antibiotic combinations would work. And I think having the answer very quickly, it is a carbapenemase, not some other mechanism, and then which one. And as I see, medicine is metallo-beta-lactamase, which rules out some of the antibiotics that you could use, or on the other hand, it's not and gives you a better option for some novel antibiotics that we can use. So I think suddenly we are getting to the point where it's not empiric treatment, it's not a best guess. You have some real tools at your hand to make those choices.
Thank you. So one quick question to Kathy, that, we assume that in a country like India, people will be heavily colonized with carbapenemase producing bugs. So what do you think? What do you suggest that after, we do not have the enough infrastructure for isolation facilities. So what should be the way forward, and how we should address this? At the same time, we cannot ignore the demand and need as well.
Yeah, and I think that with COVID-19, we all experienced the lack of infrastructure around isolation facilities. But if you don't have the isolation capacity, the next best thing would be private rooms. If you don't have private rooms, then some countries have demonstrated efficacy in cohorting those patients with similar organisms or infections, keeping them away from the general patient population, certainly. And then when you cohort them, you can create signage to alert staff members that this is a contact isolation area. I've seen some studies where hospitals have put red tape on the floor to indicate that this is a cohorted area, and once you step over that line, contact precautions are required. So I think there are a number of ways that countries and institutions without the isolation capacity can still effectively manage these patients and prevent not only transmission to other patients, but to the broader environment and to healthcare workers, and prevent overall spread.
Thank you. So thanks, Kathy. So Dr. Beryl, so one last question to you. So what should be your message, especially for the Indian setting, keeping in mind the high antibiotic consumption rate, COVID pandemic situation?
So I think we are at the point now where we do have to be cautious. We've seen, as Kathy says, the sort of chaos that can ensue when you have infections that are new, that are difficult to manage, and we don't want to get ourselves into those sort of positions again. I think we've learned from COVID and from lots of other resistance that getting the answer quickly is so helpful. And I hope both of us have shown that, these information, the diagnostics, getting to clinicians, infection prevention nurses, pharmacists, all of those people quickly can allow them to act rationally, sensibly, and not mix up those patients who've got different resistances, avoid unnecessary antibiotics in those people who don't need it, and both protect those individual patients and give them a better outcome, but protect society in the future. So I hope the learning over the last couple of years has been that diagnostics are really important, that if we don't use them, they won't become available. I just had a few questions. Are these things just around the corner? The answer is yes, they are, but they will need uptake, they will need training, they'll need support to bring all this into account. And I did just want to say, I think we all know we probably still practice in the laboratory some methods that aren't particularly useful. This is a great chance to have a real look at what we do, throw out those things that are not really helping to impact on the patient, and start thinking about how we bring the new ones in. Thank you.
Thank you. Thank you so much. Really, during the COVID, I've seen a huge uptick of RT-PCR in the country, and this is high time that, we should utilize this at the fullest capacity. Thank you so much, Kathy and Dr. Beryl. So over to Dr. Charudat. Yeah.
Thank you. It's been a long.
Thank you.
Thank you so much, Kathy. Thank you so much, Dr. Oppenheim. And thank you so much, Dr. Dev Kishore also. Can I have one last word of thanks for this session from the chairperson, Dr. Abdul Ansari, sir, and Dr. Abhishek Srivastava?
I can't see Dr.
You're on mute, Dr. Ansari.
Sorry. Thank you, Dr. Kathy and Dr. Beryl, for such wonderful elucidation of complex problems. I think the future is only going in this way of trying to get the lead time advantage. And thank you all my co-panelists. Thank you for this wonderful opportunity.
Thank you.
Thank you, Kathy. Thank you, Dr. Oppenheim and Dr. Dev.
Thank you.
Yeah. We move on to the next session, Dr. Charu.
Thank you so much. Yeah, sure, sir. So we move on to the next session, which is the innovations from India. And let me take the pleasure to introduce our esteemed chairpersons, Dr. Pankaj Anand, sir, who has actually taught me mechanical ventilation. He's the secretary of ISCCM Jaipur and the secretary of the Society of Emergency Medicine Rajasthan. He's currently working as an intensivist at Fortis Hospital in Jaipur. We have Dr. Shyam, who is a director at Critical Care Medicine at Medicover Hospital in Hyderabad, and Dr. Lopa, who is a senior intensivist joining us live from Dhaka in Bangladesh. So welcoming you all for the next session. I would request Dr. Pankaj Anand, sir, to please take the stage and introduce our speakers for the sessions on innovations from India.
So welcome everyone, and a big congratulations to the organizers, and of course, Yash, our old friend. An excellent platform I have been following since morning, and really great learnings. So it's my good fortune to introduce the person who's behind the spirit behind this entire organization, Dr. Yash Zaveri. I don't think he needs an introduction by now. Of course, he is the head of critical care and emergency at Regency Healthcare, Lucknow. He was a senior consultant at Institute of Critical Care Medicine, Max Super Specialty Hospital, Sakib. He is a graduate from Steny Medical College, Chennai, a postgraduate in anesthesiology from AMU, and has received a lot of gold medals. He is a regular speaker at, I think, almost all big platforms on critical care in India and beyond. And he would be talking on a topic which has been a topic of much debate since last few years. The use of protease inhibitors, especially unilastatin and sepsis. I've heard a lot of talks against unilastatin, but somehow this molecule seems to be here to stay. So, Dr. Yash, please go ahead with your talk.
Thank you, Dr. Pankaj. Can you play the recording, please? Hello, everyone. We are going to discuss about high-dose unilastatin in this session. We are going to discuss about the physiological basis and why are we going to use high-dose unilastatin in few selected patients. High-dose unilastatin, a concept whose time has come. no conflict of interest to declare. It was said by Sir William Osler, except on few occasions the patient appears to die from the body's response to infection rather than from it. This holds very, very true for sepsis as well as for COVID. And this is the basis of most of the immunomodulatory therapy which we are using today. The learning objectives from this talk will be to understand the theoretical basis and the clinical possibility of immunostatin and high-dose immunostatin, the need, what are the lessons from COVID, how to have an EBM approach, how the drugs and the doses have been repurposed in COVID, and what is the way forward. Whenever we have sepsis or severe or critical COVID, there is an infective stimuli, there is an immune response, there is a thrombosis phenomena, and this immune cascade is largely like a black box. We have deciphered a few of the cascades, but many of the cascades we still don't know. Don't fire until you see the whites of their eye. So unless you have understood the pathophysiology very, very clearly, we cannot have a targeted therapy for sepsis or for COVID. And we understand there are multiple pathways which are involved in the pathogenesis of COVID or for sepsis. So don't act before you have some chance of success with any therapy. So you have to risk-benefit ratio in each therapy. For every complex problem, there is an answer that is clear, simple, and wrong. So we are learning how to use these immunomodulators best for sepsis as well as COVID. This is the DRF model for COVID-19, and we see the immune response. If it is very, very less, it could be an asymptomatic disease. Overwhelming, it could decompensate the patient and have multi-system inflammatory syndrome or hypercytokinemia. So ultimately, we need a very, very balanced immune response for any disease. And the aim of immunomodulation is to bring this disarray of immune system to a lesser degree. If you cannot stop the waves, you learn how to surf. And this is the component of personalized medicine which we are trying to learn. And as disease varies in every patient, there is disease dynamics in every patient. So the therapies have to be also personalized and individualized. We all have seen this cartoon which is there in Sicily, Italy, where three-headed demons is addressed by clinicians, the three heads of sepsis, hypoperfusion, hypotension, and organ dysfunction. So we always talk about increased coagulation, increased inflammation, and decreased fibrosis in sepsis. We also talk about the trident approach for sepsis as well as for COVID. We have antimicrobials, we have thromboimmunomodulation, and we have multi-organ support therapy. So immunomodulation becomes an essential part of any therapy, especially for COVID and sepsis. So the immunomodulation in sepsis or COVID, it's a hope or hype. Whatever is it, it's a burning question, and a simple answer is a big yes. However, the bigger question is what works. COVID, steroids and antibody cocktail has the largest body of evidence. What, when, and where to use these repurposed drugs are still unanswered questions for COVID, and for sepsis as well, we are still learning. Though the consolidated sheds of evidence of benefit of these repurposed therapies are yet to be established, the risk-benefit ratios to be taken into consideration for each and every usage. Various immunomodulators are being used off-label with variable success to blunt the hyperinflammation. Many of these immunomodulators mediate individual components of the immune response rather than leading to broad immune suppression. We do not desire to have a broad immune suppression. Modulators that can suppress the hyperinflammatory host response without significantly affecting viral clearance may result in the most benefit. Steroids can lessen mortality, especially when oxygen requirement is there in COVID and when there is refractory shock in sepsis. Indeed, this was the finding which served as initial proof of concept that immunomodulation can provide benefit in management of COVID-19. Steroid dose flexibility on COVID gave us deeper insight into the right usage of immunomodulators in right dose. The lessons from sepsis. COVID replaced sepsis as the largest unmet need in ICU. Sepsis was a graveyard of clinical research because the big data analytics failed us most of the time, and same has been applied to COVID. Myriad and dynamic disease, Timelines are shared but shortened for COVID for research as well as for drug development. Search for Holy Grail is still on. So many drugs were repurposed. Ulinastatin was one among them. Many doses were repurposed, including steroids, ulinastatin, and other therapies. Often higher dose and duration were tried, especially when inflammation was overwhelming. The lessons from COVID for immunomodulators: we have to have a dynamic approach. We need to have an individualized and personalized approach. Different therapies will work in different phases. Dose and duration depends on the severity of inflammation. And we have to have theranostics guidance with various inflammatory mediators levels to guide us. We have seen this cartoon a number of times. What I want you to focus on this slide is therapeutic targets. As the disease dynamics and phase changes, the therapeutic targets also changes. So you have to remember this. One therapy can work in one phase, other therapy will work in other phase. If you have a broadly immunomodulatory therapy, you have to know the right place to use this therapy. A therapy like extracorporeal therapy, which cuts the cell space, will work best in this pro-inflammatory peak, but depends on the phase of the disease. Ulinastatin is the site of an inhibitor and urinary trypsin inhibitor. It's a broad spectrum inhibitor. It has various mechanisms of action, including the stability of lysosomal membrane, scavenging of oxygen or hydroxy radicals. It ultimately tries to achieve immunohomeostasis. What happens in sepsis? Non-specific inflammatory response is increased, where specific immune function is decreased. With ulinastatin, we try to reverse it. We try to increase the specific immune response. We try to decrease the pro-inflammatory cascades. We try to achieve a sort of immunohomeostasis, which should translate into improved organ function. Various cytokines like TNF-alpha, interleukin 1, 6, and 8 are inhibited. Activity of neutrophil is inhibited by ulinastatin. Progression of MODS is halted by ulinastatin. There are various theories about early use, but what we suggest is timely use of these therapies. There are various mechanisms for effect. The dose now we use is a variable dose depending on degree of inflammation and severity of inflammation. Duration also depends on the degree of inflammation. Large dose has found to be safe in most of the study. Why was this 2 lakh BD dose sacrosanct for a large while? Because most of the initial studies used this dose. Most Indian study protocols also use this dose, and this was widely accepted and approved dose by FDA. 2 lakh units twice a day for 5 days was the usual protocol in most of the ICUs. Pre-COVID, high dose was one odd phenomena. There was a lot of skepticism, poor understanding of immunomodulated dose titration. Infrequently, we use higher dose and duration, and all this was anecdotal. This was the paper which was published in Intensive Care Medicine from India in 2014, Dr. Karnar's paper. There also we used 12 lakh units, 200,000 units, 12 hourly for 5 days. And we published some articles in ACMED in dengue, severe dengue, and in severe sepsis of varied etiology. And we also used 2 lakh unit 12 hourly for 5 days, which was the conventional dose for ulinastatin. This was published in 2019 by Chang Group in Pulmonary Medicine, BMC, which was a meta-analysis, ulinastatin treatment for ARDS in China, a meta-analysis of RCTs. It was a very, very big meta-analysis. Total number of patients including was 2,344, and they compared ulinastatin versus conventional therapy. What I want you to focus here on the dose. Wang, 2017, 200,000, 8 hourly, 7 days. Ye, ARDS 2016, 600,000, 8 hourly, 12 days. Mo, 2016, 200,000 units, thrice a day, 10 days. V, 200,000 units, 8 hourly, 7 days. Fang, which was for severe sepsis, 300,000 units, thrice a day for 10 days. This was Indian paper, 200,000 units, twice a day for 5 days by Dr. Karnar, Dr. Mehta, 2,000 units, twice a day for 5 days for sepsis. This was published in Journal of Thoracic Disease, again a Chinese paper from Zhu Group. Use of ulinastatin was associated with decreased mortality and in critically ill patients with sepsis. They compared ulinastatin in dose of 2 lakh units thrice a day. And what they found, ulinastatin treatment is actually decreased 28-day mortality. Again, what I want you to focus here was the dose of ulinastatin, which is much higher what we are using in our practice. This was published in Medicine with an open access journal. It was an observational study from Nanjing, China. Retrospective study of 130 eligible patients with sepsis, 65 patients in each arm. Ulinastatin 2 lakh thrice a day versus ulinastatin, followed by ulinastatin 1 lakh unit thrice a day for 4 days. So you can see the dose has been modulated depending on phase of disease. So we have to understand the dose, the duration will depend on the severity of inflammation. The results of this study was that patients in the intervention group achieved better outcomes in enhancing Apache 2. As for safety, although several adverse events were reported in the patient case reports, no significant differences were detected between the two groups in this study. If we see these more studies, Chen et al. For sepsis, 2013-14, 2 lakh units twice a day for 7 days. Dai, 2 lakh units, 12 hours for 5 days. Wu et al. 2016, again for sepsis, 200,000 units 8 hourly for 8 days. So the number of days is also variable and the dose is also very, very variable. Safety of high dose was approved by many authorities, and this was the paper where high dose ulinastatin was used in patients on cardiopulmonary bypass by V group. They reported high dose ulinastatin 10,000 units per kilogram followed by 5,000 units per kilogram per hour could improve pulmonary oxygenation after cardiopulmonary bypass and in the early stage of ICU stage patients undergoing aortic valve surgery with cardiopulmonary bypass. The dose of 0.8 million, 8 lakh units per day and 1.6 million units per day, 16 lakh units per day was administered in the low dose and high dose ulinastatin. No serious adverse events were observed at either dose and most adverse reactions were tolerable. Then came the Shanghai Protocol in 2019 for COVID, where they used ulinastatin at 0.6 to 1 billion units a day until the pulmonary imaging examination improved for COVID. Ulinastatin, they also gave 1.6 million units once every 8 hours under mechanically ventilated patient when the oxygen index was more than 300, which was later reduced to 1 million units per day, which was an astronomical dose for us. And this was from the expert consensus on comprehensive treatment of COVID in Shanghai 2019. Dose of broad spectrum protease inhibitor ulinastatin given 1.6 million units once every 8 hours under mechanical ventilation patients when oxygenation index is more than 300 can be reduced to 1 million units per day. If the lung lesion progresses, it is recommended to apply a large dose broad spectrum protease inhibitor at 600 to 1 million units per day until the pulmonary imaging improves. Few more studies, most of them are again from China, 2 lakh thrice a day, 7 days, 600,000, 6 lakh units thrice a day for 12 days, 200,000 thrice a day for 10 days, 200,000 thrice a day for 7 days. This was a case report from Tamil Nadu, efficacy of anti-inflammatory drug ulinastatin in COVID-19, where again they used 200,000 units, 8 hourly dose with remdesivir for improving the oxidation indices for the patient. The conclusion, a high dose of ulinastatin treatment was safe and potentially beneficial, although this was a case report. We also published few case reports which are similar for sepsis and for ARDS. This was the IACCM guidelines and they had a similar recommendation to Shanghai Protocol, 16 lakh units of ulinastatin doses to prevent and treat hypercytokainemia. DCGI gave us an approval in June 2020 to conduct a phase 3 prospective randomized open label comparative clinical study to evaluate efficacy and safety of ulinastatin plus standard of care in ARDS for COVID-19 patients. Again, we used 2 lakh thrice a day for 3 to 5 days. The dosage may be adjusted according to the age of patients and severity of inflammation. The proposed recommended dose of ulinastatin for clinical trial in mild to moderate was 200,000 units thrice a day over 1 hour. The indications, though the indications are clear for ulcerative pancreatitis, sepsis, ARDS, the timelines are still vague. When to use this therapy? ARDS, severe COVID, hypercytokinemia, sepsis are common indications. Some clinicians utilize them for prevention or worsening of hypercytokinemia and COVID, which is in a smaller dose. Looking at magnitude of COVID, the indications could be more than what meets the eye. More often, compassionate use has been utilized during COVID pandemic and earlier also. So the conventional indications are ARDS, severe COVID, hypercytokinemia, sepsis, prevention or worsening of hypercytokinemia. Will high dose be a magic bullet? No, there is no magic bullet. Having one primary treatment for any medical disease or symptom makes sense on the surface until we realize that all disease and everything in our biological world is complex, which means there will never be one right treatment or a magic bullet for any disease. Same applies to sepsis or COVID. As much as we would like reductionist science to be true, that we can identify a single cause leading to an effect, that things are black and white, that a drug or device is good or bad, that there is one right answer. It's not how science works. It's not how biological world works. The way forward, we have to understand the timelines for therapy. We have to use these therapies very, very judiciously. Theranostic guidance is required. We have to build robust evidence on dose and duration. Indiscriminate use and pseudoscience has to be discouraged. Let the cure be not worse than the disease. The practice points, timelines for immunomodulatory options have been fast-tracked and shortened during the COVID pandemic. Many agents have been repurposed. Many drugs have been repurposed, have been having repurposed doses. Indications have myriad more than what meets the eye. Different disease, different phase, different severity requires a repurposed dose which is based on clinical picture, the severity, the phase of disease, and the degree of inflammatory markers. I like to end my talk here. Thank you all.
Thank you, Dr. Yash. Very useful talk. Now, I think we'll have questions later on because we're already running short of time.
Sure, sir.
I would now request our next speaker, who does not actually need an introduction, Dr. Pradeep Rangappa, who is a very well-known face in critical care circles. He has been a senior executive in the ISCCM, and he's a great teacher and is going to talk about EDTA. Dr. Rangappa.
Thank you, Pankaj. Can you play the video, please? I think you have sent the recording.
Good afternoon, everybody. I'm an intensive
Dr. Pradeep Rangappa's video, please.
Singapore.
Saurabh. Saurabh?
Yes, sir.
Dr. Pradeep Rangappa. No.
Just a minute, sir.
Yeah.
Yes. Meanwhile, can we take a couple of questions? Yeah. Yes, I have a couple of questions for you.
Yes, please.
See, what seems to be clear is we still do not know what is the exact dosage of ulanastatin, and we do know that it has been used in a wide variety of disease conditions. Do you think the underlying pathology or the etiology has any influence on what type of dosages would bacterial sepsis, septic shock, maybe a different dosing, ARDS, maybe a different dosing, pancreatitis, maybe a different dosing?
Yeah, thank you, Dr. Shyam. what we traditionally felt and did was 2 lakh twice a day. Very rarely we would escalate dose or duration of urinary setting before COVID pandemic. But once this pandemic struck us and we used in number of patients and we had some better understanding about degree and severity of inflammation, at least for me, I can say. But most of us understood inflammation better. So now we are comfortable with titrating dose of immunomodulators. Started with steroid, but it was extrapolated to other drugs. So every disease and what I felt, ARDS, we were underdosing grossly for the ARDS all through these years. And we were generally limiting to 5 days, but we have to understand inflammation can vary from patient to patient. So at times you might need a prolonged dose. And at times if your patient has improved, you can de-escalate the dose and duration as well. So it has to be personalized. Yeah.
Yeah.
Can we play the video? Yeah.
I have one more question. Yes, till we get the video right.
Yeah. Saurabh will play when it's available. It's ready. Is there any issue, Saurabh? Yeah. Yes, Dr. Ghanshyam.
Can I play it from my end, sir?
Yeah, please play.
Allow me to share my screen.
Good evening, friends. So, there's a WORLD SEPSIS.
Hello. Yeah. Sorry, we'll take the questions.
Sure.
I'll be talking on this topic.
I can play it once your talk is done, sir. Please let me know. I have just shared.
Yeah, please start.
Okay, thank you.
On a new molecule, innovative molecule, EDTA. So what is the science and evidence for the same? So in next about 15 minutes, I'll take you through, so what is the burden of global antimicrobial resistance that we have? Antimicrobial resistance in India, is it something for us to be worried about? And do we need to have new tools in our armamentarium? And what are the basic mechanisms? So a broad overview on the antibiotic resistance mechanisms. And a bit about this molecule EDTA. So basically it acts on a multifold, as you see. So how is its effect as a resistance breaker, as an antibiotic potentiator, adjuvant? The predominant effect is on breaching this biofilm, and it is effectiveness in countering this biofilm, and its effectiveness in inhibiting the antibiotic efflux mechanism that is demonstrated by the bacteria in inducing resistance. And we'll talk about the studies that are available until now on this molecule and a take-home message. So these are the brief contents that I would be covering in next 15 minutes. So when we look at the human and economic cost of antimicrobial resistance, so it is this is a 2014 data. If you see, there are 700,000 deaths, which is only behind the cancer, which is the leading, followed by diarrheal disease and road traffic accidents. So antimicrobial resistance is leading, is one amongst the top 4 leading causes of death. And and if the resistance patterns continue the same way as it is, in 2050, it is estimated that 10 million people would be dying of antimicrobial resistance. And the trends really indicate that the resistance patterns have not shown any slowing down, and it is only increasing. And this could lead to 10 million deaths every year. And this would have a huge impact on the GDP in reducing it or affecting it by 2 to 3.5%, which is $100 trillion US. So when you look at the spread of antimicrobial resistance globally by 2050, so in Asia, we have around 4.73 million, 1.5 million, and then in Latin America, followed by Europe and North America. And India, as we know, friends, is a hotbed for antimicrobial resistance. So we have this New Delhi metallo-beta-lactomasis, which has spread globally. It started in India in 2006, then spread to China in 2008, to Europe in 2009, and to North America in 2010. So which means to say that there is a rapidity in the spread of these resistant strains across the globe. And with our increased global interconnectedness, it's only going to increase, and the spread also would become more and more rapid. And this is indicated by the sales of carbapenem. If you see, India is amongst the leading countries in the sale of carbapenems. And if you look at the total antibiotic consumptions, this is something which we cannot be proud of. We seem to be leading in the antibiotic consumption, followed by China and USA. So which is again not a good news because the more we use antibiotics, the more would be the antibiotic resistance that we would be inducing, and we need more tools to counter this mechanism. So now coming into the latest Indian report. So this came as the data which came from the National Action Plan 2017 to 21. So if you look at the E. coli, 61% of the E. coli was found to be ESBL producers. And when we looked at the Klebsiella, 31 to 51% of the Klebsiella were carbapenem resistant Klebsiella. And when you look at Pseudomonas, 65% of them were resistant to ceftazidime, and 42% of them were imipenem resistant. And when you look at Staphylococcus, because Staphylococcus burden seemingly was less in Asia, or particularly in India, compared to Europe or America. So you would see that the resistance to Staphylococcus also has significantly increased from 29% in 2008 to 47% in 2014. And when you look at Salmonella typhi in India, 96.7% are resistant to nalidixic acid, 37.9% are resistant to ciprofloxacin, which is often used as a first line in Salmonella typhi. And 7.3% are resistant to azithromycin, and 3.4% of Salmonella typhi are MDR resistant. So this is the sort of a latest sort of a data that we have on the resistant pattern of commonly occurring bugs that we treat in ICU. And whether now the question arises, now past 2 years we have been busy with COVID, and whether COVID has had any impact on the antimicrobial resistance. So this is a good paper that came out looking at the impact of COVID on AMR, and it showed that coronavirus has significantly increased the secondary bacterial infections in the patients. And understandably, we know, friends, this is due to increased steroid usage and other immunosuppressants that we use. The risk of secondary bacterial infections has significantly increased. And this has, in fact, had an impact on increasing the death and worsening of ARDS in these patients. And increased antibiotic usage in COVID unnecessarily, indiscriminately. I'm sure all the friends here would agree that many a times antibiotics are thrown in inappropriately. Increased use of antibiotics also has led to increased AMR specifically in COVID. So COVID has really not changed the dynamics. In fact, I would say COVID has worsened our rapidity of spread of resistant organisms. So very briefly, we'll look into the second aspect. So what are the mechanisms of antibiotic resistance? So there are two broad categories when you look at it. So you have a natural resistance, and then you have an acquired resistance. In acquired resistance, it is a multimodal way that bacteria develop the resistance to antimicrobials. One is the genetic methods. So these are mediated by chromosomal and extrachromosomal mechanisms. So biochemical mechanisms are typically dependent on the type of antibiotics that we use. So limited reuptake of the antibiotics that one is using would lead to antimicrobial resistance, or modification of the target site on which the antibiotic acts also leads to resistance, or inactivity. So there are enzymes that inactivate the antibiotics, and that leads to antimicrobial resistance. And you have this efflux of antibiotics. Basically, antibiotics are thrown out by the bacteria by the efflux mechanisms. So the way we would approach this resistance also has to be multimodal. So we need to address this efflux mechanisms. We need to prevent the inactivation of it. And we need to develop modalities which do not alter the modification of the target site. So these are, in brief, the different ways the bacteria develops resistance, and we need to have tools to counter this. So what is the solution? So now we have this EDTA, which is available as in two strengths, 37.5 milligram and 75 milligram. So we need to see whether this holds promise as a tool to minimize this antimicrobial resistance. That's why we are here to talk about this. So the claim is that it is a resistance breaker. It does reduce the resistance. It does potentiate the action of antibiotic, and it is a good adjunct for antibiotic. So another important aspect when I was reviewing the literature about EDTA is it has a good effect on breaking this biofilm, or penetrating this biofilm, or minimizing the formation of this biofilm. And EDTA has an impact on inhibiting these efflux mechanisms or the efflux inhibition, because this is a mechanism where bacteria uses to throw out the antibiotic. So EDTA has a way in inhibiting this efflux pumps or efflux mechanism. So how does that happen? We'll see in a couple of slides. So antibiotic resistance breakers typically happens by EDTA by two mechanisms. The class 1 effect is by reducing the minimum inhibitory concentration of the antibiotic, and that there are in vitro studies which has demonstrated that EDTA, when used along with the antibiotic, acts synergistically to reduce the MIC levels. And class 2 mechanism of antibiotic resistance breaker is by host defense mechanism. Basically, it modifies the enzyme inhibitor and then it enhances the membrane permeability of antibiotics. So by doing this, EDTA may have had a role in potentiating the mechanism of antibiotic. And how does this EDTA help in minimizing or inhibiting the efflux pumps? So these are the efflux pumps. So basically, as the name suggests, these are pumps which throw out the antibiotic from the bacteria, which bacteria very conveniently uses. And as the name sounds, EDTA is a chelating agent. So it chelates the zinc ions and magnesium ions. And these ions, which I will show in the subsequent slides, are the ions that efflux pumps need for its functionality. So the efflux pumps basically use the zinc ions and magnesium ions, which are positively charged ions, to activate these pumps to, basically it's a fuel for the pumps which act as an engine to throw out the antibiotic. So by EDTA, by chelating this or by inhibiting this, basically the pumps would not have fuel to function to throw out this antibiotic. So that is the proposed mechanism. And EDTA has an effect in minimizing the formation of biofilms or improving the penetrability. So this is a typical schematic diagram of biofilms. So you would have a lot of bacteria encased, and you would have this biofilm formation around this bacteria and the other debris. And this would prevent the action of antibiotic or the inflammatory cells reaching out to the bacteria and eliminating it. And this biofilm typically consists of proteins, polysaccharides, and small molecules. So this is a very important figure, very nicely illustrated as to how EDTA acts. So you have this lipopolysaccharide sort of a structure covering the bacterial cell wall, and you have this positively charged and negatively charged ions, which sort of integrate to form the biofilm. And as I said, the fuel that is needed, so calcium ions and magnesium, the positively charged ions, are needed to form a bond with this negatively charged to create a biofilm. Basically, calcium and magnesium stabilizes these negatively charged ions by creating these nice bridges and bonds and help in formation of the biofilm. So when EDTA is used, it chelates. It's a chelating agent, so it removes this calcium and magnesium. So these negatively charged ions would not have this positively charged calcium, magnesium, and zinc to form the biofilm. And basically, your lipopolysaccharide will not be left with any of these negatively charged, creating bonds with the positively charged. So this is the way EDTA is shown to be effective in minimizing the formation of biofilm. So this is if you remember this figure, the clarity would be there that how EDTA is helpful in prevention of the formation of biofilms. And EDTA is a good adjunct for antibiotics in enhancing its potency in a very synergistic way. So the other important ways the EDTA acts is, as I said, by improving the membrane permeability. If you remember that slide, it acts by two mechanisms. One is to reduce MIC, one is to improve the host defense mechanism by improving the permeability, membrane permeability. And it acts as antibiotic buffer, and it improves the sensitivity of the bacteria to the antibiotic. And EDTA does have a direct antimicrobial effect as well, because you would remember that in propofol, case in which EDTA tool as an adjunct to the pharmacology. So I have around 3 minutes. Hopefully I should be able to cover. So pharmacology absorption, EDTA is not absorbed orally. It is parenteral IV or IM. Distribution is predominantly in the extracellular fluid. Metabolism is a chelating agent, so and it gets excreted. Elimination, 50% of it is excreted in 1 hour and 90% is excreted within 7 hours. And as I said, the dosage available is 75 milligram and 37.5. So the maximum daily dose is 3 grams per day, which means one could use 75 milligram 4 times if you want to use a higher dose, or 75 milligram as 2 times. So it is 3 grams per day is the maximum dose for 5 to 7 days. So indications, as this molecule is an adjunct to the antibiotic, pretty much it could be used as an adjunct with most antibiotics in any of these life-threatening infections one would be dealing with. And as I said, the pathogenic activity that one would be looking at targeting is all the E. coli, so the coliforms, Pseudomonas, Staphylococcus, Acinetobacter. These are typical bugs we see in ICU, along with Klebsiella. And these are the resistant bugs which are NDM producers, ESBL producers, and metallobeta-lactamyces producers. So you would ideally choose this agent to target these enzyme producers or these resistant pathogens, which we commonly encounter in ICU. So supporting articles, very quickly, I would see, I have to confess here, there are no big clinical data. So most data is confined to in vitro studies, looking at its effectiveness in reducing the MIC. Very quickly, I'll take you through this particular Indian study, where if you see, this was looked in Klebsiella, and they looked at the resistant patterns came significantly down when antibiotics were combined with EDTA. The resistant isolates were significantly less as compared to the group where it was not. See, this is the group where only antibiotics were used. This is the group where antibiotic alongs with EDTA, and you could see the resistance patterns coming down. And this is a data of Pseudomonas aeruginosa. Again, here, number of resistant isolates came down as when EDTA was added as compared to the group which had only antibiotics. So this was a study from Egypt where they showed the biofilm formation and antibiotic susceptibility. As you would see, it was significantly less across the antibiotic group by adding EDTA as an adjunct, reduced the MIC, and the highest inhibitory effect was found with meropenem at 81.6% and with nitrofurantoin 61.4%. So this is the sort of a percentage breakup. After EDTA was used, the biofilm negativity happened in 45.8%. In this group, it happened in 76.8 and 69.4. So there was a reasonable effect on mitigating or minimizing the formation of biofilm. This was again in vitro study. So this was one study, again looking at its effectiveness on efflux pump inhibitor, because as I said, it has a effect in inhibiting the efflux mechanism by chelating the zinc and the calcium ions. So you would see here the efflux pump inhibition happened significantly, because this is without EDTA, it was more than 512. If you see the numbers there, this is without EDTA. With EDTA, the efflux inhibition happened quite significantly in vitro studies. And this is the way the biofilm looks in the antibiotics used. So with ceftriaxone sulbactam, this is the biofilm formation. This is with piperacillin tazobactam. This is with meropenem, and this is with the control group. So this is how the typical electronic microscopic view of biofilm. So this was another study, observational study done between 2018 in 94 patients. They found meropenem when combined with EDTA, there was 50% reduction in MIC and improved the sensitivity. So these are, so as I said, I have to confess, all these 4 studies are in vitro studies. The last study, they did look at clinical indicators also, but mainly predominantly it was looking into the MIC levels. So the take-home message, antimicrobial resistance is a reality, and India is at the forefront of very high proportion of patients developing this antimicrobial resistance infections in ICU. And we need to understand the mechanism of AMR is very complex, it's multifactorial. Obviously, we have no influence on genetic mechanisms, but we have influence on biochemical mechanisms where inappropriate usage of antibiotics leads to antibiotic resistance by limited reuptake, inactivation, efflux mechanism, and modification of target sites. And EDTA seems to be, at least with regards to scientific hypothesis, it appears that it has some effect, it has a good effect on biofilm, minimizing the biofilm formation, inhibiting the efflux mechanism, an antibiotic resistance breaker, and a good adjunct to the antibiotics. So there are 4 studies, and it is all in vitro studies. So what I would conclude at the end of my talk is we need a good in vivo clinical studies which would add a huge value to this new drug EDTA to convince us that using this in a clinical scenario, whether it has had an impact on influencing favorable outcome, especially in these MDR infections in ICU. So the reason I'm giving this talk is we are doing a pilot study on this EDTA in around 30 to 40 patients, supported by the Fusion Pharma, which is producing this drug. And then we would be comparing it with our historical cohorts to see whether usage of this antibiotic usage of EDTA with antibiotics in sepsis patients with MDR infections, whether it led to favorable clinical outcome. Hopefully, we'll come out with some data in the next talk that I would give on this. So thank you all. So I would end with this beautiful quote: "We don't grow when things are easy, we grow when we face challenges." So these molecules are something that needs to be considered, especially in these challenging times where we are increasingly dealing with antimicrobial resistance. So thank you one and all.
Thank you, Dr. Pradeep. Over to chairpersons. Dr. Ghanshyam is there?
Yeah. Thank you, Dr. Yash and Dr. Pradeep, as always, to the point and, delivering the message loud and clear. Pradeep, there is one question for you from the audience. Role of meropenem EDTA, ceftriaxone sulbactam EDTA, and EDTA PFS.
Yeah, thanks, Ghanshyam. So it looks like Ghanshyam has had a long day driving back from work. Yeah. See, I think the data is very scant, Ghanshyam. As you see, you really dig into the literature, there's not much. It's all in vitro studies, let alone comparison between these antibiotics. If you on meropenem was there, but I think the highest effect was found with meropenem, because you wouldn't use ceftriaxone for all this MDR, because this EDTA is an adjunct. It is not a solo drug. So we wouldn't use this alone for any sort of a ICU scenario, Ghanshyam. So we would be using it only as an adjunct in a life-threatening MDR organisms. That is where one would position this. So to answer your question, the last point, EDTA as a solo, we wouldn't use it. EDTA with ceftriaxone, you may argue that whether it is comparable to meropenem, even that we wouldn't use, because ceftriaxone with EDTA, I'm not sure how many of you would be using it for a life-threatening MDR infections. So as you see the data, the last study which I showed was done with meropenem, and with meropenem it seemed to have had good effect in vitro. So everything is in vitro. So we would need good clinical studies to convince ourselves whether this holds promise in influencing outcome, because as clinicians we are all interested in outcome, isn't it? So that would be my submission.
Pradeep, I have one question for you. Right, looking at the molecule, where do you think, will it find its role? In the initial stages when the patient comes to prevent the development of resistance, or once the patient has already acquired a MDR bug to break the resistance?
See, if you are dealing with a community acquired, I may have my reservations. This is my personal, because there's no data, Ghanshyam. Whatever I'm articulating is on the way I have understood this molecule. So if you are dealing with a community acquired, definitely not. But if I'm dealing with a hospital acquired infections, where predominantly I would be expecting a multi-drug resistant organism, I would be considering this. As I said, I would be testing this as a part of the study that I have given to my trainee. And then I would convince myself whether this has had an impact, Ghanshyam. So until then, I would hold my answers in the, making any strong recommendations, Ghanshyam.
Yes, I wanted to ask you one question.
Yes, please.
Would you go by any specific clinical or laboratory parameters to decide when would you want to start your ulinastatin and guide whether it's actually working or not?
By clinical parameters, yes. Not by a single lab parameter alone. It will be in fact a combination of biomarkers and the clinical picture for vast majority of patients. But now we actually know which patients will have a higher TNF-alpha or 2-calcitonin. Most of the times we have a hunch and we just do it to document it. So initially, yes, we were doing it with clinical picture and the biomarker level. But now we look at clinical picture, largely the hemodynamics and PF ratio. If they are bad, then we contemplate to use it.
Thank you, Yash. Dr. Pankaj, Dr. Ehsan, my other coaches, persons, if they have any question, comments.
I don't think there are any more comments. So we'll end this session here. We are running 1 hour late almost now. Thank you, Dr. Ghanshyam. Thank you, Dr. Rangappa. We move on to the next session. I like to invite the chairpersons for the next session. We have Dr. A.K. Singh with us. Dr. A.K. Singh is a consultant pulmonary and critical care. He's a senior physician at Regency Hospital, Kanpur. He has been and various test societies. Welcome, Dr. Singh, sir.
Yeah.
We also have Dr. Prashant Bhatia. Dr. Prashant is a senior consultant critical care at Faridabad. We also have Dr. Harsh Sapra. Dr. Harsh Sapra is Director Neurocritical Care at Medanta, Gurgaon. Over to the chairpersons.
So, very good evening, everyone. We are moving for the next session. And the first speaker is Dr. Jitendra Sharma. He is the head of the Department of Critical Care Medicine at Artemis Hospital, Gurgaon. He is going to talk about MRSA, current status, and the future scenario in India. Dr. Jitendra Sharma, please.
Thank you, Dr. Singh, for nice introduction. We are having a pre-recorded video for our presentation. Dr. Yash, can we play this video?
Yeah.
Hello, everyone. After a lot of interesting discussions about the sepsis and COVID infection, I'm going to talk about 1 gram-positive organism, that is MRSA. Years back, in 1945, Sir Alexander Fleming warned us about the antibiotic resistance development and its consequences. Now we are facing the consequences. In Staphylococcus aureus, there is a protein that is a PBP, penicillin binding protein, which actually a carrier of the beta-lactam antibiotic. And with this carrier, beta-lactam antibiotic kills the Staphylococcus aureus. There is a conformational changes and a defect in the PBP makes this bacteria resistant to all beta-lactam antibiotic. Okay, what's the problem? Yes, they are. First, this MRSA bacteria are resistant to all beta-lactam antibiotics. Second, the infection is more severe, potentially life-threatening. And third, even if you recognize the patient who is, or patient or person who is just carrying the MRSA and you can address it appropriately, can prevent the infection, as well as recognition of the MRSA bacteria in early course of infection prevents the life-threatening and severity of the infection. This is the just list of the few risk factors. These risk factors can vary from one institute to another institute and the different clinical situations. There are 3 distinct strains of MRSA, and recently livestock associated MRSA has been identified, and it can cause the infection to the person or the patients who are in close contact of the animal. Otherwise, it causes infection to the animals only. The MRSAs can cause the infections like bloodstream infections that can lead to the infective endocarditis or osteomyelitis, urinary tract infections, respiratory tract infections, surgical wound infections, and device-associated infections. Community-acquired MRSA and the hospital-acquired MRSA, these not only a different strain epidemiological, they are genotypical and phenotypical differences also. Especially a penton-valentine leukocidin toxin, PVL toxin, it is almost always present in the community-acquired MRSA, whereas it is not present in the, or a very less percentage of the hospital-acquired MRSA carrying it. A distribution of the different strain, hospital acquired and community acquired in the hospitalized patients. Mostly, almost 60% of the hospitalized patients have the infections by the hospital acquired MRSA. Only the few patients who actually admitted to the hospital with the community acquired MRSA, and during the hospitalized, some patients, near about the 28% patients, developed the MRSA infection due to the community acquired MRSA. What is the magnitude of the problem and its current status? Globally, approximately more than 50% of the countries of the world actually having MRSA incidences either more than 50% or 25 to 50%. And even in India, it varies from 10 to 25%, 5 to 10% on the different region of the countries. Globally, almost 53 millions are carrying the MRSA. And in US, 500,000 carry the MRSA strain. What about the India? A study shows there is gradual increase in the incidence of the MRSA, and also there is a significant numbers, that is 10 to 14% of the healthcare workers carries the MRSA. And in outpatients, ward patients, intensive care, the percentage of MRSA 25, 27, 49, and 47% respectively. And incidence of the healthcare associated MRSA was low in 1988, 6.9%. Now it is increased to 27, 32, 42.5, and 47% in the different parts of the India. This slide shows a trend of the MRSA to the individual antibiotic, and this trend shows aminoglycosides and the fluoroquinolones are the worst agent, which is showing the increased incidence to the increased resistance to the MRSA. This study conducted to know the incidence of the MRSA, their distribution, what are the distribution among the different isolates, and that shows 28, 42, and 43% of the incidence of the MRSA in outpatients, ward, and then ICU, and it's gradually increasing. And the data collected for this study is these are the center, different part of the countries which contributed for this data. Among the different isolates, pus, blood, respiratory samples, they all showed an increasing trend, especially in ICU, from the MRSA infections. Among the agents, of the agent for the MRSA, now it is showing only a 46% resistance to the MRSA, and ciprofloxacin is a really a worst agent for the selection of the MRSA. It is almost 80% resistant to this drug. Vancomycin and linezolid in this study showing almost always MRSAs, but that was published in 2013. But subsequently in 13 and 15, we recognize the even linezolid resistant Staphylococcus aureus, tigecycline resistant Staphylococcus aureus, and the vancomycin resistant Staphylococcus aureus. This make really looming threat to us. Now, recently in the COVID infection, we have noticed a significant patients are having secondary infections, and that too, one of the organisms they found is the Staphylococcus aureus. And what are the practices of the selection of the antibiotic in these patients? And this also reveals the Staphylococcus aureus is one of the agents which are responsible for the secondary infection in the COVID patients. Now we understood the problem, we defined the problem, we understood its magnitude and the current status. What are the future strategies? So future strategies, one related to the surveillance. As we know, there are the passive surveillance, targeted active surveillance, or high-risk patient. Passive surveillance, once you really come across the MRSA when the clinically indicated screening of the cultures you are required, and then you isolate them. Targeted active surveillance in the high-risk surveillance, you actively make a screening of these patients who are fitting into your list for the high risk. And universal surveillance is all the patients coming to the hospital would be screened for presence of the MRSA bacteria. What are the pros and cons we can narrate in the subsequent part of the talk. Regarding the testing methodologies, there are different methods: broth microdilution method, cefoxitin disc method, lead test, agglutination test, oxacillin, the Muller-Hinton agar supplemented with the 4% NaCl, and the selective chromogenic agar that can also be used for the MRSA, and the PCR-based test. These all are the methods present in our armamentarium for the recognition of the MRSA. Each method has its own advantages, disadvantages, and the cost implication. Of course, the conventional methods are less costlier. They are less complex, but PCR-based, say for example, are complex. They require a dedicated labs, more training of the technicians, and of course the cost implication. But the greatest advantage related to the PCR is the less turnaround time. Of course, there are certain problems associated with the PCR test. What can be done in the future related to our overall strategy for the management of the laboratorical identification of the bacteria, local, regional, and the national? These three categories of the lab should work in harmony with each other. Local, more focused towards the detect the outbreak, pathogen identifications, and risk assessment, whereas the regional is for prevention and control of the infections, keep the microepidemiological data and evaluation, and the regional surveillance, whereas the national laboratory actually collect all the data, keep all the data, and make the long-term epidemiological plan, and they actually contribute for the overall planning of the dealing of the MRSA. In this way, the future work can be done to deal with the MRSA. Infection control practices, I'm not really re-emphasizing on the infection control practices. These are the, you can say, common practices for all the MDROs. But what is the importance over here is to give more focused attention regarding the implementation of this thing, increase the compliance rate of the different infection control practices. Similarly, antibiotic stewardship. Like any other infection prevention strategy, this also reduces the MDRO organism as well as the MRSA. The problem is again related to the universally practice of the antibiotic stewardship as well as is the consistency. So again, we need to pay more attention, and then in the future, all these strategies will be strengthened in a different way to increase its compliance and consistency. Now, screening, isolation, and eradication strategy versus the antibiotic stewardship and horizontal infection control practices. Of course, we have to overlap all these strategies. These strategy, again, each process has its own advantage and limitations. Like screening, as we discussed in the previous slide, passive screening, high-risk screening, and the universal screening, but there is no really consensus or international or national standard regarding the screening methods. Eradication, even a complete eradication does not lead to a complete control of the MRSA, which we already seen in the previous research and the studies. Isolation, of course, they are immediately helped to some extent, but technically, in isolation, patients become completely isolated from the other clinical attention also, and that makes a little bit compromise the patient safety. Antibiotic stewardship, as I discussed, of course, it reduces the MDRO as well as the MRSA to implement and the consistency, we require a lot of specialists, infectious disease specialists, cost-related issues, and the manpower. Antiseptic washing, a gradually chlorhexidine washing is gaining popularity. But there's an issue about this antibiotic washing with the chlorhexidine is the development of the resistance against the chlorhexidine. Hand hygiene, as I told you, is again an age-old intervention. But the problem again, as I told you repeatedly, is the compliance. So what newer thing can be done is the new equipment, more technology, Wi-Fi surveillance, or wearable gadgets, all these things. In the future, COVID-19, what would be our take on the COVID-19 patients? Will they require empirical MRSA treatment? Yes, maybe. Depends upon how we can segregate. And of course, it will require a risk stratification. Those who are at risk of the MRSA infection should receive empirical anti-MRSA treatment. What are the agents in future which can help us to combat this menace? Of course, glycopeptide are no more the undisputed choice of the antibiotic for MRSA infection, but a novel genomic-driven approach to drug development is being now explored. Molecules that target fatty acid synthesis as a vinexathon, which inhibit the FABL, has been recently described as a selective inhibitor of Staph aureus. And similarly, the molecules which targets the bacterial RNA polymerase, and this is the enzymes in the ATP pathway, teichoic acid synthesis, lipid synthesis, and bacterial proteins are the potential options for the in future. Use of tea tree oil for nasal application for eradication of the MRSA carriage of the MRSA. Antiseptic coated endotracheal tube use in the ventilated patients. Hydrogen peroxide use to decontaminate the environment. Air filtration units, phase therapy, and use of XF compound, which acts by the oxygenated radical disinfection on exposure to the light. So in summary, the classical approach composed of screening, isolation, and eradication has limitations. We know lack of risk of medical error, failure to eradicate bacteria. But a novel approach with training of infectious diseases specialists can reduce the use of antimicrobial, thereby significantly decreasing the emergence of the new MDROs. Increase high hand hygiene compliance. Like with the use of the new tool, of course, the conventional method for the observations and the point surveillance, but the newer technology can be incorporated to enhance the surveillance of hand hygiene by electronic wearables and Wi-Fi equipped dispensers. Daily antiseptic body wash can help, but as I told you, it may cause the resistance to the chlorhexidine. Approach to MRSA infection is likely to be tailored or individualized in clinical situation in future. And lastly, in COVID-19 infection, its implication related to the use of anti-MRSA in secondary infection as an empirical therapy. Obviously, we'll wait for further studies, and obviously we need to identify separately, apart from our conventional risk assessment for the MRSA, what is the unique risk factors in COVID infection which help us to identification of bacteria that would really help to guide us about the anti-MRSA therapy in the COVID patients. Thank you.
Thank you, Dr. Jitendra. May I request Dr. Sapra to introduce the next speaker?
Good evening, everyone. Yash, excellent conference and excellent organization as always. May I take the honor of inviting Dr. Ajit Vej, who would be speaking on a very important topic, our very own 2DG in COVID. Dr. Vej is a senior consultant and physician, respiratory medicine at Apollo Hospitals, Hyderabad. Dr. Veg, stage's all yours.
Can we, Dr. Vich, can we start the?
Yes, I'm starting.
Yeah, good evening, sir.
Good evening. Thank you for your brief introduction. At the outset, I would like to thank the organizers for inviting me as the last speaker of the day for this talk on the role of 2DG in the overall management of COVID-19 infection. And as we are all aware, this molecule has been introduced recently in the screen sharing. This has been introduced recently, and I'd just like to take half a minute for screen sharing, and just allow me to do the sharing of the screen. Increase the size. Yeah.
On the left side, this will be full screen. Here, sir.
Yeah, I'm doing it. Give me a time. Give me 1 second. Okay.
Yeah.
Is that visible now?
Yes, sir. Yes, sir.
Okay. Right. So there are several issues with the COVID infection about the high COVID-19 burden on the healthcare system, as we have been listening since morning on this particular issue. And there is always a difficulty in predicting who are the patients who are at risk for development of severe disease and multi-organ failure. Few proven therapies have been available to prevent COVID-19 hospitalization and to overall reduce the morbidity or mortality. And we are all familiar with the role of vaccine and its limited vaccine supply shortage. There are also issues of duration of post-COVID-19 immunity and potential for reinfection, particularly with the new variants, which we are now seeing, variants of concern and variants of interest, and overall availability, access, cost of available therapies also needs to be looked at, whatever strategy we adopt for our patients with COVID. Just to remind this August gathering, there primarily when a patient gets into infection with COVID, we encounter 3 stages. Early infective stage, where there is a viral response predominantly. Patient manifests clinically with fever, cough, myalgia, and shortness of breath. During the second stage, intermediate stage, where there is predominantly a pulmonary phase, and there is obvious shortness of breath and obvious hypoxemia, abnormal CT imaging, and elevated transaminases. And then there is a decreased host inflammatory response, as a result of which leads to the third phase, where there is cytokine storm, hyperinflammation phase with ARDS, multi-organ failure, septic shock, cardiac failure. We are all too familiar with all this, and our goals of treatment are, as much as possible, try to identify patients in its early stage, which we effectively did during the second phase all over the country with outpatient-based management, giving them including non-invasive ventilation and oxygen support system at home for majority of our patients during the first stage. In the second phase, when there is a predominantly pulmonary involvement, there is these patients need to be put into the hospital with some sort of a support, either in the form of high flow oxygen through the nasal cannula or non-invasive ventilation. In the third phase, obviously the patient is critically ill and they need to be intubated and provided with ventilatory support, and also with all other supports for all the multi-organ failure. The goals of treatment are: target the viral replication with a proven directly acting oral antiviral agent so as to achieve total viral clearance, so as to reduce the duration of symptoms, minimize contagiousness, prevent further progression of the disease from mild to moderate and moderate to severe. So these are the various goals, at least in its early stage. During the phase 2 or the pulmonary phase, the goals are rapidly to bring down the viral load with most potent antiviral agents, oral or IV agents, to minimize the host inflammatory response, mitigate the so-called cytokine storm which is building up in the patient, limit progression of the disease, and reduce hospital stay. During the terminal stage or the hyperinflammatory phase, the tailored therapy with the use of various immunomodulatory agents to reduce the systemic inflammatory response before it overwhelmingly results in multi-organ failure, and try to improve the prognosis or the overall clinical outcome as much as possible. The current therapy, where various approaches we have are preventive approaches. We are all too familiar with the use of masking, social distancing, hand washing, vaccines. I don't want to bore this August gathering with any of those preventive approaches. Let us look at the therapeutic options we have. We have several antiviral agents available now: remdesivir, IV, oral favipiravir, oral and IV steroids, particularly dexamethasone, oral baricitinib, monoclonal antibodies, and last but not the least, 2DG. So what is this 2DG molecule? It's an antiviral and an anti-inflammatory drug. So it has dual mode of action. And this was first developed by the Institute of Nuclear Medicine and Allied Sciences of the DRDO group. DRDO then joined hands with Reddy Labs, and they conducted clinical studies in the last 2 years for 2DG in COVID patients. Based on the results of phase 2 and phase 3 clinical studies, which were conducted in India a year ago, 2DG has received about 3.5 months now an emergency use authorization as an adjunct therapy for both moderate and severe COVID-19 infections in the hospital setting. 2DG is administered orally in a dose of 45 milligram per kilogram body weight per dose, given twice daily on an empty stomach. The molecule, the uniqueness of the molecule is there is no oxygen at position C2. It mimics glucose in plasma and during the cellular uptake. However, it does not get metabolized in the cell. That is the unique property of the molecule. It inhibits energy production. It inhibits anabolic reactions required for viral multiplication. And that's the reason why it is so uniquely placed and can really help us in mitigating the problem of COVID-19 infection. Selectively, higher accumulation of 2DG in virally infected cells occurs because of the higher glucose demand by the multiplying virus. 2DG not only inhibits energy production, but also inhibits anabolic biochemical reactions required for virus multiplication. It alters the glycosylation of viral glycoprotein, rendering the new virions incapable of infecting human cells. Therefore, 2DG acts in two ways: by inhibiting the virus multiplication and altering the glycosylation of viral glycoproteins, rendering new virions totally incapable of infecting or transmitting further infection into the human body. So two studies have been done, phase 2 studies and phase 3 studies, and I will briefly take this August gathering with the salient features of the phase 2 and the phase 3 studies. And then followed by that, our own clinical experience in the real world, where we used it on more than 56 patients. A randomized phase 2 study where this molecule was used as an adjunct therapy in the randomized open label dose ranging clinical trial, primarily to evaluate the safety and efficacy of 2DG in comparison to standard of care alone in the treatment of COVID-19 infection. So these were the 3 doses they selected in the phase 2 study: 63 milligram per kilogram body weight per day, or 90 milligram per kilogram body weight per day, or 126 milligram per kilogram body. The whole idea during the phase 2 studies was to see which is the optimum dose which will help our patients to improve significantly. And let me just take you through the salient features. The median time to achieve and maintain oxygen saturation more than 93% was about 2.5 in those patients who received 2DG and standard of care, when compared to those patients who are only on standard of care without 2DG. The duration, overall median time to achieve and maintain adequate oxygenation was almost double, about 5 days. This was statistically significant. So this study clearly showed that 2DG significantly increased the time to maintain oxygen saturation above 93% when compared to standard of care alone. Also, in that study, they looked at the time to vital signs normalization, and again, the median time taken when compared to standard of care alone, where it was 8 days in those patients who received standard of care and 2DG. Although the numbers were small, there were about, definitely it was reduced from 8 days to 5 days. Again, this was statistically significant. Thereby, it showed that significantly decreased the time to vital sign normalization when compared to standard of care alone. So the key points from phase 2 study was basically showed a favorable benefit to risk profile, and the risk was hardly any risk. No serious side effects were related to 2DG. No serious adverse events were observed. 2DG was very well tolerated by all the patients. The benefits were that there was a faster time to achieve and maintain oxygen saturation above 93%, 2.5 versus 5 days. Faster time to vital sign normalization, and 5 days versus 8 days. Let us look at the phase 3 study, where they had more number of patients, and this was again a randomized open label clinical trial evaluating the efficacy and safety of 2DG glucose as an adjunctive therapy to standard of care. And here there were about 220 patients with 1:1 randomization, and some of the sample size was derived from phase 2. And again, you can see that the dose was 45 milligram per kilogram body weight in twice daily duration, given for up to 10 days or until early discharge. And the WHO 10-point ordinal scale was used. For the scale 4 indicates that patient no longer needed supplemental oxygen. In phase 3 study, median WHO score was 5 at baseline. In the 2DG arm, 42% of patients had a score of 4 versus 31% in the standard of care arm by day 3. Relative improvement occurred in almost more than 1/3 of the patients. The clinical efficacy outcome at day 3 in the phase 3 trial clearly showed that 2DG led to a faster improvement, more than 1 point improvement, where the patients were free from oxygen dependency in the WHO ordinal scale. All patients were recruited at WHO scores of more than 5 or equal to 5. That is, all those patients who were on oxygen were evaluated. And there was a significant improvement in majority of these group of patients. So I would now like to take you through our own experience in the real world, where we looked at overall 40 patients initially, but these numbers have gone up in the last 1 month. We have added on another 16 patients, so we have now almost close to about 56 patients. But I'll share with this August gathering our original data of 40 patients, out of which 30 patients were RT-PCR swab test positive. 10 patients were negative for the RT-PCR swab test, which were done 2 times with a space of 5 days in between. And these patients were presumably having some sort of an acute viral pneumonia, which is not uncommon in an ICU setting in our pulmonary and critical care unit. All the bacterial and the fungal infections was ruled out based upon blood and sputum and endotracheal tube secretions culture sensitivity. The mean age was about 49 years. There were about 28 males and 12 females. It is important to recognize that the baseline oxygen saturation at rest in most of these patients was around 92%. We all feel very happy that they are now desaturating, they are maintaining around 92%. But let me just remind this August gathering that these are the group of patients who would desaturate on minimal exertion, the so-called happy hypoxemia, which occurs in majority of the patients. And I would like to bring it to your kind attention how 6 minutes walk test helped us in evaluating their severity of their hypoxemia. In our 40 patients, when we looked at the baseline oxygen saturation was 92%. After conducting a standard 6 minutes walk test, they dropped their saturation significantly by more than 6%, around 86%. The walking distance, which we normally measured as a routine in all our patients who come to our clinics in the pulmonary unit, the overall walking distance on an average was 497 meters. Heart rate was about 93. The both dyspnea score and the fatigue clinical score with which we on the scores in initial 2D. On the right side of the panel here, the oxygen saturation after 10 days of 2DG with the standard of care showed a significant improvement. The baseline improved to 95% from 90 walk test to 95%. The patients, the overall heart rate came down significantly, and dyspnea score also came down significantly, thus showing that 2DG along with the standard of care led to a significant improvement of oxygen saturation continued to remain above 6 minutes walk test. The overall mean walking distance improved by more than days. There were no major safety concerns observed with the use of 2DG in our clinical practice. So where do we position it? We have all these various therapeutic options available. When do we do that? Although the current recommendation and the current licensing of the molecule by the drug controller in India is for hospitalized patients with moderate to severe, but I have a strong personal hunch that in the next 1 year or so, or at least in next 9 months or so, we may probably start using 2DG in its early phase so that we can control the disease even in non-hospitalized patients at home. But as of now, only in hospitalized patients, it is recommended to initiate 2DG therapy. We have all these other molecules of which we are all too familiar with, and I don't want to bore this august gathering, knowledgeable gathering on these molecules. So majority of the COVID-19 patients are usually admitted with a score of 4 or 5 on the WHO scale. There is an overlap of viremic and inflammatory phase as demonstrated in the clinical studies. Addition of 2DG to standard of care leads to faster improvement for better clinical outcomes. 2DG therefore should be started in patients at the time of admission in the hospital. An early start of 2DG will definitely help us to augment both antiviral and anti-inflammatory effects along with the standard of care. Earlier symptomatic treatment and earlier discharge of patients, which is the key thing, because we don't want to overburden our healthcare system with too many beds being occupied. So early discharge from the hospital would be beneficial. So in summary, the molecule has a dual mode of action, antiviral and anti-inflammatory. Also has been demonstrated in vitro to have clinical efficacy against multiple variants of COVID-19 infection. Can be added to any standard of care, oral solution, easy to administer, even in critically ill patients. We can add on through the Rahul's tube and give it to our patients. I have already 2 and the phase 3 trials, basically trying to reiterate the same thing, that the overall faster time to achieve and maintain oxygen saturation in the 2DG arm was definitely much better than in the standard of care arm. And 2DG led to higher proportion of subjects improving to the score of 4 when compared to the score of 6 when compared to those patients who were on only standard of care therapy. Well-documented safety profile, demonstrated efficacy of 2DG in leading of early relief from oxygen dependency will definitely provide lot of benefits to our patients. Thank you for your patient listening. If there are any questions, thank you once again for your patient listening.
Thank you, sir, for a very great talk. Any questions for Dr. Vic, sir?
Dr. Vic? Yes, I do have one question. Yes. Can we give both 2DG and remdesivir simultaneously?
Yes, we have had several patients who were critically ill, who were severe cases. So while giving them IV remdesivir, they were continuing to receive standard of care along with also receiving remdesivir as well as 2DG. And yes, it definitely helped.
So that means there are no contraindications.
There are no contraindications, none whatsoever at all.
Thanks.
No further questions? Then we move on to is by Dr. Manu fraternity. And is in at Poland. He has been treasurer of World Society of Abdominal Compartment Society, and he runs the International Fluid Academy. He is an authority in hemodynamics, abdominal compartment, as well as fluid therapy. Dr. Manu Malgren's recording, please.
Hi, ladies and gentlemen. I'm Manu Malgren from Belgium. I will give a talk on fluid therapy in COVID-19 patients. These are my conflicts of interest, the biggest bias being the co-founder of the International Fluid Academy. I'm very fortunate to have met Mathilde, Her Majesty Queen of the Belgians, and Philip, His Majesty King of the Belgium, when I was visiting our hospital during the first wave of the COVID pandemic, as well as Maggie, Belgian minister, former Minister of Healthcare. My lecture will be on breaking bad habits. And fluids are drugs and should be treated accordingly. I will tell you a bit on definitions, diagnosis, drug, dose, duration, de-escalation, and discharge. And D1 multiplied with D7 gives us D to the 7 power, or thus fluid stewardship. So D1 is on definitions, and I don't want to provide a long list of boring definitions and overload you with data, but it's important to remember a couple of them. We all know fluid balance. Fluid overload can be calculated by the cumulative fluid balance over the patient's initial body weight, and it's defined by a cutoff value of 10% of fluid increase. Early adequate goal-directed fluid management is surviving sepsis. Late conservative fluid management, 2 consecutive days of negative fluid balances within the first week, and late goal-directed fluid removal is de-resuscitation, active fluid removal. Fluid overload is accompanied by hypervolemia, hyperhydration, and results in peripheral anathertic edema. So while hypervolemia usually is the cause of peripheral edema, and that the patient is avoid the term. There are many other definitions. I will not go into detail now, but will discuss them during the rest of my talk. Hypovolemia is bad. So D2 is on diagnosis of fluid status, as fluid status matters. There are a lot of myths surrounding this, like septic patients, they are not always hypovolemic, or surgical patients are not always hypovolemic. Sepsis and fever does not mean there is a huge insensible loss. And peripheral edema does not mean that the patient should be given diuretics. Low preload also does not mean that the patient needs to be given more fluids. Preload is the stretch on the actin-myosin complex before systole. And in real life, it's combined with afterload. Left ventricular and diastolic volume would be the best preload parameter, but it's not easy to measure in real life. So for me, ideally, preload is a combination of different parameters that tell me fluids are needed and can be given safely. So whenever there is a therapeutic dilemma, which means that treatment options may cause harm, we have to weigh the benefits and the risks of fluid administration by using different parameters, barometric, volumetric, looking at fluid responsiveness with a passive leg raise test, and assess the impact of fluid overload on end organ function. We must be aware that abdominal pressure and positive expiratory pressure may have an impact on all these parameters. Fluid status matters, and there are some clinical signs of hypoperfusion and hypovolemia, but they are rather aspecific. Other signs refer to monitoring, laboratory imaging, and impact of hypoperfusion on organ function. Fluid status matters. Brings me to D3, or the drug, and the first thing is that we should not cause harm to the patient. There are 4 questions surrounding fluid therapy, the first being when to start IV fluids, and the best fluid is the one that has not been given unnecessary. Second question, when to stop fluids. Some patients will not mobilize the excess of fluids given spontaneously and may need fluid removal. And when we're removing fluids, we must avoid hypoperfusion, so at some point we need to stop. 4 indications. Resuscitation fluids should save lives, and they received most of the attention in the literature with the big fluid trials. And the results of these studies, like CHEST, Success, Crystal, Albios Split, Salt Smart, caused a lot of reaction in the scientific community. The bottom line, resuscitate patients and give hypotonic solutions as only 10% remain intravascularly, 25% that they sent ICU, and also in COVID, gelatins, no safe solution. So balanced choice, and of course blood percent in the energy being more important. Or resuscitation fluid is part that we give to our Niels van Regenbotel studied and found that of all and was for resuscitation. 33% fluid creep, fluid that's administration of other drugs. Maintenance fluid, water, glucose, so per kilo per hour, kilo per day, and glucose per day. Studied in isotonic maintenance solution surgery. So the bottom line was solutions result balance about 1.5. Replacement and gastrointestinal loss have to fall up north because not contain 100 no chloride. Look should cover the caloric need use fluids into. For these in analogy 6, it's all about duration and who's in a Paracells Gift und nichts ohne Gift. Kein Gift. It's the dose. For a concept on dosing very well, and it and pharmacodynamics and pharmacodynamics, the actions of the drug on the bug. Finally, the duration, because what I really need to know after starting fluids is when can I stop fluids. So it's about the risks of further fluid loading. We should not use fluids to treat the numbers, to normalize blood pressure or CVP or urine output, but we should use fluids to treat shock. 6 is on. The last question was when to start fluid removal, which brings me to the fourth conceptual model of the ROSE, resuscitation, stabilization, and at the end, evacuation, hence the acronym, the ROSE. So after the first hit, whether it being sepsis, trauma, burns, pancreatitis, fluids must be given and fluid balance should be positive in order to save the patient. Then comes the phase where we stop refers. Some patient will to flow phase removal. The third hit refers to GIPS, global increased permeability syndrome, and of course, we must avoid chronic. Just tell you, I'm very the problem is that no one single study examined the different phases of fluid therapy. So when we are rescuing patient with goal-directed therapy, optimizing organ function and stabilizing with late concerns may need to evacuate the excess of fluids and save the patient. Will guide or resuscitation based on functional hemodynamics and passive leg raising test. When these normalize, we stop fluids. When the patient on evacuate, flow and perfusion. Single study looking phases of fluid therapy. The goal is to avoid GIPS, and the reason for the anasarca just being, of course, there is a problem because a positive fluid balance is an independent predictor of outcome in patients with sepsis, and restrictive regimens carry a better prognosis than liberal fluid management. Reason for this is that fluid overload at the outside, or anasarca, mirrors fluid overload at the inside, and organs will dysfunction and fail, also especially related to venous permeability syndrome. Data shown that early conservative, late conservative fluid management carries a better prognosis than giving liberal fluids initially. Is this also the case in COVID-19? The answer is yes. This is a typical COVID patient, so a woman with a high body mass index, and at some point lung water is increased and no fluid responsive. Respiratory failure and